Se dire, ok, bon, il va être ici, il se passe quoi? Est-ce que les séquences sont similaires? Est-ce que les pics sont similaires? Est-ce qu'on a mis les caféinas, les sols? Est-ce qu'on a nommé, est-ce que la température est si c'est un pays pour les populations, c'est toujours des éléments on a regardé, et sur lesquels on ne s'est pas nécessairement penché de façon systématique. On a besoin de savoir ça, parce que ça va réduire les besoins de mobilité opérationnelle chez les populations peuvent probablement être différents de ce que c'est très évident. Donc, l'objectif de tout ce qui se passe, point de vue environnemental, point de vue température, point de vue, on va dire, entre guillemets, cyclo-planétaire, ça, on décrit ce phénomène-là, c'est de pouvoir anticiper pleinement qu'il y avait une différence. Et quand on va garantir, on fait l'exposition, le service de santé, il faut par rapport à la possibilité de problème. Our medical action is not primarily climate change, but we are trying to add an eco-friendly lifestyle. Our medical action should not be implemented in a way that jeopardizes the future of our patients. Our medical action needs to be aware the way we implemented it without jeopardizing public human function. Sickness, doing it in a way that is less harmful to the people and environment. But we also have to avoid making people sick. So we have no responsibility as a medical organization of restoring physical health, but maintaining environmental health to avoid people getting sick as well. As running hospitals, as running large medical programs, we are reviewing our way of working in those programs to be able to provide the same level of care and with the same speed and impact. We're trying to make it in a way that does not contribute to climate change. On va faire bien pour une population, on va s'adapter. Mais en tant qu'individu, est-ce qu'il est fort? Est-ce qu'il est pratique? Nous, qu'est-ce qu'il nous va à la détérioration de la planète? Si on prend en charge les populations affectées par les maladies différentes, il y a un lien avec les dégradations du climat et les dégradations de l'environnement, donc rôle du monde, c'est l'environnement, c'est l'extérieur, en plus, pour moi, c'est normal que ça fasse partie intégrante du plan stratégique, et c'est plus est-ce qu'on doit le faire, ou est-ce qu'on fera dans 10 ans? Non, on va probablement le faire dans les 10 ans, c'est déjà largement en retard.
Atal, Bihari Vajpayee Institute of Medical Sciences, and the Dr. Ram Manohar Lohia Hospital. My name is Bhargavi Rao. I am the strategic research lead for the Manson unit at Médecins Sans Frontières, and also chair of the MSF Scientific Days International. I'm actually taking the place of a colleague, Petros, who unfortunately couldn't be with us today. So please excuse if I stumble a little bit, and also if I'm having a sleeping baby on my shoulder. Today we gather at the MSF Asia Scientific Day 2024 in New Delhi, in India. But our headlines and our hearts are filled with sorrow at some of the unprecedented crises in our world today. From the horrors of Gaza to the escalating disaster in Sudan. From Venezuela to Yemen, the nature, the scope, and the scale of humanitarian crises have grown in severity and complexity over the past 2 decades since the MSF Scientific Days families were initiated. More people than ever live in fragile or conflict-affected settings, and these crises, whether related to conflict, climate, emerging threats such as HIV, TB, or COVID-19, structural violence, or increasingly a combination of all of these, have incalculable acute and long-term and long-term health and social impacts on hundreds of millions of people. Despite these burgeoning and evolving needs, the evidence base that informs how humanitarian organizations such as MSF respond to existing and progressing challenges remains quite weak. It's often focused on quite a few infectious diseases, based in a very limited number of settings, overwhelmingly disseminated in English, and populations most in need of the benefits of this research are often excluded from its rewards. Now, research plays an absolutely critical role in enabling MSF to realize our social mission. It enables the organization to improve our medical operations and our decision-making, and to build access for the populations we work with, all of which will be covered throughout today. It also equips us to advocate for those most in need and drive global policy and programmatic change based on evidence rooted in the settings in which we work. Research helps bring the complexity, suffering, and unpredictability of people living in crisis, as we've seen in some of these videos, to the center of humanitarian intervention. And if any of you are interested a little bit more in the role that research plays within MSF, I encourage you to look at online at the London Calling, which really looks at how research is embedded in humanitarian planning within MSF. Now, this year's MSF Scientific Day is co-hosted in partnership with the Atal Bihari Vajpayee Institute of Medical Sciences and the Dr. Ram Manohar Lohia Hospital. As we all know, partnerships are critical for better research, for dissemination, and importantly, for uptake of the outcomes. And the aim of this scientific day and the wider family of MSF Scientific Days hosted across our calendar is to foster a collaborative environment that brings together the humanitarian and the scientific communities, public health organizations, patient representatives, and academics to build a really inclusive platform for sharing knowledge, expertise, innovation, and experiences, all of which, again, will be showcased today. And importantly, when we talk about access, whilst we are here live in person here at the India Habitat Centre, we are also live streaming the event for our global audience, including those in association with MSF and beyond. Now, today, it really promises a very dynamic lineup of interactive sessions, so I hope you all really engage with our speakers and the abstracts that are being presented over the next few hours. We have the privilege of hearing both from early career researchers and established scientists from around the world. For our online audience, those of you out there, we've provided a guide. So we welcome you to check the posters and the innovations being presented today on our website under the same name tabs. And additionally, you can click on the CC option on your screen for English generated auto captions. Whether you're joining us in person or online, we also invite you to share our live stream and engage with us on social media by using the hashtag MSF Sci Asia. So a few house rules before we proceed. We kindly request everybody to adhere to the schedule as much as possible. I realize that's the pot calling the kettle black, given that we've started late, but please do try and keep to time as much as possible. We know most of you will need to keep your cell phones on, but please keep them on silent. And if you need to take a call, please sort of go outside into one of the other rooms to take the call, and try to sort of maintain decorum throughout the event. We will have questions for our speakers after each session, so please stay tuned. But when you ask a question, I really request that you keep it short, you keep it to the point, and importantly, you have a question mark at the end. Okay. Online participants are encouraged to send their questions via the chat box below the live streaming window on the website, and they will be read out by one of my colleagues. We also ask all attendees to review and complete the consent form at the registration desk. Okay, with that housekeeping done, I'd like to thank you all for joining us at MSF Asia Scientific Days 2024. And I'd like to welcome Dr. Farat Mantu, Executive Director of MSF South Asia. So if you could come forward and formally open the Scientific Days.
Good morning. And what a beautiful scene to start the day with. A mother, a researcher, starting the day and stepping in when we needed her the most. So thank you, Bhargavi, for that. So what do I say about today? I have a few words for all of you. I'm not going to tell you why Scientific Days, but I'm going to tell you why have we designed the day as it is today. We at MSF believe that we want to ignite change, and we see research as a tool for change. However, the day today, we do not want to talk about only data, but we want to talk about the human face behind this data. So all through the day as it is curated, it's an abstract-driven day with scientific rigor in place through an editorial committee. Still, we wanted to hear the human stories behind this. So you will see the day has a variety of topics for each and everybody. This year's Scientific Day has something which I feel is very, very important for the scientific community, and not only for the scientific community, for any one of us to have in ourselves, is the innovation mindset. So we have chosen 5 innovation posters today. They are outside, but they are also online. I would really welcome and encourage each one of you to go through them. For us, these innovations, some of them may not be new to you. You must think, okay, I've seen it somewhere. But for us, it is an acknowledgement and belief that if one person wishes to change the system, the health structure, they should not stop with the thought, they should act on it. And through these 5 poster presentations, they demonstrate that if they have experienced a barrier that has issues to access to healthcare, they have come forward and found solutions. That solution-oriented mind, that is what MSF admires and hopes that is something that we find in the ecosystem. We encourage that in the ecosystem, and we facilitate that in the ecosystem. I'm not going to talk about collaboration because my colleague Bhargavi has already spoken about it, but I would also talk about the power of adding 1 + 1. So today, when we have all people sitting across this room and online, the idea is that we build an ecosystem for future, and it does not stop today. We are in our 9th year of Scientific Day, And each year we have chosen a way of how best to engage. It's an engagement space. It's a space we hold not only for ourselves, but for each and everyone who believes in doing better for public health. So it's your space, it's my space, it's all of our space. So please use that space by engaging with researchers, scientists, young and experienced, and understand the intention behind the research. And we also do not only want to talk about the research that was successful and made it here, we also want to talk about the failures and the learning. We want to be making learning a way of research and not as something that it needs to have a positive outcome. In addition to the abstracts that you will see today, we are very fortunate to have two colleagues in the room, Dr. Yogeshwar and Dr. Shweta. And it's a very specific choice to bring them here because I believe that they would help us challenge ourselves and all of you with some very basic questions that are in front of our eye, but sometimes either they are invisible or we choose not to see them, or we believe they are not here. It is some time to go, we will not see them. So, Dr. Yogeshwar, I believe that what we would hear is that the power of indigenous knowledge and how we use that in research or not. What assumptions do we make? Dr. Shweta will talk about the legacy of advocacy as a tool of change. And can we, as health actors, across not only this room, but across the uh, online space, come together to be advocates of bringing the climate change? And I think what she would show us mirror today, and I really hope that we all are willing to see ourselves in this mirror and what we leave as a legacy for our future generations. Some of you must be knowing MSF as a medical humanitarian organization where medical action is at the heart of whatever we do. The other aspect of it is témoignage, bearing witness, but it is embedded in the reality of what we work, what we see. So this evidence based, as it is today, it is also intended to counter the vast misinformation we see that is growing by the day related to health, related to public health. So I would really urge each one of you when you tweet something, when you put it on LinkedIn, talk about how important it is to be speaking of something which is verified, scientifically embedded, and has evidence behind it. That's it from me, because I would be more happy to hear the researchers today. Again, a very warm welcome to all of you and looking forward to having engaging discussions through the day. Thank you.
Thank you so much for really setting the tone for the day. Next, we have Dr. Ajay Shukla, Director and Medical Superintendent of the Atal Bihari Vajpayee Institute of Medical Sciences and the Dr. Ram Manohar Lohia Hospital, to provide us with his opening remarks.
Thank you. A very good morning to all of you. I began my medical journey more than 40 years ago. And I always knew that medicine was a very exciting, a very challenging profession to enter into. And all along my journey, I was always thinking that what could be more challenging. So when it was about choosing a specialty, I thought orthopedics is extremely challenging. So I took orthopedics. And then I kept challenging myself. What subspecialty to take? So whether it is replacements, arthroscopies, spine. Initially, I tried to do all of them, but gradually I thought that probably joint replacements are very good. So I did complex cases, complex primaries, revisions, knee, hip, shoulder, everything. But then I realized that the challenges aren't only in orthopedics, but they're in other specialities as well. So I was a lot of, in awe of neurosurgeons, cardiothoracic surgeons. And then I thought that, well, are the challenges in the new emerging fields more like artificial intelligence, 3D printing, immunotherapy, nanotherapy, molecular diagnosis? You have so many coming up. And now, since I've been introduced to MSF, I've started thinking that there are other challenges and very serious challenges. So, on one side, yes, the challenge is to embrace newer technology, newer advances in medicine. But on the very other side, the challenges are still there and which are probably greater. And those challenges are to reach out to the poorest and those humans, those of our, I would say, brothers and sisters who are not so fortunate to live in stable and big environments where they have access to the latest and advanced medical care facilities. So I knew there was the International Red Cross, but I never really could sort of appreciate the work they were doing. But when I got associated with MSF, I mean, when I discussed and I read about it and the work they're doing, and it hit me that probably MSF has taken up the most significant challenge a doctor or medical professionals could take. So reaching out to people in the remotest and critical areas of the world, I mean, that requires, I mean, it's difficult to find the words. I mean, you have to be so much like steel yourself. I mean, if you want to go out there, and especially areas like Gaza, Ukraine, you're providing health services to places where the local governments are unable to do adequate relief for suffering for their own people, reaching out to them. You're negotiating with those governments to let your workers, your doctors, be able to provide care and suffering to all of those people. And then when I think about it, people in those areas with bullets whizzing by and missiles dropping all around, and you don't know when one hits you, and you're still standing there, you're still delivering. I mean, I don't know what to say. I think probably it took me more than 40 years to realize that probably this is the most challenging thing a medical professional can do. So you're doing great service. And that's why I feel extremely honored that you chose our institution to collaborate for this year's annual scientific program. You, I've been told, are a 53 years old institution. My institution is also old. It's 92 years old. We not only provide medical care, but we do it in a very stable environment. We are also a teaching institution. I know that you're also very fond of teaching. You also have a 9-month training course. You also engage in research like we do. And you're also interested in innovations. So there's a lot of things in common. Yes, of course, doctors from our institution, we do at times go to crisis affected areas, like areas which have been hit by earthquakes or flooding, etc. But that's a very small, on a very small scale. You've got a massive global presence. I've been told more than 69,000 people in almost 140 countries. So that's huge. And you've got a big, I would say, population that backs and trusts you and funds you, unlike many organizations which are dependent upon funding for big corporates and governments. But your donors are from the middle class and widely spread, and there are lots. And there's so many that many a times the amount of money they give is not, you're not able to spend it in that year. But you're doing great, and it's nice to be here standing in front of you on this scientific day. And I'm sure that a lot of data that you've accumulated from the various researches, trials, etc., whatever you've been doing across the world and also in our country, in especially on resistant organisms, resistant TB, antibiotic resistance, on Kala Azar in India. So all of that data and all of those learnings would be shared here today. And I'm sure many people from across the globe, and of course from our institution and our country would benefit from today's proceedings. So my very best wishes, and thank you for collaborating with us. Thank you for calling me. So have a great day. Thank you.
Thank you so much, Dr. Shukla, for your insights and encouragement and sort of wisdom on this for today and for our collaboration going forward. We now welcome the signatories to come up on stage for the lamp lighting ceremony. And with this, we will also open the innovation exhibition. So please do come to the stage.
Yeah, I just wanted to do one small minor kind of correction. Uh, we have colleagues from 140 nationalities, and we work in 88 countries, just to put it on record.
Okay, thank you very much. Before we get to the exciting part of the day, I just wanted to let everyone know that we have a visual artist here in the corner who's making caricatures of the various speakers, panelists, people attending. So please do come and have a look at his incredible work. Thank you. Okay, so after all the ceremonial sort of formalities, I'm really excited to welcome our keynote speaker today, Dr. Yogeshwar Kalkunde, who is the public health doctor. He's a researcher, a neurologist, and an advocate. He's worked with SEARCH, the Society for Education, Action, and Research in Gadrucholi, with the incredible Doctors Abhay and Rani Bang, personal heroes of mine and I hope of many of you. And he's worked there for many years, focused on healthcare delivery solutions for rural and tribal populations in India, and is now a member executive committee member of Sangwari, which is based in Chhattisgarh in India as well. A place that we know well in MSF, where we have several operations, so really relevant to our scientific day today. Dr. Kulkunde believes that data poverty leads to health issues of the marginalized populations remaining understudied, which further compounds resource poverty, which is something, of course, very dear to the hearts of those of us at MSF. He is keenly interested in strengthening healthcare delivery in rural and Adivasi areas through documentation, through public health research for developing grassroots level healthcare solutions, health system strengthening, and mobilizing young health professionals to take up these challenges. It's really my privilege and honor to welcome him here today, Dr. Kulkarni.
Good morning, everyone. MSF members from various parts of the world, distinguished attendees, and our special attendee, the youngest attendee that I see in Bhargavi's lab, who's demanding that we do better for a better future for her. It's a real honor to be here. I and a lot of us in medical community look up to MSF for how the humanitarian work has to be done. And it's a special privilege here. And Farhad challenged me that I should challenge MSF to do better. Now you can understand how challenging that task is, to challenge an organization that works in the most challenging situations. So I thought I would talk about slow emergencies. So when we talk about MSF, our larger impression is they work in fast evolving emergencies. And I thought I would speak about slow emergencies. And these slow emergencies typically affect the most marginalized people. And what is slow about it is the slowness of the response of the communities. So these emergencies are emergencies for the people who are affected, but the community, the systems, the health systems, the governments often respond to it in a very slow way. So that is one. And the second part I wanted to highlight is the role of data poverty. And data poverty is oftentimes, having worked in under-resourced settings, I realized that data poverty sometimes can be worse than physical poverty because there are no problems that are identified and then there are no solutions that immediately develop. So with that background, I'm going to share 3 stories with you. I'm a small health practitioner, public health researcher who works in this rural and tribal regions of central India. So as practitioners or fellow practitioner, I'll share 3 stories with you. So story 1 is about breaking a stereotype. And I'll start with my personal story. So about 13 years ago, I moved from working at Texas Medical Center in Houston to work in Gadchiroli. And this is just a symbol because most of us in this room are coming from privileged communities, and we often get dropped into these challenging situations. So I was here, one of the largest medical centers in the world, where you have all the facilities, almost all the facilities that you need for healthcare, to this scenario. So suddenly you are coming to a very remote and rural area, which is quite underserved. And when we work in public health is all about context. So what is the context? So Gadchiroli is one of the most underdeveloped districts of India. It has population at about 1 million. About 40% of the population is indigenous or tribal or Adivasi. 75% land is covered by forest. And rural population is 90%. And physician to population ratio, this is in 2011, was 1:5,000 as against 1:1,300 for rest of India. So this gives you a glimpse as to how under-resourced this community is. And as a practitioner, I was a clinician then, as a neurologist, I'm coming in. And the big problem is, understanding what could be health priorities of this rural tribal community in Gadchiroli. So the transition here is from a clinician to a public health researcher. As a clinician, we are thinking as to what is the problem in this patient. And now as a public health researcher, you have to take a step back and ask the question, what are the public health or what are the health challenges of this community? And how do you answer that? And often you go to the under-resourced setting and you don't have solutions. You don't have data. So if I would show you this picture of a village or hamlet in Gadchiroli and ask you, what do you think would be health priorities of this community? Oftentimes what we have is visual data. We make impressions based on these visual data. And most of you would probably answer that pneumonia, diarrhea, tuberculosis should be the health priorities here. But then the question is, how do I find it out? And so, one of the ways we do that in public health is through research on causes of death. It is one of the ways we identify health priorities of the solution. So what we did is, in a population of about 100,000, we looked at all deaths and tried to classify cause of death in these populations. In most remote and rural underserved settings in India, the deaths do not occur in hospital, they occur at home. So as a health system, if you go to health system may not have data on what people are dying of. So what do you do? So what we did is we used a method of verbal autopsy, and I'm sure many of you are aware of it. And for those who are not aware, it is just a narrative tool where a death has happened, a trained worker goes and collects the circumstances in which the death has occurred. And then a trained doctor looks at it and assigns cause of death. It's not a perfect system, but it gives you a glimpse. So we try to do that to understand what is happening with this community. And it is relatively easy tool to take a snapshot of the community and understand what's happening. And this is what we found. So after looking at close to 1,600 deaths over 200,000 person years of observation, we found that contrary to our stereotype that TB, diarrhea, and malaria should be the leading causes of death here, what we find is stroke is the leading cause of death. Right? I never imagined, I'm a neurologist, and I never imagined that I would have to work on stroke. I came here just to, with the open mind, asking the question as to whatever the health priorities of the community, I would try and work on it. So, and again, tuberculosis is there, cancer is there, is an important cause of death. Diarrheal diseases have not gone away, they're still there. Malaria is there. And so it's a mixed picture. And when we pull this together into lumps of non-communicable diseases, infectious diseases, external causes and injuries, and unclear cause. The unclear cause is because the narration is not giving you enough evidence as to what the potential cause of death could be. So what you see is a community is transiting. We have made a stereotype that this is a rural community, they need to die from infectious diseases. And what we find here is non-communicable diseases are already the leading causes of death. But the infectious diseases have not gone away. And injuries, which account for suicides and motor vehicle accident and other traumatic deaths, are also there. So based on, we started with stereotypes, but the data, the research actually showed us what's really happening with the communities and how the communities' priorities are changing. So what the learning from this experience has been that, we often make stereotypes about communities, and it's the research here, the epidemiological research actually helped break that stereotype. And now we understand that rural and underserved regions in India are actually facing double burden of diseases. So the infections have not gone away completely. The non-communicable diseases have emerged, and health systems are not yet ready to tackle the challenge of non-communicable diseases. So that is the first lesson that I learned. And eventually this work led to developing a community-based solution for reducing stroke deaths in this community. I'll come to second story, and this story happens in the state of Chhattisgarh. And the story's title is, Why Are So Many Pando People Dying? So when we moved, this was year 2021, the COVID was gradually disappearing. And the newspaper in the town of Ambikapur, where I work, were full of these stories. And this is a story from a family. A 9-year-old boy got sick with fevers and died in 3 days. And the father and his older brother was there in the cremation, and father felt uneasy. So the town was very scared. So the village were very scared, and they said that we'll send you to the medical college, which is the divisional headquarters. And the father and the older son go to this medical college. They get admitted. In 3 days, the older son dies, and in another day, the father dies. In a span of 4 days, half of the family is wiped out, all males. And the cause remained unclear. There was outcry in the newspaper. And then there were many newspaper stories as to a lot of Pando people are dying, and nobody knows what this is happening. So every other day, there is a newspaper headline that these Pando community members are dying, and government is not doing anything. So what government did is they reached to us as a not-profit organization. They asked us to do an impartial inquiry into these causes of death. So our job was to evaluate medical causes of death and identify any modifiable causes, understand the perception of health practitioners and the community regarding potential causes of death, and document the health system's response and recommend action steps for improvement. And so the question is, who are these Pando people? So first thing, we are new in that area working. We need to understand who are these Pando people. And we realized that we go to Google, there is no wiki page on this community. We found very few other links which talk about this community. We go to PubMed to see if there are any studies done on these people. We came across only one study done in 1980s. So essentially, these are invisible people, and their problems are largely invisible. There was no information on their population in India, and the population is thought to be about 40,000 in the entire country. And another particular challenge was in the neighboring state of Jharkhand, they were classified as tribal, indigenous, and Adivasi community, but not in the state of Chhattisgarh. So in India, there is this funny thing where communities are classified as tribal or indigenous based on different states. So you could be a tribal in one state, and you could be something called as open in other state. So this was really a challenge. So we realized that often these tribal communities, don't get attention, don't get researchers are not ready to go there and work in that area, and so these people become invisible. And this is what I talk about health data poverty or data poverty. So a lot of these deaths. So if you look at the map of India, the state of Chhattisgarh is shown, and then I have highlighted and enlarged the map of Chhattisgarh. And we work in this northern pocket of Chhattisgarh, where more than 50% population is tribal or indigenous. And most of these deaths were occurring in the Balrampur district, which is on the north tip. And these patients were referred to Sarguja district, where the medical college was. And so now our challenge was to how do we investigate this thing in terms of death? So we decided to do twofold investigation. We wanted to do a biomedical investigation, and we wanted to do a social inquiry. Gathering data becomes a real challenge because you don't know where to start with. It's a large geographic area. So we made hospital visits. We talked to staff to get insight as to what these patients might have died of. We tried to get whatever data that was available with the hospitals. We had patient interactions. We talked to admitted patients and families of the disease. Then we did community interactions. We talked to community leaders and community members. And this is a visit to the family where 3 people died. And, you can see me sitting there and doing verbal autopsy of sorts. And so we tried to use 3 data sources. So we talked to the district administration in the Balrampur districts and asked them whether you have some data as to what could be the cause of death in these people who have died in the district. We tried to gather data from patients who had died in the medical college. And then we had some suspected patients from that community who are coming and who are recently admitted at the health facility, and we tried to get some laboratory data on them. So what did it reveal? So we got data on 47 deaths from Pando community, which was provided by the health department. And then based on narrative circumstances of death, so similar to verbal autopsy, which was done by the ASHAs, the ANMs, the nurses, and the community health officers. So we learned that 27 out of 47, that is 56% of the deaths were in the age group of 6 to 60 years. So very young, most of the deaths were in a very young age. And fever of unknown cause resulted in 23% of such deaths. So we started to see a thread that maybe fever, we need to first go after the fever because, maybe there's an infection that we can diagnose and treat. Then we looked at files of 11 patients who died at the medical college. And out of the 11, 8 died due to fevers with multi-system or multi-organ involvement. So once you get, we got one more clue that people are dying of fever plus multi-system involvement. Then the differential diagnosis that we consider is whether this is malaria, whether this is scrub typhus, whether this is COVID-19, whether this is dengue or sepsis and other viral fevers. So we started to narrow down, at least from the medical part, as to what could be causing the deaths. So one clue that we had is we went to these patients with fever who were admitted at that time when we started investigating, and we collected 9 samples, 4 from Ambikapur district, which is where the medical college is, and 5 from the Balrampur district. And we sent it to the Indian Council of Medical Research Laboratory situated in Jabalpur. And 4 out of these 9 tested positive for scrub typhus. So that gave us an indirect clue that people are dying from scrub typhus because it was not easily diagnosed. There were no tests for diagnosis of scrub typhus in the entire division with a population of 5 million. And doctors, in response to fevers, were giving them higher antibiotics, mainly cephalosporins, and they were not using azithromycin or doxycycline, which work wonders for patients with scrub typhus. So this, at least the biomedical investigation gave us some lead as to, what these patients could be dying because of. And then we looked at perception of healthcare providers as to, we asked them, why do you think these people are dying? And they said that these people drink water from ponds and eat stale food. So obviously they are going to have illnesses. So very, typical caricaturization of a marginalized community. And then there were some who said that the issue of excess death is not at all real. Pando people are dying due to causes which are not very different from those of other rural people. And in fact, they questioned that whether these people are tribal at all. And they are not at all tribal, and it is a political ploy to get themselves the Adivasi status, which will get them benefits of affirmative action. So oftentimes, the other communities were labeling this as a political ploy. And people in the health system were agreeing with it. And then we looked at social causes of death. So we asked Pando people, we community members, why do you think so many people are dying? And so we had gatherings with community members, and we asked them, and their answers were completely different. So they said that the first cause of death, excess death, was caste certificates. We are not identified as tribal or indigenous, and this is our major problem. And as we do not have a caste certificate, we are marginalized because they are not considered marginalized. If you have tribal certificates, there are affirmative actions that come in place. There are actions against severe actions against atrocities. There are atrocities committed against these people, but they couldn't do anything because they are not considered tribal. So the people who have committed atrocities will get very simple punishment. But if you have a tribal certificate, then you can't get away that easily. Then the second thing that these so-called illiterate people told us is that lack of education and employment. People are not educated. As they do not have tribal caste certificate, they have to pay all the fees to get higher education. So then they don't get benefits of the government system at all. And only a handful members of the Pantu community have government jobs. So we all, crave for, especially middle class in India, craves for government jobs. And we realize that why these marginalized communities crave for government jobs is because it gives them social protection. And so that was they were not getting. And so the senior members in the community were frustrated that since education is not giving us job, what's the point of education? So we should go back to farming and keep on doing farming. Drinking water and food rations. So, they had issues with drinking water. They don't have hand pumps or taps. And hand pumps which were given to them by the government were taken by other community members in other hamlets. So, and they didn't have a voice to go against it. Food rations, there were some community families that had large families, so the food ration that they get from the government was not enough for them. So essentially it's wonderful that you call these, we talk about social determinants of health, and who's teaching me these social determinants of health are these community members. That's saying that biomedical thing is fine, but work on these social determinants of health. So what we did is based on the communication that we had with the community and doctors, we tried to do structural analysis of these deaths. So by structure, I mean social structure, which can be defined as a way a society is organized in hierarchies through institutions, policies, economic systems, cultural or normative belief systems, such as caste, tribe, socioeconomic status, and gender. And we said, can we pool all these problems and can we have a framework in which we can look at these things? And these are very busy slide. This is a slide, and we try to identify 10 factors. So for example, the structure could be the political structure. And what was the structural determinants is because Pando communities, population size is small. So, and they are distributed in multiple electoral districts. So they don't have any political power to ask for anything. So the structural vulnerability was poor political representation of these people. What was the structural violence? The denial of political voice compared to other larger Adivasi communities. So even among tribal communities, their population was small. And there is this violence occurring because nobody is listening to them. And then we proposed actions as well. So there is a need for by political members or political leaders to reach out to these marginalized communities, and also on the part of these marginalized communities to reach out to the political system. Administrative, we realized that the health system was administrative healthcare structure can't respond adequately to the health challenges of this community because they don't have data. And so the structural vulnerability becomes inability to define, measure, and respond to disease outbreak by the health administration, so on and so forth. So we identified, legal issues, the economic issues, social and cultural issues, and material issues, technical issues, biological issues, and environmental issues. So this most marginalized community, these are forest dwelling community, and they were in close contact with mites habitat. We looked at scrub typhus as an emerging infection in this community, and it's a mite that transmits this infection. So they had no rights onto the forest that they live in, while because other tribal communities are gradually getting forest rights so that they can harness the economic resources in the forest, while Pando community, as it was not considered tribal, was not getting it. And scrub typhus was not a priority of the public health system because public health system didn't think that it is an important issue. It's an emerging infection in the central India, and it's one of the important causes of pyrexia of unknown origin or fever of unknown origin. So similarly, we tried to see a large picture, and we realized that there are multiple points where one could intervene. And some of the points we could intervene. So we told the medical college that you need to have this test for scrub typhus, and possibly there could also be leptospira. And those with our intervention, the test for scrub typhus became available in the medical college in September, and now the medical college is diagnosing a lot of cases with scrub typhus. As far as getting the tribal status was an important and long war, which was fought by the tribal community leader. And there was a young community leader named Umesh Pando who actually fought very hard. And finally, in 2023, they ended up getting tribal status. So that was a win of a community who fought for their own rights. So essentially, from this second story, the learning is, solution to health problems are often, especially in marginalized communities, could be way outside the health system. So there is importance for social and biomedical research to go hand in hand to solve this problem. And especially in marginalized communities, the structural determinants can play a very important role, which is beyond the health system, and we need to work on that. And this community also, in addition to suffering from non-communicable diseases, the emerging infections are also affecting these communities. So that was the second learning that I had. So coming to the third story, again, this happens in Chhattisgarh. And the story is, why do my children have so much pain and need for frequent blood transfusions? We are all born of blood and pain of our mothers. But what if the children who are born also have to suffer the pain lifelong and often need blood? So sickle cell disease is that disease where, it's a genetic disease which affects your hemoglobin production. It's quite common in Chhattisgarh. And this is a patient that I'm examining. He and his brother both have sickle cell anemia. Every month, the family is in the hospital to give blood for either him, his name is Jitendra, or David, his other elder brother. And the family has to sell off all their land, and they are barely surviving because they had to take care of these two children who are suffering from sickle cell anemia. So sickle cell disease, as I said, is a genetic disorder. It's very common in Chhattisgarh. So 1 in 10 people carry sickle cell gene in the state of Chhattisgarh. So every 10th person is a sickle cell disease carrier. Sickle cell anemia affects 1 to 3 people per 1,000 population. So every district on an average has 800 to 900 patients with this condition. These patients suffer from frequent episodes of pain because their red blood cells are sickle shaped, and these sickle cell red blood cells clog in the blood vessels, causing ischemia or reduced blood supply to body organs, which produces severe pain. And often they develop crises which are completely unpredictable, and suddenly their hemoglobin level drops. And if they don't reach in time in the hospital, they die. The challenges we realized was there was lack of clarity regarding screening and diagnosis. There is a two-step process for diagnosing this condition. You have a screening test and a diagnosis test. Physicians were not comfortable prescribing hydroxyurea. There's a medicine all over the world which is used to reduce these episodes by 50%. So hydroxyurea was not prescribed because the primary care doctors thought that this is a cancer drug, so I can't prescribe it, which led to reliance on blood. So all these pain crises were treated with blood, which reduces pain, but it's not the appropriate use of blood. So they were treated like thalassemia. There was no regular follow-up. There was discontinuous documentation. There was no pneumococcal vaccination, which prevents infections in these patients and crises. And there was no penicillin prophylaxis, which again reduces crisis. So we knew certain things work in sickle cell anemia, but they were not working in the health system in Chhattisgarh. So what this led to was, it typically affects the poor communities in Chhattisgarh. So tribal and indigenous communities and other backward castes are affected. There is suffering, which is preventable. Children often end up losing schools, and adults have loss of wages. They can't work hard because any physical activity leads to crisis. And family suffers due to frequent admissions and leads to poverty. These children have something called as avascular necrosis of femur. Their femur bone degenerates. So in the age of 10 or 20, they need hip replacement surgery. And there's also frequent deaths. So we asked the question as an NGO, can we streamline and improve care of patients with sickle cell disease in a public health system? And so we started working with the government because we believe that government is the largest social organization in the country, and we need to strengthen government's efforts. And so these two districts have a population of about 1.5 million, close to 50% population is tribal. And secondary level care seeking is mainly from the public health sector. So what we did is we came out with 7-fold interventions. So we said that we'll deploy a team of care coordinators, and the care coordinators work as a liaison between the government health system and communities. Then we created a simple telephone helpline number where people can ask questions related to sickle cell anemia, and we deployed peer counselors. So we selected some patients with sickle cell anemia to be peer counselors. These care coordinators work with the government health system to make sure the supply chain is maintained well. We create a simple training material, which I call last mile training solutions for doctors, general duty medical practitioners to prescribe this medicine called hydroxyurea. Then we create a simple patient awareness material, which is often not available for tribal and marginalized communities. We created treatment linkages within the public health system, and we started building community of practitioners and patients. So this is our team of care coordinators, which acts as a secretariat within a busy public health hospital, where patients with sickle cell anemia and some other conditions that we are working on can go. They keep a track of patients, and they create a registry of patients at these district hospitals. And once you have a registry, you can actively track. So usually in India, the care is patient-initiated care, and we tried and we made an effort to convert it into a system-initiated care, where system is actively tracking patients with sickle cell anemia. Because if you actively track and you advise patients well, the hospitalization can potentially come down. And here is a team of care coordinators visiting the patient when they are sick, because in the public health system, nobody will kindly talk to her. And there is this, our team who, goes and inquires and helps them around in the public health system. And as I said, we created a registry for active follow-up. And oftentimes patients, if they don't follow up after phone calls, our team makes a home visit. And population in Chhattisgarh is quite scattered. So you have to, oftentimes walk 5-6 kilometers from a motorable road to actually reach. And oftentimes we realize it's a genetic disease, so we have to screen everyone in the family. And it's quite expensive for the family to travel to a district headquarters and get their blood tested. So our team actually goes to patients' homes and get their blood tested. And you can see our care coordinator has to walk through a river to actually reach the households. We realized that simple training doesn't work. So these doctors have been getting training on prescribing hydroxyurea for 10 years before we started our work. But there is handholding that is needed. So someone needs to, pat on the back of the doctor saying that, okay, you can do it, and I'll tell you how to do it. So some of us doctors actually went and sat with these government doctors for 6 months period. And we created these simple tools. So, we realized that the doctors were not comfortable calculating milligram per kilo dose because they are very busy seeing hundreds of patients in the clinic. So what if we create this simple tool where they just have to look at this table and prescribe hydroxyurea? We created a simple 3-page guide for them to prescribe hydroxyurea. So we told them that if you don't have time, just read these 3 pages. For patients, we created simple patient continuity of care booklets. And again, this is very simple interventions where patient can come in and bring that book every time they come, which is not the practice right now at the district hospitals, so that doctors know what's happening to these patients. And we realize that for chronic diseases, oftentimes the health system takes what I call one-hand approach, meaning that, you have to try to solve a problem with both hands, but you just use one hand, and that is doctors and systems. So we completely ignore the second hand, which is the patients. For chronic diseases, we really need to empower the patients, and they can really help to improve care of these chronic diseases. So we started conducting patient peer support groups in these district hospitals to build their capacity. We celebrate, sickle cell day was celebrated, but patients were never invited because the government system did not have a list of patients. So we started inviting patients to these sickle cell day functions, and the doctors were quite surprised to see so many patients coming on the sickle cell day function. Then we realized that patients are not represented in various discourse on sickle cell anemia. So you have sickle cell anemia conference, and mostly would be researchers and doctors, and there is hardly any representation of patients. So we wanted to change that power dynamics, and we said that can we have patients conference? So we started sickle cell anemia patients People's Health Conclave, where we invited patients and we invited doctors as come and speak to these patients, and where the dais was given to patients, and for the first time they actually got a dais to speak. And here the health minister of the state attended virtually. And these are patients who are lined up in the lower picture. You can see they're lined up to convey what they are suffering from. Then we realized that we had to bring patients and doctors together. Often they are on the two sides of the fence and fighting with each other. So we felicitated doctors for their good work, and which just an effort to create bondage between patients and doctors. And this was, this initiative was highly appreciated, and we again had it earlier this month. Where we had a lot of panel discussions where patients also participated in the rural area and spoke about the challenges that they face, and mainly the challenges were in the social determinants of health. So what's the effect of this intervention? So over last 2 years, we have enrolled close to 1,200 patients of sickle cell anemia in 2 district hospitals. When we initially went and asked how many patients with sickle cell anemia you said that you have, the doctor said that it's about 100 per district, and now we have 1,200 in 2 districts. When we work, we look at gender equity. We make sure the women patients are coming and taking care. And very nice to see here that almost 50% of our patients are male and 50% are female. We look at age equity. Sickle cell disease is a genetic disease, so we want to push early diagnosis. And you can see that in District Hospital Surajpur, we have been able to push it early diagnosis, and Ambikapur, we are still working on to improve early diagnosis. Then we sat with these doctors for first 6 months, and then we stopped going. And so the question was, are these doctors really prescribing hydroxyurea on a regular basis? So the way we tracked is we just looked at the the stores of these district hospitals, and we we asked for the number of hydroxyurea dispensed. And you can see that in district hospital Suratpur, which was the medical college hospital, when we started work, the monthly hydroxyurea capsules dispensed were 1,800, and on an average for the last 6 months, it is now 18,000. So tenfold increase in prescription of hydroxyurea. In another district hospital, which is a smaller one, when we started, they were dispensing 150 capsules a month, and now they are prescribing 6,000 capsules a month. And when the hydroxyurea use goes up, we looked at what is happening to the blood transfusion. So these are percentage of enrolled patients who are needing blood transfusion. And in a span of 2 years, you can see it's gradually coming down. And similarly, with hospitalizations, you can see that the percentage of patients needing hospitalizations have come down from 15 to 25% to now around 5%. So with these simple interventions, we could, we could bring about such a change. And so to end, on the third aspect of research is we realize that solutions to the health problems, you also need to find within health system, which oftentimes doesn't have technical capacity to deliver. So this this highlights the importance of health systems research that you need to do along with epidemiological or social and biomedical research. And the key thing is importance of improving access to care for the marginalized communities and engaging them as partners in problem solving. Often they are seen as a passive recipient of whatever care that the health system gives them. So this is the last slide. So we are moving on to our last challenge, which is next challenge, which is tackling type 1 diabetes. So again, this is a neglected sort of disease, chronic disease, which is present in rural and tribal communities. And if it is there, this is one of the hardest challenge that I have known to tackle in the public health system. On the top picture, you see this young girl, probably weighing less than 20 kilos. She's about 15 to 16 years of age. And she was not getting insulin. She was not aware where to get insulin. And while insulin was available in the public health system. So here our care coordinator, we actually work closely with these patients to increase improve home glucose monitoring. We provided them with kits to improve, to do home glucose monitoring. We taught them. And we are working with the government system so that these patients get insulin. And there are multiple challenges starting from there being no refrigerator. So this is our team member telling how to store insulin if there is no refrigerator. And you can see a challenge. This is a young girl with type 1 diabetes and diabetes ketoacidosis being transported by her father, carrying her on lap to the nearest road from where she will be taken. So with that, I would like to thank, and this is the work done by a group, and is a large group. So I want to thank everyone who has sort of participated in this work. Thank you.
Thank you so much. Thank you so much, Dr. Kalkunde, for a really inspiring talk and so much for us to learn at MSF. And what I think is really special is you will hear echoes of these topics throughout the course of today and the seminar sessions that we've organized. So relevant, so challenging, and so inspiring. So thank you. And it leads rather well onto our next session, which is about driving health reform, community-led action, evidence, and advocacy for equitable health outcomes. Now, it's become ubiquitous, almost glib, to talk about the importance of community healthcare workers, community engagement in global health. I often find community is like wafted around like a silver bullet, from COVID and malaria treatment to sex and gender-based violence and leadership. We have community healthcare workers, ASHA workers, whatever they're called in wherever you come from. They're often the very front line of health response, juggling their multiple roles and needs. But whilst there's lots of interest and a lot of rhetoric around community-led responses, and especially the word co-creation with people affected by crises. For those of you who know the humanitarian space, local leadership and community participation are actually integral to the grand bargain pledges. But often there's very little clarity on what this actually entails and how it can be operationalized. And there's a great background paper from ALNAP, which is the Active Learning Network for Accountability and Performance, on engagement of crisis-affected people in humanitarian action. And it suggests that actually there's a lot of engagement in the diagnosis or the information gathering phase of a crisis, but much less engagement at the stages of prioritization, design, and planning, unlike Dr. Kolkonde's great presentation. And a grassroots activist in Ecuador told the people writing this paper, this is how the verb to participate is conjugated. I participate, you participate, they decide. And I think it's also really important to consider a risk with community participatory approaches is that sometimes they can unintentionally strengthen the strong rather than those with less voice, and amplify the roles of brokers, translators, and gatekeepers, with the risk of further marginalizing some groups, and especially women. So I'm really pleased that we have this session on our agenda today. We're going to hear from several experts in this field. Every presenter will have 10 minutes, and we urge all the presenters to be mindful of the scheduled time. So with that, I call for the chair for this session, Dr. Sutapa Nyogi, who is Director and Professor of the International Institute of Health Management Research here in Delhi. I hand over to her now. Thank you so much.
A very good morning to all of you. I think I'm audible. Yeah, now it is. So thank you organizers for involving me in this very important panel. We just heard about science to serve better, and now is the time that we talk about the service. And as has been emphasized, that whenever we talk of diseases, we need to move beyond the biomedical concept, and that is where the importance of social determinants of health lies. We also heard from the previous session that the solution to health problems lies within the health system. And here I would like to emphasize that community is very much a part of the health systems. It does occupy a central position in effective health systems and healthcare delivery. And what is community? It is nothing but any configuration of individuals, families, and groups whose values, characteristics, customs, rituals, interests, geography, or relationship unite them in a particular way. And hence, a community based solution is an action, it's a policy or a program or a law which is driven by the community members and has a huge potential to promote health equity. And hence, this session, which is driving health reforms, community led action, evidence, and advocacy for equitable health outcomes. We are a very eminent panel with 5 speakers, and I would want to invite all of them to the dais. Ms. Anisha Singh, who is the project director, ACSM NTSU, the Union, New Delhi. I hope, yeah. Then we have Dr. Mrinalini Das, the monitoring and evaluation specialist of FIND, New Delhi. Ms. Lindsay Barnes, health director, Jan Chetna Manch, Bokaro, Jharkhand, India. Ms. Leboang Kabola, Regional Community Engagement Coordinator, MSF Johannesburg, South Africa. And Dr. Haifa Muhammad Ali, Program Manager, REACT, Asia Pacific, India. So we would begin the session with one important aspect where we find that community-based intervention does have a huge impact, which is tuberculosis. Community-based tuberculosis activities cover a wide range of activities contributing to prevention, to diagnosis, to improve treatment adherence and care that positively influence the outcomes of tuberculosis, including drug-susceptible or drug-resistant tuberculosis. The activities also include community mobilization to promote effective communication and participation to generate demand for TB services, be it preventive or curative. So we'll hear from Ms. Anisha Singh about the TB story, which is technology-led crowdsourcing and dissemination of personal TB stories of hope, courage, and success to destigmatize TB conversation. Over to you, Anisha. Yeah. Um, I would request you to stick to 10 minutes, and then we can have question and answer session after all the speakers have made their presentation. Do you have a pointer or something?
Yeah, okay, while that's happening. So good morning. And I think Dr. Golconde, you started by talking about stories. So I think I rest my case. I had come here to make a compelling case on how storytelling is really, really important. And Dr. Golconde talked about 3 stories. And these are all stories of hope. So I think that the context has been very well set already with you by the keynote speaker. So thank you for that. I have just a couple of disclosures to make. I usually do extempore, but since we are so particular about time, and we've been told twice already today, I have a script, but this is original script. I have written it, so and just to make sure that passion doesn't overtake time. So that's one disclosure, and the second, I hope technology sides with me today, because there is some stuff which is not just simple presentation, that it would require tech support. So fingers crossed, and I hope that works well. So do we wait for the clicker, or maybe I can just start, right? So thank you for this opportunity to share with the scientific stroke medical audience that we have here how science has to be and should be complemented by heart, right, to make a real difference. And I think when I say that, that really will resonate and will talk to the humanitarian audience that we have here today. So let me start with one alarming sort of statistic, right? In the most recent prevalence survey that was conducted by the National TB Elimination Program, it was found that 64% of the people who showed symptoms of TB have actually not done anything about it. They've not got tested, they've not got treated, they've not even gone and shown themselves to probably a doctor. And that's alarming now, right? Because if every one person can infect 5 to 10 more people over a span of say 1.5 years, and if we don't find those missing millions, then we are really facing a disaster. And the government program has done wonders in that in that aspect. We've reduced the missing millions from about, I think we are now left to about 23 odd lakhs from about a million. But the point that I'm trying to highlight here is that the community really, since we're talking about community, needs to really know that they need to really get up and go and get tested and treated, right? So that, and if they don't do that, that's like serious trouble. I'm happy to just do this if the clicker is not working. Okay. Okay. Uh, Okay, now many reasons have been attributed to that, right? Why are people actually not going and getting tested for TB? Lack of awareness, there is stigma, discrimination against TB, and the like, right? And as we've established by the earlier speakers, that health problems, and especially TB, is not just a medical problem; it is a socio-psychological problem, right? So on this slide, you will see some quotes from people which are really talking to the fact that it is talking to the stigma, TB being a stigma narrative, right? Now, armed with this knowledge about TB being a stigma and the our whole TB community actually believed that, people are hesitant to talk about them having TB or having had TB. And maybe rightly so, there are many people who are probably not forthcoming. However, when we reluctantly and reticently somewhat tried talking to people about TB, we figured that while, yes, there are some people who are skeptical, but there are also many, many who are quite open to sharing their TB experience, right? So the thought bubble that we had, are we getting blinded by a preconceived notion and ignoring an opportunity that is presenting itself? And especially after COVID, when COVID was it was a stigma, and then that changed and people started talking. So we said, maybe things have changed and masking is no longer a stigma or a discrimination. So are we ignoring a huge opportunity that is presenting itself? Additionally, just to highlight, health communication has been evolving over the years. There are new platforms like digital that are giving birth to many community content creators and taking their stories far and wide. So, what if we could create a digital platform that hosts and posts millions of community TB stories? The potential of it becoming a watershed movement towards normalizing TB conversation gave us goosebumps, and it continues to give me goosebumps even today as I'm talking, right? Thus was born Meri TB Ki Kahani, which is as has been described. That's a title. I'm not going to sort of go through this again. Just want you to take a look at this. The audio is missing. That's why I had hoped that technology plays sides with me. Can I just play this once again, just so that it'll give you a little bit of context? So audio, please. Yeah. Right. So so that was just a glimpse of what that platform looks like. And of course, since we have 10 minutes, I can't go through in detail. Now, with this platform in place, we had to get people to start to contribute their stories, right? We engaged in a sort of a disruptive communication campaign. Now, if you look at this, this is not a typical, maybe a TB communication, asset that you will see, or maybe even a health communication asset that you will see. But we are very conscious that the audience that we are talking to not only receives health information, but receives a host of information from all kinds, right? From corporates, from, viral content creators. So we had to do something which was disruptive in terms of its look and feel. Now, once someone was interested and went onto the platform, they were served a tutorial on how to record their story and submit. All a person needs, sorry. So all a person needs is one mobile phone, an internet connection, and a TB story to tell, right? And one thing that I would like to highlight here is that it can be a story from anyone. So we were talking about what is the definition of community, right? So for us, the community here were not just persons affected with TB, but it could be a practitioner, it could be a friend, it could be a family member, it could be administrative staff, it could be frontline health workers, and of course the person themselves, right, who's had this TB experience. So once they submit their story, automatically through tech, which is inbuilt into the platform, an intro and an outro, it's slapped. So imagine you have a phone. Typically, I would do an exercise where I would ask everybody to record a story, but again, in the interest of time, can't do that. So you record the story, upload it on the site, and there is an already, without human intervention, there's tech which slaps an intro part and an outro part and then sends it back to you to be able to further share. So and of course it's vetted for content which could be factually incorrect. And I just wanted to see if I can show you. This is the final. Okay, volume please. If this is the final product.
और मैं पंचायत कुथोल पंतेड़ गांव से हूँ और मेरे को गले में तकलीफ थी तो मैं डॉक्टर के पास गई उन्होंने बताया कि आप चेकअप करवाएं तो मैंने चेकअप करवाया और फिर उन्होंने बताया कि मुझे टीबी की प्रॉब्लम है इसलिए उन्होंने मुझे 6 महीने दवाई खाने को लगातार बोला और हमारी जो आशा वर्कर है उन्होंने दवाई डेली मुझे खिलवाई अगर आपको भी कोई ऐसी प्रॉब्लम आए तो आप भी चिकित्सालय में जाकर अपनी प्रॉब्लम बताएं और कोई जैसे कि डॉक्टर बताते हैं कि आपको कैसी जैसे दवाई खानी चाहिए वैसे ही आपको लगातार दवाई खाएं और फल फ्रूट सेब वगैरह वो आप खा लें और इसी के साथ धन्यवाद।
अपनी टीबी की कहानी को www.meritbkihani.org पर आज ही शेयर करें। मेरी टीबी की कहानी।
This is then uploaded on the platform with the functionality to share. It is shared back with the person who has submitted it for them to share further with their contacts through WhatsApp, through SMSs, through social media, etc. So it doesn't really remain confined to conferences like this, right? The idea is community creates content and shares it back with the community that it's most, it's supposed to affect and impact, right? So coming to the vision, all kinds of people talk about their TB experience on one platform, and then these stories don't remain only on the platform or behind closed doors, but go out to communities that they're meant to impact. And coming from people like them, for them, attracts the community to what these people have to say. It is real and it is relatable. And the power of storytelling to communicate, of course, has been undebatable forever. And we saw that in the, the keynote speaker address as well. Now, with this context and background, an almost 6-month experiment was conducted in HP in a staggered approach manner. The campaign first broke on social media, on key social media platforms, plus regional platforms like Moj and ShareChat and Public, and national platforms like Facebook and Instagram. This talked about soliciting stories in the initial phases, and as stories started coming in, motivating the people to share those stories further. This was followed by an offline rollout, which was launched by the Chief Minister of HP, thereby giving it more eyeballs, supplemented by an offline outdoor media dissemination via hoardings. And this is an experiment we did in Simla to make it more obvious, right, for the people of Simla. But all this was leading everyone to the digital platform and their digital journey thereafter. As a special intervention, 22 social media influencers were roped in to share their stories. And these are micro influencers, right, from Himachal Pradesh. And since this is a digital intervention, so of course, I'm sure those of us who are familiar with digital marketing understand the importance of influencers. And they share their stories. So they also had stories of TB to tell. Okay, somebody's friend was impacted, somebody's grandmother was impacted. Some of these were paid influencers, but a lot of them were onboarded on a pro bono basis because they came in because somewhere or the other in their life they had that connect with TB. So they came in just to support. So all I'm saying is, वो जो in Hindi what we say na मांगने से तो भगवान भी मिलता है. So this is like all we have to do is go out and ask people, and you will realize what from like we realize that there are many people out there in the TB space who are willing to come and lend their voice. So this really was a winner intervention, but not only did it lead large numbers of their followers, but also we got engagement. You can see, so one thing is to say, okay, you 50,000 people, this was seen by 50,000 people, but how many people actually ignored it and how many people engaged with that content, right? So 3,500 plus engagement with this content happened during a very short span of 7 to 10 days, right? And of course, a WhatsApp, this is just to give you some numbers on the kind of influencers and their reach and and the kind of reach that we got for this intervention. WhatsApp community was also created. Search engine optimization, which is basically to say that when people type TB or type stories of TB on Google, this page sort of shows up and guides you to actually go and visit this page. Apart from the qualitative impact, right, which hopefully we've all begun to feel at this moment, and we've all, after having seen the slide so far, hopefully have understood the potential of the quantitative numbers themselves are really very exciting. This campaign reached about 20 million people. That's about 2 crores in India, and about 13 million, which is about 1.3 crores, actually saw this. The even better part is that people started to engage with this content, which means they commented, they further shared it, they pressed an emoji for it. So about 36,000 people actually engaged, in this manner. The influencers, of course, provided a big fillip, but even so, a significant portion of these numbers happened organically. Very negligible amounts. I mean, if we were to talk about the financial efficiency of an intervention like this, very negligible amounts of money was spent on ads to generate traffic, and about 90 paisa, which is I think 0.01 USD approximately, to engage one person, right? I mean, that's really nothing. On the website, the traffic increased, 55,000 people spending more than 1 minute on the platform. Now, the stories shared actually covered a diverse set: information about TB, symptoms, how early detection is the key, how they address stigma, government skills available, etc. So while it started as a with the intent of normalizing TB conversations, breaking stigma, but we figured that it actually started educating people about TB. Everybody knew TB, but everybody not necessarily knows the right information about TB. And this kind of real and personal experiences started to do that. And most of all, these are stories of hope, of saying that you can do this, just take that first step. And just showcasing 2 or 3 things here from the people who have shared stories, like what is their motivation to share their stories. So somebody says they feel empowered, helping others to get courage. People are informed about TB.
तो मुझे लगा कि जैसे मेरी कहानी को एक नई पहचान मिली। मैं जानती हूँ कि अपनी स्टोरी शेयर करना कितना टफ है, बट ट्रस्ट मी, मैंने भी अपनी स्टोरी, मेरी टीबी की कहानी प्लेटफॉर्म पे शेयर की।
केरी लोड़ी ना सोबिरे करना इलाज ताकि बची सो का देश हमारा बचा दुनिया सारी.
Right. So what it does is it makes the community feel empowered, right? So we were just talking about how, we want to engage community, but we actually don't engage them in the designing, planning, etc. But this is an intervention which actually, and community not restricted to a traditional definition of a health community, but the larger definition as we had just discussed. Now, the key learnings have been that a concept like this works at a fraction of the cost of big media campaigns, needing minimum intervention. It's led by the community, for the community, and youth actually, which is 18 to 34, are really the ones that are most attracted to this and connect with this, right? Um, and of course, I mean, the result is, and the hope is that, this now becomes, this is of course a very, very recent experiment. And the hope is that now we can take this to the whole TB community and we get millions and millions of stories on this platform. Um, so here, very happy to state that this is India for the world. It has been replicated in South Africa. We had a conversation with the South African TB program, and it has been replicated there and saw the merit of this intervention. And they have actually included it as a part of their SPCC program on TB. And that really validates, that we are on the right track. And not only is this geography agnostic, but also health issue agnostic, right? It could be used for HIV, for asthma, for anemia, sickle cell anemia, for whatever you want, right? It is any other disease, including, I would say, mental health issues, right? Where community storytelling really is of significance and importance. So,
अपनी टीबी की कहानी को www.meritbkahani.org पर आज ही शेयर करें. मेरी टीबी की कहानी.
so that's what I had to say. And I hope you found this interesting. Thank you.
Yeah, very much. Thank you, Ms. Anisha. As it's a very good initiative to show how to normalize the conversation about different diseases, not only tuberculosis, but it can be expanded to other spectrum of the healthcare system as well. So just one question. Did you take consent from the people
Sorry,
that it
yes,
would be?
yes. In fact, I forgot to mention that. So there is an inbuilt consent form.
Okay.
When you're uploading the story, it asks you for a consent form, and then only will it take it forward.
It's very, encouraging to see that more than 36,000 followers are already there. So do you have any breakup of the age group and what kind
So I
of
did-
people?
Yeah, so I did mention in my learning slide that 18 to 34 is the
Is it?
category
Oh.
that is most attracted to this.
Okay. So I'm sure you were having many questions for her. So we'll take all the Q&A session maybe towards the end, all the questions after all the speakers have made their presentations. So the next one is again on tuberculosis, but here we'll be listening to Dr. Mrinalini Das. We'll be talking about the community-based person-centered TB care. So just brief introduction of Dr. Mrinalini. She is working as a monitoring and evaluation specialist with FIND. She's an epidemiologist and an operational researcher. She has a master's and PhD in public health. Her area of interest is pediatric and adolescent tuberculosis and drug-resistant tuberculosis. She has been involved in operational research activities for more than 12 years in the field of HIV and tuberculosis, including new TB drugs. Over to you, Mrinalini.
Thank you. Hi, everyone. Good morning. Okay, yeah, this is okay. Thank you. So my name is Mrinalini Das. I'm from FIND, and I'm representing the Unite to Act project. We'll share some findings from the project here. So we all understand, thank you to the first presentation and the people before that, people with TB do face multiple challenges during their TB treatment and diagnosis. Stigma usually leads to delay in access to TB treatment and instances of TB treatment interruptions. Poor awareness in communities, misbeliefs, misconceptions have been linked with TB stigma and poor TB adherence. People with TB often visit multiple healthcare providers, and these also lead to long TB diagnostic pathways. They also face catastrophic expenditures during their TB journey. TB treatment usually focuses on clinical management and less emphasis is given to psychosocial support. Thus, in recent times, the global and national programs are focusing more on psychosocial aspect of the TB treatment. So our project, Unite to Act, This aimed to amplify the access to person-centered TB support services, leveraging the lived experience of TB survivors to drive impactful change and improvement of the outcomes of TB patients. The project was implemented in 25 states and union territories. We directly implemented in 11 states and 82 districts, and we provided technical assistance where information was offered how person-centered TB care services could be implemented by trained TB survivors. We would like to acknowledge the project was funded by the Global Fund. So under this project, trained TB survivors provided person-centered care to people as peers, specifically at their doorstep and also at treatment facilities. The main theme they said was, I had TB, I took treatment, I am cured. So if I am cured, so can you. So the project was implemented by FIND as a principal recipient, REACH as sub-recipient, and our implementing agencies, Mamta and World Vision India. Under the project basic outline, we identified TB survivors in collaboration with the NTEP. These identified people were brought for a 2-day capacity building of TB survivors meeting, where modules on TB disease, treatment, prevention were provided. Post-training, consent was sought from these survivors whether they want to be engaged as TB champions and enrolled in the project. Once they agreed, additional project-specific trainings were provided. We would like to inform that more than 1,900 TB survivors were trained during the project period, and we also developed certain training materials and modules for their use later, even when they were doing the activities. Under the implementation plan, the project was implemented in a phased manner. We had a 6 months mentorship program where these TB survivors provided care at the doorstep. And also it was followed by 2 years of facility-based support, where these trained survivors were sitting in the NTP facility and they were providing care once the person was diagnosed with TB, so that early intervention and early management could be provided. Apart from this, as a one-to-one activity, they were also engaged in community engagements, where they were doing awareness sessions and getting the community leaders involved in these activities. So currently we are describing the study using secondary data from the project. A package of services was provided for all the people with TB. There were 10 services which included treatment literacy, gender responsive peer counseling, gender responsive family counseling, linkages for care related to adverse events, and either for comorbidities. So currently we are sharing this 3-year project achievements, including the TB outcomes. So coming to the results, people with TB under the project, as we mentioned, for 11 direct implementation states for the duration of the project period, we could provide person-centered care to more than 238,000, which included 90,000 people who received care during the mentorship period, which was a doorstep delivery, and 148,000 under the facility-based care. If we see the social demographic characteristics, 5% were less than 15 years of age, 59% were male, and 76% of people with TB had pulmonary TB. Coming to geographical distribution, the services were also provided considering the population of the state and how much it required. That's why Uttar Pradesh stands tall, where 53,000 people with TB receive services. For Himachal Pradesh, it is at a lower grade because the services started or the project started 1 year later. That's why 1307 was for Himachal Pradesh here. Successful TB treatment outcomes. We also reviewed and reported the people who received care during January 22 to March 23, and after 1 year, what was the success related to being cured or completed for TB treatment? It was around 88%. And if we compare it with the states, considering the year 2021 as the baseline, when the project, it was a pre-project era, we could see that majority of the states had improved their TB treatment outcome under the project. Just wanted to mention 2 things here. For 2021, we've taken the annual TB report, which has all the districts. And for this particular project, we are only reporting about the 82 districts where we had our own activity. We would also like to mention about the TB self-stigma mitigation efforts that the project has taken, where trained TB survivors were providing, a TB stigma information and mitigation plans in community meetings. Individualized support was offered to people with TB and their families in case identified stigma incidences were identified, and they were discussing it with the community leaders, school teachers, and even the families. So we did a baseline in 2022 where we asked these. A particular sample was taken from 15 districts, 5 states, and the question was asked whether they face TB self stigma. There were certain 12 questions were asked where they, if they said yes, we also asked them whether this self stigma led to inhibition for seeking treatment. And if they said affirmative, the answer was like 20% of them said yes, I faced maybe self stigma, which inhibits me from receiving treatment. 3 years later, we did another survey as an endline survey in the similar states and districts, and we could see that there was a 60% reduction in the stigma related to the same questionnaire being asked. Other project activities. So, more than 400 community health officers were sensitized about the activities of trained TB survivors. So, after our project closure, for continuation of their work, we worked on those lines. There was liaising with community leaders for Nikshay Mitra initiatives and other NTP plans. In 2021, the project also received an additional grant under C19RM mechanism, where the activities were designed to respond to COVID-19 pandemic. We had three main components there: rapid response team, communication skilling, and third gender TB survivor training. Under rapid response team, the team provided information about TB and COVID-19. For communication skilling projects, they received training about customized IEC materials that they could develop and use in mass awareness campaigns. And third gender TB survivors, this was a special pool of people who were trained and could provide services to their community and in general as well. So what do we recommend? So we believe that continuous guidance and support from the national program and collaborative efforts help the project. Active participation of community representatives in preparation of context-specific strategies, including the IC materials. Regular training and hand-holding of the TB survivors helped us prepare a pool of trained TB champions that can be used even after the project has ended. A robust monitoring and evaluation system, and majority of the times we used to have discussions on challenges and mitigation plans at each level so that we can provide improved care to people with TB. We believe that the trained TB survivors provide person-centered care to TB champions as an extended network to the national TB program in the community. And the scale up of similar community-based initiatives through NTP resources will help in minimizing the TB stigma and overall TB burden. We'd like to acknowledge the support of people with TB, their family members, survivors, project teams, NTP, and the Global Fund. The pictures that are shown on the slide are the IC materials that were prepared by the TB survivors for the project duration, and they are also being in use right now. Thank you.
Thank you, Dr. Mrinalini, for telling us how trained TB survivors can act as catalysts for change. So they were trained for 2 days using a guidebook, right? And they were all serving free of cost? No, they were being paid an honorarium of how much?
Yes, there was a particular honorarium under the project that was discussed at the grant. And then later, we are also thinking about putting it on incentivized projects.
Okay, great. So out of all the states that you mentioned had shown a positive result, I see that Punjab had shown a kind of a decline in the TB, cure rate or treatment completion rate.
Correct. So there was a minor difference. I would owe it to the late reporting or probably from our side. It would, because we also looked, what we have not presented, we've also looked at unsuccessful outcomes. So we saw an improvement in loss to follow-up cases, diet. So in that ways, it was an improvement in the community.
Yeah. Thank you so much. So now we will move from tuberculosis to childbirth. And we have a very exciting session here. So just to introduce you to the topic, by 2030, maternity services in India will need to respond to approximately 35 million pregnancies per year. As a response outlined in its national guidelines for midwifery services, the Government of India is committed to educating 90,000 midwives who will be called nurse practitioners in midwifery and function in midwifery-led care units, which is called MLCUs, to care for women during labor and birth. MLCUs in which the midwife is a primary healthcare provider caring for low-risk pregnant women. It represents one model of how to integrate midwifery-led care during birth into existing health systems to improve maternal health. So, midwifery led continuity of care has midwives as a lead professionals to support women in planning, organizing, and delivery of care from the initial visit to the postnatal visit. So, we have with us Ms. Lindsay Barnes, who is the Health Director of Jan Chetna Manch, Bokaro, Jharkhand, India, who will be talking to us about the impact of such a model in the state of Jharkhand. So she is the Jan Chetna Manch, Bokaro's health director for nearly 3 decades. She was awarded a PhD in sociology from JNU in 1990. Since then, she has lived and worked in a village in Jharkhand, helping women establish their own health center, and has trained over 100 health workers to provide quality maternal health care. She was conferred an honorary fellowship of the Royal College of Obstetricians and Gynecologists in recognition of providing quality maternal health care to rural women in 2014. Over to you, Ms. Lindsay. And I can see some people standing at the back. If you can come to the front, please. There are some empty chairs here. Okay. Thank you. Over to you.
Thank you for the introduction. And I'd like to also make a few disclaimers. I think some of it has already been cleared. That I'm not a doctor, I'm not a midwife, but I'm also not talking about disease, sickness, and patients here. I think the last couple of hours we've been focused on diseases and illnesses, and I'm very clear that pregnancy and childbirth is overwhelmingly not an illness or a disease. So I'm coming from Jharkhand, and what I'm presenting to you today is a 30-year-long story. It had no planning. But anyway, I'm sharing with you today the results of this long story. This is our health center there in Jharkhand. So this health center started, my involvement or our involvement with health started over 30 years ago. And it's being facilitated by an NGO called Jan Chetna Manch Bokaro. As the name suggests, it's located in the district of Bokaro in Jharkhand, which is in eastern India, adjacent to Chhattisgarh. It was registered as a society in 1994. And one of the key activities, and probably one of the most important activities which has influenced our involvement in healthcare and childbirth, is the establishment of a network of over 600 women's groups with 9,000 members. Now these women's groups are federated. This is an autonomous federation of women's groups, and it is their demand over the years that has directed us to get into the sphere of pregnancy and childbirth and dictate the sort of services that we are now involved with. So from the beginning, 1997, we set up our first health center. Once women had a voice and were organized into groups, the first probably demand was not for savings and credit, was for healthcare, for childbirth. We want a place for ourselves. It was a time the traditional system of healthcare in childbirth, traditional midwives, the guys were dying out, and there was nothing really taking its place. So the women were very clear, we want our own space and we want our own center. Initially, they demanded doctors. 97. We went to the head of our district and he said, I can't get our doctors to work, so forget about it. So we forget about it since 97. But we didn't give up on the demand. The demand was still there. So over the years, we've established our own center. Now, this is today's center. It's after 25 years or so. We've got a 20-bedded health center. It's providing childbirth care 24/7, and it has a very robust clinic, mostly for pregnant women on 5 days a week. These are our team. They're all of them living in the villages surrounding our health center. They're from the same community of the women that come there. As far as training is concerned, we've done in the beginning 6 months, you could say theoretical and practical training. That's a sort of screening of who can become a midwife and who cannot. The ones who you see in the picture now, they've all gone through this screening, you can say, because training is ongoing. We've had multiple outsiders and visit and also take part in the training of these women from all sorts of medical practitioners. I forgot to write midwives here. Sorry. One of the things which I have found is that these women take a long time to get to where they are. But once they are trained, once they are providing the services that they do not leave. There's a very low turnover and very high motivation of our team. Apart from the health center, we have an outreach program. So we have 8 community health workers who link our health center to the community. So we have women's groups in around 100 villages. So these 8 women, they visit these 100 villages every month. And they visit the homes of pregnant women, as well as women who have recently delivered in all these 100 villages. So something like 2,000 women per year are visited at home. And linking them to the village women, we have 75 what we call Swast Sakhis, health friends. These are women who have been selected by the women's self-help groups. So why did we collect data? Data is very important, as we have heard today. So data speaks to us. We needed data to see where are we going, where are our gaps, and also speaks to others. What we're doing, is it saying anything to the wider community, or is it just a gut response to a local problem, which is not replicable anywhere? This was why we collected data. So since 2016, we've got very robust data now in our health center. We've got data of some 7,249 women who have come for birth. The vast majority have delivered in our health center, 7,065. 200 and odd women have been referred to a so-called higher center if complications arise, because it doesn't have emergency obstetric care, obviously. These are our results. Over the years, I've never seen a maternal death in our health center. And that is not since 2016. I'm talking about 1993, 94. I have never seen a maternal death. Our C-section rate in the last 8 years is 5.5%. This is including all women who were admitted and those who were referred to a higher center. Intervention, we have a very clear protocol of no intervention if there is no indication for it. So our induction rates are very low, 6.3%. Augmentation in labor is also very low, 12.2%. Our midwives are trained to do vacuum deliveries, which has been a lifesaver for many neonates, 6.4%. As a result of these less interventions, we have less complications. So 1.9% of women have had PPH, the vast majority of whom have been dealt with and treated in the health center itself. I think in the last 8 years, I know of 5 women who have had blood transfusions at a higher center due to PPH. Only 8 women have had eclampsia, and these include women who have been brought to the center having eclampsia. 1.6% of neonates had an APGAR score of less than 7 at 5 minutes. And our very early neonatal death rate, that is death of neonates of less than 7 days of birth, is 10 per 1,000, which comes to 70 babies over the last 8 years, which we feel is still very high. But this includes very, very preterm babies of 600-700 grams, as well as babies with severe congenital anomalies. These are the numbers over the year. You can see during lockdown, it did hit us. The number of births did go down, and we're slowly getting back now to pre-COVID levels. In conclusion, I'd like to say that the most important thing of our health center is community involvement. It is their health center. It is not, we have not set up this center to provide a service for the community. It is the community's own center. And it is their demands. It is known as the Mahila Mandal Hospital locally, because it is the women's groups who have, it is our hospital. They invested in, initially, it was their capital that they invested in it. They sent women outside for training. They paid for that. So even now, they charge themselves less money than the other non-members for the services that are provided. So the women are both the owners of the hospital as well as the recipients of the services in it. And the other conclusion I'd like to highlight is that the most obvious, less medical interventions leads to less complications, lower cesarean rates, and the best of all is no maternal mortality. I'd like to acknowledge this presentation would not have been possible without all our health workers, our nurses, our community health workers, and our Svasthakis. Thank you.
For a very, very motivating, presentation. It clearly shows that persistent efforts and commitment can even move the mountains. So one quick question is about the community health workers. Are they voluntary? Are they voluntary workers, or were they paid also by anyone?
Hello. The community health workers, 8 of them, they are paid by our NGO Janchetna Manch. The Svasthakis are not.
Okay, and is there any relation with the Ashas? Are they also working as Ashas in their communities?
The Svasthakis predated the Asha program. When the Asha program was rolled out in Jharkhand, we thought that many of our Svasthakis would become Ashas, but it didn't happen. There's lots of problems related to that. There's also a lot of not duplicacy. There's no duplicacy because the Ashas generally are not doing what the Svasthakis do. They don't attend women in childbirth. Okay. So that is a very specialized thing that our Svasthakis are doing. I would say that the Svasthakis are probably more like a doula in the sort of global sense.
Okay. So thank you so much. And now we move on to the next session, which is on capacity building for community-based organization. And we all understand that capacity building is a core to any program that needs to see success at some point of time. And the capacity building initiatives are basically meant to develop the skills, the knowledge, resources, and network of the community-based organizations. The purpose is to provide guidelines for the community-based organizations in order to strengthen their organization and improve their overall management and operational systems. So in order to highlight this thing, we have a session which will be delivered by Ms. Lebong Kabola, who is the Regional Community Engagement Coordinator, MSF Johannesburg, South Africa. And she'll be talking about transforming MSF's approach to community-led initiatives. She's currently studying for a postgraduate diploma in applied health economics with the University of South Wales. She started out in MSF with the Access campaign, supporting efforts to push for access to affordable medicines, vaccines, and diagnostics in South Africa. For the past 2 years, she has been working as a community engagement officer with the MSF Southern Africa section, working more closely with community based partners in building their capacity to support project exit strategies that will ensure sustained health service delivery after the MSF project closure. Over to you, Lebon.
Thank you so much. And I'm grateful for the opportunity to sort of present on the approaches that we have taken in working with community-based organizations in order to capacitate them to support MSF's exit strategies when we leave or close our projects in areas where there are gaps when we see MSF leave or hand over to Ministry of Health facilities. So this project was initiated 3 years ago, called the New Ways of Working Community Organizations, supported by the Transformational Investment Capacity, which is sort of an investment hub within MSF, sort of working to create new ideas and changing the way in which we work with patients and communities, but also adapting to our evolving patient needs. And the objective behind the project was to sort of support MSF handover strategies. So when we leave and hand over to ministries of health, we wanted to find an alternative to also ensure that healthcare services still remain within the community, especially for key populations who would otherwise find it difficult to access services with ministries of health. And this approach we have taken sort of values the community's input and sees them as communities and community-based organizations as active participants instead of just passive recipients of aid. So in terms of the organizations we've engaged around 14 community-based organizations. And this is specifically in areas where MSF projects had already closed and in areas where MSF projects were still running. And the disease areas or the focus areas in terms of healthcare were quite different, ranging and aligned very much with what the project or the work that the project was doing within these areas. For example, in Malawi, this was quite special because these were former patients of the MSF project that was working on HIV for HIV healthcare services for sex workers, as well as sexual and gender-based violence services. And former patients sort of banded together after the MSF project had closed to form 2 CBOs that still focus on providing lay healthcare services to sex workers within the community. In Kenya, for example, as well, we have 2 CBOs implementing differentiated service delivery for non-communicable diseases. It's also in an area where government has, the MOH has shortages of supply for NCD drugs a lot. So former patients also came together to sort of form these CBOs, and they are supplying drugs through a WHO pre-qualified supplier within the MOH facilities. So the approach we have taken to this is quite sort of adaptable approach. We call it a twofold capacity building approach, where on one hand, we are building the organizational structure of the community-based organizations, where we're looking at sort of the fundamental components that are essential for the day-to-day running of the organization, such as governance, your financial management, administration, human resources. But concurrently with that process, what we try to do is also implement the activities. So support the organized CBOs in implementing lay activity, healthcare activities, such as your referrals, awareness raising, peer-to-peer counseling and support, as well as health promotion. So we ensure that we run these concurrently, because if we wait for us to build the organizational structure, it will take time for us to also start, by the time we start implementing or supporting on implementation of activities, it will take a lot of time for that. So we make sure that we run these processes quite concurrently. The process itself initially starts with a capacity needs assessment. So we've developed a tool where we sort of assess the key areas that were mentioned in the twofold approach, such as your governance, your administration, your financial management. And based off of that and the gaps that we assess in the assessment, capacity needs assessment, we developed together with the community-based organization a capacitation plan where we prioritize in what areas they will require training, mentorship, and so forth from us. And from that, that's where we support in terms of the service delivery, in terms of them implementing the activities, but also in terms of them creating monitoring and evaluation tools, which are quite essential when they apply for their grants and require resources from external stakeholders. And the final step to that is an MSF exit strategy, where we see how we incorporate in our MSF handover strategies the community-based organizations that we've worked with, but also how we continue to support their sustainability even beyond MSF closure. So just an example of some of the outcomes we've seen from Malawi with having the community-based organizations sort of go through this capacitation process. The sex workers are now accessing sort of lay services from the community-based organizations. They're accessing pre-exposure prophylaxis, post-exposure prophylaxis, contraceptives and self-tests, HIV self-tests within the community, so they don't have to go to the MOH facilities to access these. So psychological first aid, as well as for sexual and gender-based violence, as well as referral pathways to the Ministry of Health and to local authorities in cases of sexual and gender-based violence. So the CBOs themselves have established sort of this relationship and partnership with the MOH and local authorities as well. Implementation of peer-to-peer and counseling sessions. And one of the organization has actually implemented a teen clinic where adolescent sex workers are able to access services ranging from HIV testing, family planning, STI management, as well as psychological first aid as well. The health education sections are conducted at the hotspots. So it's also access to information for the sex workers where they are and taking that information to where they are. And also advocacy initiatives. They're engaged or working collaboratively with social welfare to get small children or young children out of sex work, but also part of even national networks where they're working with the AIDS councils to advocate for better access to healthcare to sex workers. In Kenya, which is another example, where they are implementing differentiated service delivery for NCD drugs. This is in areas where patients don't have constant or consistent supply from the MOH for their NCD drugs. So the two CBOs that were developed developed community revolving pharmacies, which are actually based at the MOH facilities within the communities. There are now 11 satellite community revolving pharmacies established between two CBOs. And these are in two different counties in Kenya. And so approximately 9,000 patients are registered between all the 11 facilities where they actually receive their drugs at these facilities. And 18 peer-led support groups have been established from these 9,000 patients that have been registered from the community revolving pharmacies. And this community revolving pharmacies are also monitoring drug stockouts from the MOH facilities, which has supported them in their advocacy initiatives when they are calling to increase supply or consistent supply of NCD drugs from the MOH. So what we have learned from this approach of engaging community-based organizations is that once capacitated, the community-based organizations themselves can implement community-led solutions. And this has been evident in the sort of context-based programs that they've implemented for their beneficiaries. Contextual sensitivity is quite key. As I've said, I think in the beginning, this is an adaptable approach, which can be adaptable to the different contexts that we are implementing. This has strengthened our handover strategies because it has ensured that alternatively to the ministries of health, patients or beneficiaries and key populations can access services beyond ministries of health. And integration of the community engagement, of this type of community engagement is important right at the beginning of the project life cycle, instead of us engaging community-based organizations when the project is about to close. And just finally, the recommendations for this is that it is essential to maintain ongoing consultations with community-based organizations. So capacity needs assessment don't just happen in the beginning when we are trying to see the gaps in the beginning and how we can implement capacity initiatives. But this is an ongoing process because community-based organizations, like any other organizations, are ever changing. So we need to constantly keep sort of looking at the gaps as we go. Strengthening reporting tools is quite critical for the organizations as they apply for funding, because this is what funders want to see. They want to see the evidence of what they are implementing. And sort of this peer-led model is also quite key when it's a key strength of the community-based organizations, especially working with key populations, as they are more comfortable receiving services from people that understand what they're going through, as opposed to just the MOH. And encouraging increased networking and collaboration is quite essential for these organizations because they have to develop networks and form part of partnerships that will sort of sustain them in the future, even beyond us as capacitators of these community-based organizations. So I will stop there. Thank you very much.
Yeah, thank you, Lebon, for a very interesting presentation, and also underscoring how much it is important to have a succession plan in hand in order to ensure sustainability in the longer run, and as has been explained from examples from Malawi and Kenya. And we also agree that increased networking and collaborations is the key to sustainability in the longer run. So this hand-holding happened over how many months? I mean, was it variable, or was there a fixed kind of a structured program?
So this has been initiated, I think we've been working on this for 3 years, and it's quite variable. I think, as I said, it's a context-based approach, and it's adaptable to the different contexts, because in different contexts, you will find that sometimes you have to take a different approach because maybe the MOH isn't cooperative. In some instances, you have to take a different approach because the members of the CBOs as well need a bit more of a push than other CBOs. So it also doesn't have a timeline where we can say it takes this much time to build sustainability of a community-based organization, because each has its own unique kind of way of taking in this capacity building.
Sure.
Yeah, and building on that. Yeah.
Yeah. So thank you so much. And now we'll move on to the last presentation of this session, which is on antimicrobial resistance. India has a very high burden of antimicrobial resistance that we all know, and it's expected to worsen in future. So in 2019, almost 3 lakhs deaths were directly attributed to AMR, and another 10 lakhs were associated with AMR. So it has a huge impact on the health of the country as well as of the globe. And we all understand that behavioral change is required to control AMR, and these can facilitate the development of resistance, including inappropriate use of antibiotics and ineffective infection control hygiene practices. There are several community-based models which are in place to address this whole menace. One such example is a community dialogue approach, where there's a training program that trains community volunteers to facilitate dialogues within their communities to discuss AMR. So the members explore the challenges, they identify solution, and they plan for action. So similar, there's another model which is also in place that brings together researchers and practitioners to tackle AMR in low and middle income countries. And the network shares project reports, guides, and community produced resources. The third model is that of antibiotic smart communities, which has been piloted in Kerala, India, that has developed a model for community engagement to address AMR. The project involves a community-led process to identify the needs of community and develop context-specific intervention to contain the impact of AMR. This was launched by REACT, which is an international network working on AMR issues. The project was of a 4 years exercise to develop a model for community engagement. And this will be discussed by our next presenter, who is Dr. Haifa Mohammad Ali. Over to you.
Just a little bit about REACT before I go into the Antibiotic Smart Community project. REACT was launched in 2005 in Uppsala, Sweden, and we are primarily funded by SIDA, Swedish Development Aid. And it is one of the first international network to articulate the complex nature of antibiotic resistance with a mission world free from with a vision of world free from untreatable infections and a mission to enable collective action that ensures sustainable and equitable access to effective antibiotics to all. We have nodes in Latin America, React Africa, and Asia Pacific, apart from Europe. And in India, we are hosted by initially we were hosted by CMC Vellore and currently hosted by Global Institute of Public Health in Kerala. So, as we try to do engaging communities with respect to ABR, we try to have these four broader objectives like identify strategies to improve understanding and competence among community stakeholders, create an accountability of efforts to implement NAPs at local level and plans that we can, revise and co-create together with the communities. NAP implementation processes and how we can be more sensitive towards communities' priorities and then most importantly, identify local strategies and resources. So with Antibiotic Smart Community Project, we try to come up with, it focuses on coming up with public health driven innovation, then identify optimal strategies, then co-create resources for the community stakeholders. So the four key deliverables that we try to focus were like identify a set of multi-parameter indicator framework for quantifying maybe antibiotic smartness of the community, then identify approaches and strategies to engage specific stakeholders within the community, create toolkits and manuals to educate and build capacity in specific groups within the community, and identify novel interventions to tackle antimicrobial resistance in community contexts. So this was like a broader framework that we adopted was like identify an overall, interest in health, communicate it, then making AMR an issue of concern for the community, de-jargonize the context of AMR, and then use like micro incentives to bring people towards the discussion platforms. Then with that, we try like small implementation approaches, co-creating solutions together. And broader strategies include like communication strategies for ABR and engaging key stakeholder groups. So just the indicator framework, the details of the indicator framework and how we have structured it, including the scoring pattern. I have added a QR code at the end, which you can scan, and I'm open for discussions and questions later. So basically, it's a broader set of One Health set of indicator framework. It's a multi-parameter one which was created initially, understanding our experience from the community as well as insights from experts locally, regionally, and internationally. So these are like few examples of the indicators that we are like, we can just use it. Anybody can, just go into a community and quantify them based on the parameters we have listed in the handbook. So it ranges from, hygiene facilities in primary, secondary schools to, percentage of vaccine coverage, which we can available with the health system to what is the availability of over the counter. So it's antibiotic specific, it can be antibiotic sensitive. So it includes like right wash, animal health is included, environment is there, a little bit of development context. It's an overall package that we can use to see how smart the community is just for measuring it for our and our understanding. So the framework leading to an action agenda is the second component of the project, where we try to create a baseline, and then using that baseline, we try to work with the community, support them in identifying what are the activities that they want to do, and then teaching them how is it connected to ABR. So basically, the indicator framework helps in identifying the lacunae, then prioritize the actions in a resource constrained setting, accountability for overall, community engagement initiatives that we have, and then facilitate communication with the community, like these are the issues that you have, and let's focus on building on it together. Yeah. So this particular village in Kerala was selected for our activity exercise, and the indicator framework was piloted there, and we received a score of 34 out of 45. So we have 15 indicators, and then each indicator is scored from 1 to 3 on specific criteria. Then, so it's mostly we see it as a point of entry to the community, so that we can initiate a conversation, because the faceless nature, it's not easy to discuss ABR as an issue to the community. Then we came up with this 12 set of action agenda that we co-created with the community using the existing structures which is available in the community. So for that, we did a conceptual, mapping of the stakeholders and the programs and activities that are carried out on the ground. And so basically, we tried to, as we decided what should be the action agenda, we assisted the resources. Then those should be like the activities that is available for multi-sectoral collaborations. Then priorities of the community was definitely weighed in. And then it has to be something that the community owns and then they want to do. So these are like some of the activities that we did, and these are like very low cost activities. If I have to weigh, if you have to see the finance part of it, and it's basically linking all the facilities or stakeholders within the community together. We created a small digital application that can help people to identify what are the antibiotics there, and if they go for an over the counter purchase, teach them how to reject it. So that we created separate communication modules and then sensitize the community members. This was especially seeing the context that in this particular community there were a lot of like elderly retired people who prefer to go to the pharmacy rather than actually going to a hospital. Then engaging farming communities. So while we did the scoring, we understood that the antibiotic use was high among farmers, and especially the context where these are like not large farms but small backyard farms, and they have free access to antibiotics considering the case of India. So we try to especially focus and work a lot on like farmers in the community, and we connected with community Krishi Vignana Kendra, ICAS, and other agencies that are already present in the district, and connected with the community members with the support of local self-government. Then similar activities was like, using the Swachh Bharat Mission Abhiyan, and where they have been trained to construct soakage pit. We took that as a platform to engage WASH and AMR. Another example is like, biosecurity measures instead of, using antibiotics, and what are the other technical support that can be provided through existing government mechanism. We provided platform for people to come up together. Local self-government and communities were together, people suggesting the ideas and helping them linking with the existing community mechanism. So like if I have to see these are the framework, the baseline and the post agenda score. So this agenda was conducted in 6 months with 2 activities each month. And but we have been engaging and we have been involving the community, sensitizing local self-governments, Kudumbashrees, Asha, and other workers for 3 years almost before piloting the community engagement work. But COVID was something which happened in between. So yeah. Then we see that already the community actually had a good score when it comes to certain indicators like access to household, water supply, and pediatric vaccine coverage. But we see that we with the focus interventions, we could see changes or improvement in scores in over-the-counter availability of antibiotics. Pharmacists and communities together were involved in addressing this, including we created like concave mirrors we set up in pharmacies for people to identify if they need, or we also had like a small box to bring back the leftover antibiotics. Then another was like antibiotic initiatives among farmers and biomedical waste management healthcare in healthcare facilities. So these were the few indicators that we could improve and were like sustainable in the period of 6 months we did the framework. And some of the insights that we have is like, certain components like explaining it in the context of gender, wash, or environment for that matter, even development perspective, how your cattle being infected can lead to lesser productions. Those gained more, interest among the people rather than, telling them, it is a big issue and it's a global issue, like just making it them to their, breaking it to their level of understanding was like a key thing. Using and identifying existing community structures is important rather than coming up with a new initiative. Engaging local governance, it is key, and dejargonizing AMR is an issue. Again, we should have a proper approach to how to exit from the community is also something which we found is like important. As we keep on pouring engagement, people do demand every time newer activities. So we have to identify a proper strategy. Then contextualized approach and entry point identifying is critical, and resource prioritization is again equally important for the project to be sustainable. And some of the challenges, yes, the nature of AMR, communicating it was a huge challenge initially, and we used to pitch on other diseases to explain AMR to them. Competing priorities, which was, it's not again a visible, they would prioritize more, especially, in pitching it to the local self-governments, it is a very, it's not at all a priority to be honest, but then bringing them on board was a huge success and it was equally a challenge. Lack of awareness and understanding overall, it is still there, but it has been improving. Uh, Again, like the external trust factor is also important as we try to explain to them. There is an often a chance of like people, questioning, is it really relevant to us? Uh, yeah, resource constraint and sustainable funding that is still lacking for these kind of projects. And overall, what we understand is like we shouldn't see AMR intervention as a separate thing, but rather something we try to integrate with our existing framework. And we believe the framework is useful in identifying an entry point and integrating it with the existing system that we have. And you may scan this QR code if you have any. You want to know a little bit more about the project. I'll stop with this now and I'm available for any questions. Yeah.
Thank you, Dr. Haifa. Hello. Yeah. I see that the multi-pronged approach actually yielded results. I'm just curious to know whether there was any targeted intervention for the doctors and nurses, because they're the main culprits, no doctors. Mhm.
Yes, for this particular community, the health
This is the mic.
Give. Yeah, so thank you for the question, ma'am. For this particular community, targeted interventions was like only with the waste management was like the only thing we could come across. And there we did create small posters and engagement directly with the nurses and primary healthcare centers. And for all the activities that we did lead in the community, primary health center as well as one of the medical college, their outreach area was also very similar to this community, so they were involved in it. Yeah.
So thank you so much. I can see that you all are thirsty for tea, but then we still have some time to take maybe one or two questions from the audience if there are any pressing questions for our panel, for the all-women panel. Yes, please. Yeah. So if there's a mic.
Good morning. I am Bijay from Nepal, and thank you all, five of all of you, for the good presentation. As a TB worker in Nepal, I want to learn from Anisa and Dr. Das. I have a small query for both of you. So for Anisa, um, as you are, what is the criteria? Is there any criteria for like uploading the kahani of the TB patient? If they can upload their like solutions, I mean to say like problem related to the, like TB or their, like social problem. And do we have any interventions related for those problems they share in the Kahani? And the next one, I will just finish my question. And for the Dr. Das, um, what is the like selection criteria for like TB that survivor patient, and for like mobilizing them for counseling and like education? Because when we are doing this in Nepal, we are having very difficult time, to continue those TB survivor for the education and mobilization. Thank you.
The first part of the question, maybe.
Yes, okay. Yeah, thanks. So basically, the objective of this is it's not a grievance redressal platform.
it is not a grievance redressal mechanism. The objective of this is to actually motivate those. I started with saying 64% of people who show symptoms of TB don't come and get tested. So this is to actually get those people out by talking about stories of hope. To say, if I can overcome, I had X challenge, this is how I overcame it, and if I can't you. So the objective of this is that it's not a grievance redressal, and the program, of course, has a separate, process and intervention for grievance redressal.
The second part of the question. Yeah.
Okay. Okay. So yeah, about the TB survivor selection and the criterias, we had a close discussion with the National TB program, and they were actually providing us the list. What the criteria we had was at least minimum education of class 10th or 12th, so that they can write the forms and don't know. And more importantly, we had a conversation that whether they are ready to share their stories or ready to work as a peer supporter. I think that was the most important thing, whether they can break their TB stigma and talk to the communities and be motivated to continue. We've had, the TB survivors have moved on with the career options and new people have roped in. That's why we were saying that we are training a pool of trainers so that it can be there in the community even when they want to move to another profession. They have a pool where we can substitute. So this is how probably our thing has been working. Thank you.
Yeah. Any other question? Yes, please.
Anisha from the union. I just wanted to know the timing of these videos, the storytelling videos. What is the timing when they are shared? Is it before or during treatment or after the patient is cured?
No, it could be any. So again,
Because I believe that the timing is very important in circumventing, the issue of discrimination. For example, if the patient has still not started treatment, that can lead to discrimination among the community. While if the video is shared after the patient is cured, then they can share their success stories. Yes, I was suffering and now I've been cured.
So this is, again, I think you've answered that question. It is stories of hope. It is success stories. And actually, I won't call it success stories. It's actually stories of hope. So there is one story there in which a daughter, her father suffered from TB, and they ignored the symptoms. And unfortunately, he succumbed to the disease. But she is actually coming up and she's saying, it's important for me to say this because I want to encourage you to not ignore your TB symptoms, right? So these are those kind of, and the community, as I mentioned, are, not just persons with TB, but families, friends, doctors. So at whatever level they feel comfortable, but largely stories of hope to motivate and to, to get people to overcome their hesitation and inertia and fear by listening to these stories.
Yeah, I think any other questions, or should we just wind up? So I think thank you everyone for sticking to your time and for delivering on the very important topics. I feel that there are 4 takeaways from this entire session. The first is that community-led action works. Second is that we need to have a succession plan in mind so as to ensure sustainability in the longer run. We may say that it is still a neglected part of the health systems, and therefore it's very important to document our learnings, which is, I see, as a very glaring gap. Thank you, everyone. Now over to you.
Thank you.
Thank you so much, everyone. Just before everyone leaves, just one quick announcement. We actually have more people attending than anticipated, which is wonderful. But it does mean we're going to put some rows of chairs at the back. So those of you who are at the last 3 tables, can I request when you go to coffee that you take your things with you so that we can then replace the tables with just rows of chairs, because there's quite a lot of people outside waiting to come in that weren't able to during this session. So now we're going to break for 20 minutes for tea and coffee, during which time I request that you go and look at the posters, the innovation kiosk. If you're online, you can click on the button above the live streaming window to view the posters. And a quick reminder that if you haven't already signed the consent form, please do so. And I'm going to see you back here at 12 Indian time. Look forward to seeing you back here. Can we get all the panelists for the next session to come up and sit on the stage, please? Any panelists for the next session, please do come and sit on the stage. We're going to get started in 1 minute.
You know who they are? They're I just read them out. I read them out as well. But she's just there, so I can.
Dr. Mala Chabra.
We're gonna talk.
We get Dr. Mala Chabra, Rahul Dwivedi, and Dr. Kamini Valia.
We need to.
Just a.
Okay. Feeling it.
Calling everyone who's having coffee. We're about to get started in about 30 seconds. Is your online participant on? Huh? Which one? Should have been here quite a long time ago. Do you want to ask where is who's responsible for that? Who's responsible for that? Sevanti, can you come to the front, please?
Have you got Rahul online? And yeah, I've asked him to. How are you? No. I see.
Hey, so I think we should respect the schedule and people who are online and get started. So if people could settle down at the back, we can commence this really exciting session that is super relevant to the context in which we find ourselves. maybe we can close the doors to the tea area so that we don't get a lot of noise as well, because I think that's been disturbing the online audience. We close the doors. Perfect. Thank you. Okay, ladies and gentlemen. So this is a panel discussion on antimicrobial resistance, introduction of new antibiotics and associated surveillance systems, barriers and potential solutions. Around 6 million people die due to lack of access to antibiotics. The majority of those are in humanitarian settings. That being said, we also know that these very same settings bear the disproportionate burden of AMR, fueled by overcrowding, poor infection control in hospitals, lack of water and sanitation, heavy metal contamination, all of which drive AMR. And antimicrobial stewardship is really quite challenging in these sorts of situations, especially given frequent self-medication practices in settings with fragile health systems, a lack of law enforcement on sales of over-the-counter antibiotics, a lack of awareness amongst healthcare workers who are often much more focused on expanding access to life-saving measures rather than performing a stewardship duty, the absence of laboratory infrastructure, and conflicting agendas in prioritization of programs when immediate life-saving priorities need to be addressed with limited resources. But I think it's also perhaps less well understood that lack of access to first-line antibiotics is not only an issue of equity, but it is also in itself a driver of AMR, leading to inappropriate use of other microbials, often with a higher resistance potential, leading broken pharmaceutical supply chains, a lack of essential medicines can often lead to a rise in substandard or even expired drugs and an increase in self-medication with suboptimal therapies. In many conflict areas and regions such as Gaza, access to essential antibiotics is often primarily through donations and has been a continuous challenge due to the blockade and embargoes, resulting in antibiotic availability as low as 40% even before the events of 2023. We have experts with us today from the field, and I'm going to pass over to my colleague from the Manson unit, Claire Shorthall, who is the AMR strategic lead within the Manson unit MSF. Thanks, Claire.
Thank you very much. And so I'm very pleased today to be introducing this panel. My esteemed guest. Sure, apologies. I will be very pleased. Just don't worry. I think maybe we need to check on where. All right, okay. Any better if I do that? Oh, there we go. Oh no, already. Is it to do with the? Any better? No. Is it okay? That seems okay. Apologies, everyone. So I am, again, very pleased to introduce this esteemed panel. We will be talking about today the introduction of new antibiotics, the surveillance associated with that, and the barriers and possible solutions. I'm very happy to have with me today Dr. Maya Shibadri, to my left here. She is a consultant microbiologist with considerable experience. She's based in the tertiary centre that is RML Hospital, which is very close to here. And she has also got a history of being the additional director of the NDC, the National Centre for Control of Disease, apologies, in India. And to the left of her, I'm happy to be joined by Dr. Kamini Walia, who is the AMR lead, the lead of the AMR initiative for the Indian Council of Medical Research, which crosses over surveillance, antimicrobial stewardship, and also One Health. She also has a considerable history in public health, working for the WHO SAGE on the introduction of diagnostics, and also a commissioner for the Lancet Commission on Diagnostics. And joining us online, we have Rahul Davadi, who works for GARD-P, which is the Global Association Research and Development. And with this panel today as an introduction to this piece. So we'll be focusing on the introduction of new antibiotics. But for MSF and the point that we all made in the initial discussions, really we are living, as Bhargavi talked about before, in a situation of unprecedented levels of humanitarian needs and with reducing capacity to respond to them. And really for MSF, AMR has been a priority since 2014 for this reason, because fundamentally it undermines our capacity to respond. We feel the compulsion to act in all our projects. We see people suffering from traumatic conflict-related injuries in our hospital in Amman in Jordan. We see children with severe acute malnutrition suffering from sepsis secondary to resistant organisms in our inpatient therapeutic feeding centres in Nigeria, through to Afghanistan, where we see children dying of neonatal sepsis due to inability to access antibiotics to treat them. And these are just some of the people that are impacted by AMR. So it's really, it's not just a technical discussion, but it is really something that massively impacts on MSF. And in terms of our activities and response to that, we've looked at how we can better support advocacy around AMR, how we can better do many of the things that have been discussed today in terms of address the data poverty issues, address or try to support the human face on it, on data, which I think was all very good points. And actually the excellent points made in the previous sessions about the real need for community engagement on this. Fundamentally, even though this panel to a degree talks about dealing with the consequences of our inaction, fundamentally global failures to respond appropriately to AMR, we have seen as disproportionately impacting on vulnerable populations. And if we do not do more to address them, then we will see this continue to increase. We talked as a panel before about how important prevention was as well, because the difficulties that we face when we deal with the consequences are so extreme. Sometimes we talk of AMR as a super wicked problem because you need such complicated multimodal interventions to try and address that. So while we talk about one area, we want to just keep in the mind all the different facets that come into play. I will now turn to our esteemed panel to get their input on the particular question of the challenges that we face. So first of all, I'll ask Dr. Maya Chabaji if you can speak a little bit to what your experience has been really kind of on a clinical level. So you work within a clinical team in a tertiary centre. What is it that you see in terms of patients with multi-drug resistant infections in your work?
At the outset, thank you so much for making me part of this panel, and I'm really honored to be associated with MSF. Thank you for that. And a very interesting question, what could be more painful for a surgeon who's done a planned clean surgery and the patient has landed up with multi-drug resistant organism infection and he's unable to treat? What is the state of affairs of a physician who is treating simple infection, a tooth abscess or a typhoid fever, and is not able to treat? These are the problems that we face in our day-to-day practices. And this is not just one odd situation. This is every day that we are facing. We are working in a tertiary care hospital where we have a unique situation. A patient comes to us. He's already he's self-medicated himself with antibiotics because they are available over the top of the counter. So he's taken those. Then he's gone to a private practitioner, a local doctor in his locality. Now, in our system, we have clinics, 2 clinics per street in India. We have small nursing homes where both qualified and non-qualified doctors are practicing, though there are regulations on that. And some of these doctors are very conscious of what they are prescribing, but some may not be as conscious. So they are prescribing, it is usually injudicious and overuse of antibiotics that has already occurred before the patient lands up in the tertiary care hospital. And once they come here, then they come with a lot of hope that they have landed up in a big hospital and now they will be cured. But when I talk to my team here, Dr. Sujata is here, Dr. Pinaki, Dr. Rahul, they are here. When I talk to them, they feel like weaponless warriors. They have nothing in their armor because the patient has already taken so many antibiotics. He's landed up in a state where infections are overwhelming and they are unable to treat those. So in addition to all this, there is overcrowding in tertiary care hospital, which compromises the infection prevention control practices, which is one of the main pillar in preventing antimicrobial resistance. So that is also adding to AMR. That is another challenge we face. Then lab infrastructure, how quickly to report, what are the point of care tests that we can help to do, and whatever conventional we are doing, are we doing, not only in our hospital. If I talk about tertiary care hospital, as you said, I was in national CDC, I traveled across the country. There is so much of disparity. Are we doing quality testing? Because any which ways, this is the basis that forms, or of reporting AMR. Are we doing quality testing? Are we quality controlling it? So those are the challenges that we face in day-to-day practices when it comes to, few initial thoughts on facing challenges in a tertiary care hospital when it comes to antimicrobial resistance. Thank you.
Thank you very much. That's a very helpful start, and starts with putting the face to AMR as well, which I think is important. Raul, I don't know if you can speak a little bit more as your job as access lead for the Global Antibiotic R&D Partnership, whether you can speak a little bit about what you've been trying to do and a bit about your organization, just for the audience as well, to understand what you've been trying to do to address access to antibiotic issues.
Right. I hope you guys can hear me.
Sorry. Okay.
Unfortunately, we can't hear Raul, which would be. Can we? Are we able to hear Raul in the room, please? Yes, I think so. Could someone with technical expertise help us to hear Raul in the room? Apologies, Raul, we can't hear you in the room. I don't know if they can hear you online. Please, could we get someone urgently to address that? Yeah, because we had this a bit the problem earlier, and they managed to get the sound to come out.
Right.
So if they could try to do that again, please. Sorry, Raul, we'll be with you shortly.
No worries.
Otherwise, we can try to computer mic, but it was working earlier. Otherwise, if someone can get a computer and then we use a mic. This could be another option. Yeah, do you want him to keep speaking? Would you like to recite a piece of poetry? We're trying to see if it comes out. We can't hear it at the moment.
Reciting poetry might be difficult on this
Okay,
call.
yeah, good point. Let's ask for another. So, Dr. Valia, could you speak a little bit about ICMR's position when it comes to, you've got a microphone, when it comes to access to new antibiotics, and also maybe how you see it, as we discussed before, in the context of all the actions that need to happen in India?
Thank you. Thanks for involving ICMR in this discussion. A lot has been happening at ICMR. In fact, antimicrobial resistance has been one of the flagship programs of ICMR. And we started working in antimicrobial stewardship about 6 to 7 years back. Initial initiatives was mostly focused on antimicrobial resistance surveillance. So it is important to understand that in India we have both access versus excess issues. There is a certain population which are actually socially and economically a little marginalized, and that's why they are not able to access even the basic antimicrobials that should be available to them. And at the same time, especially in the urban settings, we see a lot of excessive use of antimicrobials, which is driving the AMR, antimicrobial resistance levels in the tertiary care hospitals, which are mainly located in the urban sections. So this issue of access versus excess has been, one of the important points for discussion at ICMR, and many of our meetings that we do with regulators as well as other stakeholders. And we have been in touch with the drug regulator in the country and have time and again pointed out about the challenges with the implementation of the H1 schedule, which is there to regulate the use of higher generation antimicrobials in the country. And on the other side, we have this national essential list of medicines, which is also being coordinated by ICMR in close collaboration with CDSCO, in which ICMR has consistently made an attempt to um, uh, neutralize the pricing of antimicrobials so that the antimicrobials become accessible economically to all the populations. But then antimicrobials are different from your anti-cancer or anti-hypertensive drugs. So when you reduce the price of a drug excessively, it also tends to be overused. So this is a very a tightrope to walk, and it is a very fine balance that we as a country have to strike, that while the antimicrobials should be available to the populations at an affordable price, at the same times we have to take actions which actually discourages the as Dr. Mala pointed out, the injudicious use or irresponsible use of and misuse of antimicrobials. So as a country which is actually having a very wide economic spectrum, that's a challenge we will face. And also the healthcare systems, as Dr. Mala pointed out, many a times the healthcare system is not functioning optimally to give the right treatment to the right patient at the right time. So that also drives the excessive use of antimicrobials. But yes, access of drugs has been an issue, and that's why this question, why can't we ban over the counter sale of antibiotics, would be a very hard one to answer for us as a country. Do we want to really make antimicrobials inaccessible to those people who may not have an access to a healthcare system or a doctor completely? I don't think that is something that would be easy to answer. But yes, we need more discussion and deliberation on this as to what can be a more pragmatic solution for us.
Thank you very much. And yeah, I think this point, I think this is a very important point also for us within MSF, the idea that universal health coverage and AMR are essentially interlinked, and that AMR is really kind of horizontal in terms of access, and it's fundamentally an issue of access. And I agree on the access to excess debate. We've debated this a lot also within MSF. We need to do both elements. At the moment, I'm thinking possibly we can't go to Raul still. So should we carry on discussing between us? Yeah, okay. So we'll keep going, and then we'll bring Paul Raul in to talk a bit about GARD-P's work. But I think it's good to keep on talking about the fundamental issues of stewardship, which I think is the point that you've made there, and how important that is to all our endeavors. Maybe I can ask you a little bit, Dr. Maya, specific work that you've done around stewardship within RML, or things that you think need to be done as well.
I think that's a very good question, and that we need to deliberate in detail. And in any tertiary care hospital, we have doctors who are junior residents who have just passed out their medical school, but they have been, authorized to prescribe drugs. As Dr. Walia said, that you have given them the right to prescribe the drugs. Then there are senior residents who have done their specializations, and junior faculty, very, very amicable to adjusting to and learning, eager to implement things. And then there is senior faculty who's learned and difficult to target, to change perception. So we have different categories of doctors there who need to be targeted, so they have to understand actually the concept of stewardship. It looks like a big word, but it is actually what drug to choose, and I would talk about what I speak in hospital is the 4 moments of prescription, 4 moments of using antibiotics. The first being, decide whether this patient really needs antibiotics. That is the first moment. When you decide, okay, this is the patient who needs antibiotics, when you have to decide as to whether you are going to send any samples to the lab, because that will make a lot of difference. So timely and appropriate samples to the laboratory, who do quality checks on the samples, a quality antimicrobial sensitivity test, and give you out a report. Meanwhile, you can start an empirical treatment. And what should this empirical treatment be based on? We have national policy, we have guidance documents from ICMR, from the national AMR program. But what is required is the local antibiograms, local practices, and what has gone into the hospital and what is our requirement. So local antibiotic policy. Who should be making that policy? It is a coordinated effort of a pharmacologist, of a microbiologist, of a physician, of a surgeon, of multi-speciality, because they have their experiences and they know how their patients responding. So do we have that antibiotic policy? And are the empirical treatment being started? Once the empirical treatment is started, the third step is, are you ready to, after you receive the report, are you ready to de-escalate antibiotic? Now, this is a major challenge in the hospital. A patient has been given high-end antibiotic. He's already on high-end antibiotic, and you get a report that the organism is sensitive to first line antibiotic. Are you ready to de-escalate that? So that is another challenge that we face. And when they ask us, we have no specific answer to that. Okay, that you de-escalate, and if patient does not improve, what are you going to do? So we leave it to the clinician. Say, okay, our sensitivity report is saying that it will respond, and they should definitely try to step down to a specific antibiotic. But this is definitely a debate in the hospital. And the final movement is, when are you going to stop the antibiotic? So our policy should be when to start the antibiotic, when it is required to change the antibiotic and what are the reasons to that, and when to stop the antibiotic. So we have to remember, this is what I say, we have to remember these these things when we are initiating antibiotic treatment to a patient. Then, as I said, local antibiotics, I'm talking about RML, we have a antimicrobial policy in the hospital. But in other, if I talk in general of tertiary care hospitals, some of the hospitals may not have local antibiotic policy. Then the issue in our hospital is, how frequently do you revise these policies? Do we have any guidance document on that, or do we use our own judgment to revise? So are we looking at the national programs, other countries' experience as to how they decide on these things? This is another major challenge. And then, as I said, different level of doctors. So you have to educate them, make them aware. And this is going to be an ongoing process, because the doctors change. The resident doctors would
Hello, can
leave,
you
senior
hear
residents
me?
would leave. So it has to be an ongoing process. It is not a one-time activity, okay, that I've done it today and I don't need to talk about it tomorrow. So it is going to be. Another major thing is our lab infrastructure. As I already said, you have to give out quality reports. So it starts with what media you're using, what method you're using. Now, this is very important, because we follow CLSI guidelines, and that is being followed world over. And so you really need to, everybody needs to stick to those and report accordingly. Now there is shift of reporting. Instead of the zones, we now think of reporting in terms of MICs, which gives more indications, and we need more directions. We need to educate our clinicians how to use those reports, and how to, whenever a new antibiotic is introduced in the market, who introduces it? It is usually, the company driven or pharmaceutical firms driven. They are educating. What is the procedure that we have, that once a new antibiotic is launched, who is going to do it? It is our responsibility. We have to take responsibility in our hospitals to introduce a new antibiotic. And as Dr. Walia very rightly said, indication of use of those antibiotics. So right antibiotic at the right time for the right duration should be prescribed. Only then this new antibiotic will ever work. So those are some of the things that we say. And of course, in our hospital now, with the initiatives of our MS, he's very particular about use of antimicrobial agents in the hospital, and now he's given us clear cut targets, that you have to monitor those and what are the outcomes of giving a particular antibiotic, what happened in an MDR case when you gave such and such. So we are modifying our guidelines to that extent, and I think that needs to be done. It is a difficult task. It is a task which needs multidisciplinary collaboration, but we are going to do it. So we hope that we will be able to achieve some kind of success in that. It is a difficult uphill task, but at least that vision and the thought process is there. Yeah.
Well, thank you. That's great. I think you picked up on quite a few points that I think are really it reminded me of a couple of things. Was particularly the challenges we faced in stewardship. This is within MSF, so obviously quite a different context. But that generally medical, even including my own. And even including my own medical background, I don't think in medical school I had such a good enough conceptual understanding of microbiology and antibiotics to be able to really make kind of clear decisions and choices that you spoke a little bit about, identifying focuses of infection, how you think about CNS penetration, how you think about all the different elements. And so we at MSF, we developed kind of a course along with other partners that supported and mentored people in developing that capacity. We also did for IPC, which is something that, again, I'm assuming also is quite fundamental in your approach. And Dr. Valia, in terms of ICMR's position on, you mentioned, of course, I saw the Lancet article you wrote in 2023 about the ceftazidime-avibactam. Is there a little bit more that you'd like to kind of say about priorities around stewardship and your perspective on that?
Thank you. ICMR has been publishing the AMR surveillance data for more than 7-8 years now. We publish a report of almost 1 lakh isolates every year. And what we are seeing is that there is a consistent increase in resistance to broad spectrum antimicrobials. And this also corroborates very well with the other published data from India. One of the recent studies which was published by NCDC, which brought out antimicrobial consumption data from almost 35 government sector hospitals across the country, and is one of the most expansive study, largest study looking at the prescription practices. And what we saw is that we prescribe a lot of broad spectrum antimicrobials which come from the 3rd, 4th generation of cephalosporins, piperacillin, tazobactam, carbapenems, a lot of it. And if we look at WHO's AWARE classification, any country as per that guidance document should be prescribing almost 60% antimicrobials from the access category and rest from the watch and the reserve category. What we see in our country is very different. We prescribe 60% of antimicrobials from the watch and the reserve category, and there are many improper fixed drug combinations as well. So this actually calls for an urgent attention, because the problem with using broad spectrum antimicrobials is that they are encouraging a broad spectrum of pathogens to become resistant. So large number of pathogens are evolving under that antimicrobial pressure. And that is the reason that we need to move in a direction where we have more specific treatment using the narrow spectrum antimicrobial products. Now, if you talk to physicians about it, the challenge of using a narrow spectrum is that, as Dr. Mala pointed out, the lack of diagnostic facilities. So most of the time when the clinicians are treating, they are blind to what they are treating. They don't have a lab report. All they have is a symptoms from the patient, and they are treating syndromically. And in order to treat the patient more effectively, the first approach is that you give a broad spectrum antimicrobial to the patient, which covers a broad range of pathogens. And the brunt of that is that we have very high resistance to broad spectrum. We have MDR pathogens, E. coli, Klebsiella pneumoniae, Acinetobacter. So that is the reason that we
must try to regulate the use of broad spectrum antimicrobials. So the manuscript that the moderator referred to was the new drug which is recently become out of the patent. So there you will see many companies manufacturing it and as a generic product and marketing it. So now what we are seeing is that because we have high resistance to piperacillin tazobactam, doctors are frequently prescribing ceftazidime-avibactam. This is not good for the country. This is not good for the patients, and that is the reason that we published it. And we, following that, we also had a discussion with the drug regulator as well as other stakeholders that we should have a mechanism to regulate the use of these broad spectrum antimicrobials, which are actually meant for serious bacterial infections. MSF was involved in that. GARDP was invited for that discussion, REACT, and many other stakeholders who actually work with the communities as well as the physicians. And there was no difference in opinion. I mean, we had a almost unanimous agreement that yes, we need better regulations to encourage and to implement appropriate use of these antimicrobials, and those discussions are ongoing. But the other step that ICMR, this is the exercise that ICMR does regularly, is that from the physicians we collect the list of inappropriate antimicrobials which are available in the market, share it with CDSCO, and request them to take them off the market. This exercise we have done twice, and quite a few number of combinations they have taken off the market. The recent example was a combination of vancomycin with ceftriaxone. This was available as an injectable product in Indian market, and that was something that we shared with CDSCO, and that was one of the products which was banned. So this is a regular exercise, I think, which we have to undertake. And needless to say that the education and awareness must be integral part of this activity, because it is not the patients who are consuming these antimicrobials, which are many a times injectables, which are many a times prescribed. I mean, only the doctors know about them. So it is the physician community, I think, which must be engaged to address this aspect. Thank you.
Thank you very much. I don't. One of us, so maybe we can all have one. Does this one work? Oh, yeah, there we go. So yeah, no, thank you. And I think that there's particular elements, particularly the community and what we need to do, that I think we should pick up a bit more and go into a bit more later. But actually, now hopefully we've got Raul able to join us now. Are you able to speak?
I've been following the fascinating discussion. Are you guys able to hear me?
Yes. And
Awesome.
thank you to the team for
Brilliant.
fixing the problem. Thank you. It's good to hear
thank
you.
Everyone. Likewise. But thank you for the opportunity to participate on this panel. If it's okay, I can maybe give a brief introduction of GARDP and then kind of talk about what we're doing in India. So GARDP stands for the Global Antibiotic Research and Development Partnership. We are a product development partnership that, on the R&D side of things, partners with pharmaceutical companies and small biotechs, helps them advance R&D on promising molecules or promising antibiotic assets. And then on the access side, which is what I'm slightly more familiar with and I work within, we figure out ways and mechanisms to get those products into market. And in terms of focus, I lead our access strategy for serious bacterial infections, where we're working specifically on new and repurposed antibiotics, focused on dealing with SBIs in an ICU setting. But also at the same time, we have a very strong program on STIs that focuses on drug-resistant gonorrhea for now. I think in terms of the work that we've been doing within India, we've obviously partnered with ICMR had implemented an observational study a few years back, hopefully the results of which would be shared later this year, to really study what is the current clinical practice and how are reserve antibiotics being used currently in an ICU setting. We are also trying to make available a new reserve antibiotic, cefiderocol tosylate, in India, but also across 135 countries, most of which are low and middle income countries. And this comes from a licensing agreement and a partnership that we have with Shionogi Pharmaceuticals, who is the originator of this product. And as a part of this project, we've identified a manufacturing partner in India that's based in Chennai, who is in fact in the process of manufacturing development for cefiderocol. And with the hope that we're able to launch this product in India sometime in 2027. But the time that we have between now and 2027, when we do launch cefiderocol in India, we really want to understand how will a product like cefiderocol, which is a reserve antibiotic, be used in an ICU setting. And again, in partnership with ICMR, under Dr. Walia's mentorship, we have been working to conceptualize almost like an introduction study for cefiderocol, where we're hoping to partner with 2 to 3 tertiary care hospitals in India and understand how if cefiderocol is made available in ICUs and across tertiary care centers in India, how will it actually be used? Now, because this is pre-registration and pre-approval, we're hoping to really, capture these insights in a near real-world setting rather than a real-world setting when it will be available. But that is one way in which we really want to figure out, what are essentially the guardrails that need to be put in place for reserve antibiotics going forward, because we do not want to be in a situation where cefiderocol becomes the next carbapenem, which we saw 10 years within 10 years of launch. There were high rates of resistance to this category of products in India. So that's in short a bit about GARD-P and some of the work that we're doing in India in partnership with ICMR. And I'm happy to talk more about what we're doing on stewardship or what we're hoping to do on stewardship, as well as capacity building for clinicians, in due course. Thank you.
Thank you very much. That was really a really helpful explanation of that. I think that brings us back to what do we need to do, and I think this element of there is a need, which we do also need to do a huge amount of activities to prevent getting more needs like this. But how do we responsibly introduce antibiotics? What measures can we use? And maybe that brings us back to, as we talked a bit about the stewardship, but we can also maybe talk a little bit about, you spoke of diagnostic infrastructure, but maybe we should also speak a little bit about the essentialness of quality assurance and companion diagnostics when it comes to the introduction of new antibiotics. What kind of things do you think practically need to be in place as a way forward to looking at how we could potentially introduce novel antibiotics in your facility?
Absolutely. I think that's very, very important that we should understand, are we looking at new antibiotics first? And when I spoke to the clinicians, they said, yes, very excitedly, expectedly, we are looking at introduction of newer antibiotics, the magic bullets to treat the infections. But I took a back seat, one step behind. I was very skeptical about it because of the stewardship. We have to have our guidelines in place as to who's going to write those antibiotics. And more importantly, how are we going to regulate them? How are we going to monitor their end result as to what they are doing? And as I said, we have given right to the doctors to prescribe antibiotics. So it is so difficult to withdraw that right to a prescription. So they will continue to prescribe. So we have to have a very strong, you know, advocacy, regulatory mechanism to look at newer antibiotics. Then from lab point of view, which you very rightly pointed out, we for any antibiotic that is being introduced, there should be a clear cut guidelines as to how we are going to check the antibiotic sensitivity towards, you know, how do we perform the tests, what quality do we have standards for those and newer antibiotics, are our infrastructure strengthened enough to undertake those tests. Like some are distribution methods, others may be MIC, and that way MIC in agar dilution or in broth dilution, multiple methods. So those guidelines should be clearly laid down before we start using any of those antibiotics, even in trials, if we are introducing them in our country. I think that is the basic that we should actually look at. And newer antibiotics, of course, we are talking about elusive new antibiotics, but we should also think of, you know, prolonging life and preserving the existing antibiotics. For that also, these quality checks become extremely important. So thank you for asking that very important question, because that is the preparedness that we need to have before introduction of any new antibiotic. Thank you so much, yeah, for that question.
Thank you. And I think also that, yeah, and you mentioned also preparatory things I think we've mentioned before, also from MSF's perspective, everywhere we try to put IPC and AMS as a fundamental. Obviously, access to diagnostics, we're not able to do that in all places. And that does, of course, create the data poverty that we have around AMR in a lot of the places we work. But yes, the diagnostic component, I think, is incredibly essential. And maybe, Dr. Valia, we can go back to you a little bit about, again, from your perspective, essential elements that need to be in place. Now we've also heard from Raul as well.
Thank you.
Yes, Dr. Mala mentioned very important point that preserving what we already have while we prepare for introducing the new antimicrobials. Now, the concern is that we are so used to writing indiscriminately or prescribing indiscriminately. So it is very difficult to reserve something and not put it out there in the market. But we have done it in the past. For example, TB program, we have two new drugs, bedaquiline and delaminate, which we have not put out there in the market. It is only available with the program. There has been a downside to it. Many patients were not able to access the drug. Matters went to court. But then that is the only way you can preserve a drug when everyone is writing indiscriminately. That's why antimicrobial stewardship becomes very important. But for antimicrobial stewardship to function optimally, it can help the hospital. But some part of regulatory stewardship, I think, if that supports the antimicrobial stewardship, it can actually help us gain much more. And that is the reason that we need better stewardship around regulations of antimicrobials in our country. Kerala banned the use of over-the-counter antimicrobials few months back, and I think the state gained almost or lost 1,000 crores worth of prescriptions which happen. Now, on one side, we are gaining in terms of reducing antimicrobial prescription, but then there is also loss of revenue of 1,000 crore to the state. It just depends how you want to interpret it. But I think that is why it is important to regulate, to think at least about what kind of processes we can have to regulate the new antimicrobials. You talked about companion diagnostics. They are very common in cancer. In cancer related treatment, you come to know whether the cancer will respond to a particular drug or not. And that's very helpful. But we don't do the same for example, carbapenems. There are diagnostics which are available, which will tell you whether the patient will respond to a particular carbapenem or not. But many a times we do not want to invest on a diagnostic because diagnostics also cost a lot. And, but for as compared to prescribing a drug, which you think as a physician, it might work for the patient. Now, one problem in having a adequate stewardship around antimicrobials is, as Dr. Mala mentioned, diagnostic stewardship. The cost of a antibiotic is many a times lower than the cost of a diagnostic. So how do you navigate this space? So that's why it is, I think, a long-term agenda with the solutions which will come through deliberations, which will come through examples which we set. But yes, we need better strategies around conserving antimicrobials. If we don't use judiciously what we have today, we may end up losing the new products in a very short time span. That's why, to improve the longevity of the products, whether we have them today or which are upcoming, I think the country needs a better antimicrobial stewardship plan in place.
Thank you. And maybe actually we can bring up some of the points that you've mentioned there, because I think the point about the cost of diagnosis versus the cost of antibiotics, and then the cost of, and again, the cost of new antibiotics and access and all of these dimensions. I know that one of the challenges that we also face in terms of having better data and visibility on AMR is if the cost of having the blood culture is so high that it's cheaper to have the antibiotics, of course you won't have the blood cultures people cannot afford to. But this comes into dealing with something that is much bigger than all of our operations. It also comes into the bigger pharmaceutical sector and the challenges that there are there in terms of the cost of things, profit versus cost. I wonder also, Farah, we can ask you to talk a little bit more to that about what is it that's making these challenges, these practical challenges in terms of cost and barriers related to cost, and is there things that we can do about that or advocate for?
Yes, indeed. I think, again, so I take the example of, say, cefiderocol, for instance. It's a sterile injectable. There's a very specific manufacturing process that needs to be followed to make this product. It is a product that is lyophilized in a vial, say, for instance, which is a technology that unfortunately did not exist in India. It exists out there in the world, and the partner that we have identified is actually working with us to set up a fixed dose facility that would have the capability to lyophilize the API in a vial. Now, those are things that obviously take time, but are also highly capital expenditure intensive activities, right? And so what we've also been trying to work with our partners internationally is how can we help alleviate some of these capex constraints and considerations for our partner. And because what we realize is the more we're able to provide that sort of a capex assistance, the more we would be able to impact the eventual price at which the product is getting launched in the country and across LMICs. Right? So that's one way of trying to address this issue by enabling catalytic funding, by building capacity for potential manufacturers that have the necessary capability, but might not have the necessary technology because they haven't been able to, or they haven't been required to have that technology in the first place, right? So I think that's one piece that is definitely very critical and important to be thought through when we look at especially enabling supply for new antibiotics and that fall within the reserve category. And our hope with the cefiderocol access project is to really use this as a pathfinder initiative to be able to try new things, fail fast, but then try again, to really figure out what is that template or what is that framework that works in a reserve antibiotic setting, which can then be replicated for other reserve antibiotics that will be launched in the future, either by Bihari or by other organizations. I think having partners like ICMR and others that we are working with in India and across other LMICs becomes so much more important, because then we're able to almost coordinate and align our thought process around introducing new and repurposed antibiotics to what or to how the guidelines are being shaped, right? Or how the guidelines around appropriate usage are being thought through. So I think that's the other piece that that at GARDP we are looking to do and are already doing in conjunction with in-country partners across 135 countries, say for instance, in the case of Seven Recall.
No, no, thank you. And I think so. Yeah, so I think we're very clear that on the need for stewardship, and I think also maybe going in, of course, we haven't mentioned, obviously, this year's been the UN high-level meeting on AMR. There was a political declaration that brought out global commitments towards addressing AMR that covers many different areas that we've discussed much on prevention, the role of Watson, the role of vaccination, the role of access to healthcare in general, and then the specific challenges that we're facing in IPC stewardship and access to quality assured diagnostics. But I think for all of us now, it's really how will that global commitment then translate into specifics, and also how can we do more with communities and make sure that affected communities are represented and that we're engaging more with that. And I know that that's something that we discussed the other day, and I would just like to bring back around again, because I do think from my experience and from our team's experience that one of the challenges with stewardship is really about expectation of antibiotic as well. It is really difficult, even with the knowledge, if the expectation is that you should be getting an antibiotic or a particular type, whether it be IV, which again might drive your watch versus oral, or a brand named antibiotic, that it's really challenging for clinicians. People may feel that they're being discriminated against or treated differently, and so that this element needs to come in. So maybe I can ask both of you to speak, Dr. Rav, first about how you think we can try to address this really fundamental issue of kind of community engagement when it comes to stewardship as well.
Well, again, very interesting and a very important pillar in antimicrobial stewardship, I would say, is involvement of community, because those are the consumers. They come to the doctors and say, okay, prescribe. So we saw that in COVID times. Everybody wanted azithromycin, whether you're giving it or not. They were taking it themselves and they were demanding that they want this antibiotic, and we did not have any kind of scientific evidence whether it is going to help or not. So community involvement is very, very important. And how do we reach to them? We have to sort of formulate messages which are very simple, that reach out to them. We always tell them, okay, this is harmful for you. Now we should tell them that also tell them that this is more of benefit if you do not take this antibiotic. So those kind of simple messages should reach them. And we have our Department of Community Medicine also sitting here, Dr. Sagar Borkar, and they make a lot of effort for community outreach. They go out to community and talk to them on various aspects, and they are doing a wonderful job. I've attended their this thing, and they give out very simple messages. They make them enact. They do, what we call nukkar natak, that is street plays, to make them understand the misuse or overuse of antibiotics, and that they have to be used on a proper indication. And a lot of work has gone from different organizations, CHEB and others, ICMR funded projects were there, national action programs were there, where they have made they have made those small videos. They have made, some mechanism of delivering the messages in local languages. Now, India is a huge country, and every 10 kilometers, the languages change. So they have now made those messages go out in local languages so that people understand not only the benefits, but also the harmful effects and of both use and misuse of antibiotics. I think that is the way that we reach the community, make them equal partners in our movement of preventing antimicrobial resistance.
Yeah. Thank you.
Thank you. So, contrary to what we like to believe that patients ask for antibiotics, there is a practice of self-medication. Yet, I think when doctor tries to talk to the patient,
about that this situation doesn't warrant antibiotic, the patients do understand, because we know that in a country like India, people still have a lot of faith on uh, doctors or the prescribing physicians. But the problem in our country is that the doctors are overburdened and overworked, and they don't have time to counsel the patient. So if we are able to um, make a convincing case for doctors to have more time to counsel the patients, I think it will help. Other than that, I think the problem of antibiotic resistance is something like climate change. Today, the carbon footprint that we have, we are not able to really understand the kind of impact that it has in future. Similar is our antibiotic use. One dose of norfloxacin or one dose of azithromycin, how it is going to impact the future use of those antimicrobials, it is very difficult to explain such a long-term impact. But yet, I think it is any communicator's challenge how to explain the problem of antibiotic resistance to patients. For tuberculosis, I will give a specific example. There is a one pathogen, there is one very well defined few tests, and there is a well defined program which administers that treatment. How do you explain antimicrobial resistance to community? Do you start with explaining the pathogens? The same pathogen can cause sepsis, it can cause UTI, it can cause respiratory tract infections as well. How do you explain that to the patient? So, those are some. I worked in this field of HIV/AIDS for many years, and we thought HIV was challenging till I started working in antibiotic resistance. So, in the recent discussions that we had with some of people who work in this space, we thought we could take up syndrome wise. For example, typhoid. So many patients experience recurrence of typhoid. They experience treatment failures. Diagnosis is a challenge. Treatment is a challenge. Can we start working around typhoid and use that as a reference point to start explaining the importance of not taking that first dose of antibiotic because it will not give you the test result, not taking the wrong antibiotic because it may cause recurrence? So I think communication is a very gray area for antibiotic resistance. We don't know what to talk to the patients when we talk, because many a times we may be conveying something that really doesn't make sense to them, that okay, if I don't have a doctor in the vicinity, why I can't get better by taking a one dose of antibiotic from a pharmacist who's located nearby? So it is very hard to explain sometimes these things. So communications, I think, will remain an important challenge for us, and that is something where organizations can, like MSF, can really help us understand what will work for Indian countries and Indian populations. Thank you.
Thank you very much. And I think that leads nicely on to what I was going to ask as my kind of final round of questions. And obviously we take some questions from the floor. If anyone has one, do raise your hand. But was what, as MSF, what would you suggest that we try to look at? Obviously, we to kind of optimize our AMR identification and response, really, but also within our operational realities, because I think that is also the big challenge for us, is that it's not always possible to do everything we would like to do. But as you say, understanding better the risks and also where our priorities should be in terms of gaps of data. We've talked a lot about this this lack of visibility, and this is definitely the case for us in many countries. And I don't know if you could maybe just say more about what you think MSF should focus on, and any ways forward that you see.
Oh, fantastic. Now, this is, it brings us hope, because MSF is one organization which can penetrate anywhere. They can go to Gaza, they can go to Israel, they can go to anywhere, any country, any part of the world, they go there. So you have, I mean, like, there are a lot of hopes that we rest on you. And it should be, the community outreach, which is so important, as Dr. Walia has already pointed out, that clear-cut messages should be given to not only the community, but to the doctors also. They, as she said it, the problem is very complicated. But definitely there are solutions to it. How do we make our IEC material, that is education, communication, information materials, so that we can effectively communicate at different levels, at community level, at junior doctor level, at senior faculty level? How do we make that communication which is very effective? And I think, I'm sure MSF can do it. Another area that I think MSF should uh, uh, go into is infection prevention and control, because that forms the pillar of prevention of AMR. It so an IPC, thankfully, COVID-19, the very positive aspect was awareness about infection prevention control practices that should be encashed, and following universal precautions, following standard precautions as they are called now, and following transmission based precautions and preventing infection would be basis of AMR control also. So I can think of these areas. And of course, when we are talking about stewardship, again, I think MSF has a lot of role to play in stewardship practices also. So these are some of the areas that I can currently think of that MSF can encourage. Yeah, thank you so much for that.
Yeah. It is the first time, I think, after this UNGA that we have a preventive based approach for AMR. For a longest time, we were only looking for new drugs and a lot of focus on antibiotic development. But this time in UNGA, very rightly, I think we are talking about prevention, preventing infections, using vaccines optimally, then using the WASH strategies. WASH was, I think, was the buzzword about 8-10 years back, and suddenly it disappeared. And I'm so glad it is back on the radar. And that is where I think we should focus more on reducing the load of infections as such. So once we do that, obviously the denominator will be smaller, and the proportion of drug resistant infections will also reduce. So that's something for those for WASH, for vaccinations, all the interventions are still available. Even the diagnostics we have, we are not really using them optimally for guiding treatment. So that should be, I think, focus for MSF as to how to engage communities to have better WASH strategies, use the vaccines, especially the flu and the pneumococcal vaccine. We hardly use these vaccines to reduce the RTIs, which becomes one of the major contributors to antimicrobial prescriptions in the country. So I think MSF can help a lot in improve on the prevention side, on which there is a lot of focus now, and this will actually contribute a lot to our SDGs as well as the UHC coverage. Thank you.
Thank you. Yeah. I totally agree. And Raul, for you on your side, maybe also think about particularly when it comes to novel antibiotics, what you would think from
Right.
GARDP's perspective that you think MSF can help with.
Yes. So, I think the panelists have spoken very appropriately and very eloquently about IPC and WASH. I think that is very, very important. But, I'm picking up from what Dr. Walia had said previously about AMR not being one single bug, and what that translates to is also the fact that I think there is an unmet need with respect to building capacity for healthcare professionals as well, for HCPs, for doctors and nurses who are maybe not at tertiary care centers, but in secondary and community healthcare centers as well, right? I think that is one place where we see a gap in terms of there being lack of capacity, and hence by the time the patient reaches a tertiary care facility, as Dr. Mala had said previously, they've already kind of gone through the rigmarole of having had a few courses of antibiotics, which were probably prescribed to them empirically, without a lot of diagnostic evidence. And hence, by the time they reach a tertiary care center, they've already developed resistance to a certain class of antibiotics. So there is an acute gap in terms of building capacity, right? And I think that could potentially be especially from a novel antibiotic standpoint, as well as for antibiotics across the AWARE classification. That's one. I think the other piece is around the fact that because it's not a single bug, there aren't any patient groups that really talk about the aftermath of a serious bacterial infection. I've in my interactions with several oncologists, they talk about the fact that a patient might not die from cancer, but the chances of a patient dying from a serious bacterial infection that they've acquired in an hospital setting are also significantly large. And there is only so much that the clinician can do. But the fact that they don't exist patient advocacy groups that really talk about sepsis or serious bacterial infections is also something that can potentially be looked into. There isn't a silver bullet or a single solution for this, but I think if we're focusing on building capacity for healthcare professionals, especially the ones who are in secondary and in non-tertiary centers or non-quaternary centers, as well as thinking through how do we kind of mobilize patient support or advocacy groups to really start talking about challenges with antimicrobial resistance, maybe linking it to other therapy areas, say for instance cancer and others, where the chances of a patient dying because of a drug-resistant bug are also quite significant. In addition to the challenges that they're facing with, say, their treatment, I think those are some of the additional ways, in addition to what the panel rightly mentioned, that could potentially be thought through and looked into. Thanks.
Thank you so much. And is there any questions from the floor? Otherwise, I think right. There is. Do they want my mic? Have you? Yeah. Yeah. Okay. Yes, that's all right. I'm sorry. Yeah. He's got them. Could you, yes, if you could give one question, one short question, sorry, because we've run over time. Apologies.
As the panelist already mentioned, that there's a huge cost when over-the-counter sales of antimicrobials are banned, as which was seen in Kerala to public to the government treasury. And then it was also mentioned that the blood cultures will not be affordable for every patient. But the thing is, like we are comparing it with climate change. So there has to be cost-benefit analysis. Whether it is worth it or not, if the government takes upon the expenditure of the every required blood culture and the whatever the fallout that happens with banning of drugs. So has ICMR done any cost-benefit analysis in the future? Is it worth it or not? Because the time to take a decision is right now.
What is that? Cost benefit. Yes, there have been cost benefit analysis of investment in diagnostics, but they have been limited to the point of care diagnostics. For example, a UTI, POC, or many others, those have been done. And the analysis has actually shown that it makes sense to invest in diagnostics in terms of the overall expenditure that is spent on the treatment. To answer your question on the blood culture, Yes, the cost of blood culture is very high in the clinics and in the hospitals, but then the government also has a national essential diagnostic list and the free diagnostic initiative that makes it mandatory that every district hospital must have a culture facility. So many labs are in the process of upgrading their labs, and they will be able to provide the blood culture free of cost to their patients who visit the district hospital. And that, I think, will address this problem that the blood culture is cost is high, because these district hospital labs will do that free of cost. So we are progressing in that direction where we are trying to make these diagnostics more and more affordable.
Thank you very much. I'm afraid if we can we'll take the other question offline if you want to come up and you can ask us here. And just to finish there, this is just the beginning of conversations. There is a whole scheme of work that is being done with MSF led by Himanshu in front of me here, and the partner project that will look at all some of the different elements that we've raised today. But thank you very much for your time, and I will let everyone go to lunch.
Thank you very much for an incredible panel, I think, really, and lots of discussion generated. So please do follow up with the speakers whilst we have lunch. Ladies and gentlemen, we have an hour for lunch. We are now half an hour over time. So I would really encourage you to come back on time so we can make sure that we don't kind of bleed further into the evening. So please come back in 1 hour, and lunch is served outside.
देखिए मेरे को पता नहीं बीमारी कितनी हद तक कम हो चुकी है। दुनिया की बीमारी इतनी हो गई है, कुछ को हो गई है। Nada, सिर्फ हमारी बीमारी की बचा नाम है पेट को फिक्स पता नहीं तीन बार नहीं लगा और तकरीबन और जो बात है कि ये मिलता है वो वायरस तो किन किन कारणों से होता है इसको हम समझाने की बस कोशिश कर रहे हैं मैं कुछ बीमारी नहीं अगर छूने की पड़ता है मैं छूने की समझ कोई तो भेदभाव अपने में so had this proper information would have been given to them right at their stage. I think the mental stress that the entire family had gone through, maybe the severity could have been way less than what it was, at the onset of the medical condition. That is why we make sure that there are support group sessions held on a weekly basis. From the week, correct? The treatment and the schooling that we provide is not going well. So we always request our patients to use strong. The humor should be very high. Because we are not culture of experience. We are taking everything that is said with someone to make the life fit. Changing. The time is coming connected. It's also clear that there is some enlightened temperature and slide. More frequent and intense extreme weather events such as very often even now, flooding and loss. This will impact on meaningful issues like food and water. This in turn will also affecting changing behavior and people who are sick because of pollution. And people that start leaving their homes, and some families who have running into control to them. All existing injections seem to reinstate the change of the blood. And he can only anticipate when they have the right effect. And we need to adapt the way it works ready to respond. We learn from experience that is the most strong when we even nutrition. Making them have many hands. We know it because the planet is in the knowledge. We now look for intelligence and objectives in the treatment. We have chosen leaders who balance rights and development. It focused on the changes that humans are making to education. These changes really are lifted in natural choices. Having climate change in usually air and waves. This in fact is the global create and the ambiguity. It means we will see structures of construction. Resuming complete physical levels. It means we may see a new
and also the real moment from the video. Nutritionally change. I mean, when you are looking at how the drinking and the confusion is changing. So the alcohol prevents the understanding of the well-being of the planet. So how we thank you.
Yeah, yes, yes. But also, as Humanitarian, we are concerned to preventing every household regulating sacred. We do know that the environment has needs to worse than the existing. So it's part of who we are, basically. As you know, Larry, but you see introduction to environment in energy. If the water is connected, if you do that, right. But if the direct environment, issue, the advocate there.
Tout le temps, de regarder toutes les interventions avec en intégrant un fils santé planétaire, c'est se dire, OK, donc au niveau climatique ici, il se passe quoi? Est-ce que les sécheresses sont plus sévères? Est-ce que les pluviométries sont plus sévères? Est-ce qu'on a moins? Mais quand il y en a, elle lave que le sol. Est-ce qu'on a une limitation? Qu'est-ce que ça implique pour les populations? C'est toujours des éléments qu'on a regardés et sur lesquels on ne s'est pas nécessairement penché de façon systématique. On a besoin de savoir ça. Parce que ça va plus les besoins médico-opérationnels sur les populations. Comme probablement être mis sur de ces faits. L'objectif est de faire ce qui se passe. On va dire que l'innovation qui va être c'est ça, beaucoup plus évidemment, que de faire une difficulté, on va garantir, on met à disposition les services de temps, et pas par rapport à des questions.
Our medical action is not to the veterinary action, but yes, and I can buy this. Our medical action does be implemented in a way that generalize the picture. Our medical action institute is where we've been defending action for us in guidance. Deep down, clinical Wales is the best pathway to an environment. Take care of before, but we also have to avoid making. So we have a double responsibility of presentation stories tell, but maintaining and tell to avoid people getting smart. Running hospital, nationally, larger yeah, reviewing our way of working in those know-hows to be able to provide the care. And staying on speed, but trying to bring it in a way that doesn't have you to attract.
Moi, qui reviens dans les populations qui passent mais nous, dans les situations, est-ce qu'il faut est-ce que nous continuons pas oui, la différence sur évidemment, ça me fait que les noir, c'est rien. Donc, vraiment, c'est une mal. Je sais plus, est-ce qu'on fera la nuit? Non, c'est on va faire avec des émissions, des amis, c'est
We need to care for our patients in a way And that's not one thing, and they're doing this. And with doing that, we need to take away our responsibility to be the most environmental friendly economic decision.
Thank you.
Balance is breaking. Our global environment is changing. Temperatures in sea levels are rising, and we'll see more frequent extreme weather events, heat waves, cyclones, and floods. Before seeing the homes, we know that the most vulnerable individual is affected.
We do know that the environment has we are seeing now that because the mosquito now is like we see introduction of mosquito transmitted illness on the in urban setting in a larger scale. If you later change temperature, if you can figure it out, the direct research environmental system is the vector to push the drain.
I'm very helpful to know. It focuses on the changes that humans are making to the environment, impacts that has on human costs. These changes to the environment destabilize the natural ecosystem, causing climate change and pollution in our air, soil, and rivers. This, in turn, affects the water we drink and the air we breathe. It means we will see disruptions to our food production and changing patterns of disease, such as malaria. It means we may see new diseases we didn't know before, and also the re-emergence of other diseases. Our health, and well-being of our lives, and the well-being of the planet depends on how we act. It is all.
We can kill people, but we also have to avoid making people sick.
We can learn to down sign become people. It's hard to create a new future. Andrea, can you hear us?
Hello. Hi. I can hear you. Hello.
Can you hear us?
Can you hear me?
Thank you.
Hello. I can't hear you properly. Hello.
Okay, ladies and gentlemen, we will be starting in about 60 seconds. I think most of you are back on the room. I think people are back online. Just give you 60 seconds to get yourselves comfortable. Ask anyone who's outside to return to their seats. I'll just wait for 1 minute. Let the poor gentleman serving water finish. All right, I think we can get going. If those of you who are sitting next to open doors, if you could close them, brilliant, so that our online audience doesn't get all of the extra noise. Brilliant. Okay. So we have a real treat today. Often that post-lunch period can be a bit of a slump, but we have a really energetic, wonderful speaker with us this afternoon, talking to us about the climate crisis and health, which has come up a few times over the course of today. And just to put this within a sort of a humanitarian perspective, whether unseasonal floods and outbreaks, whether it's drought fueling famine, whether it's conflict over limited resources, the climate crisis is very much a humanitarian crisis. Of the 15 nations most vulnerable to climate shocks, 12 have an ongoing humanitarian response plan. These are deeply intertwined issues, and it's a very critical issue for those of us both in MSF but also within the South Asia region. And so we are really pleased to welcome Shweta Narayan to talk to us today about climate crisis and health, the role of the health community as advocates. So Shweta is an international climate and health campaigner, previously for Healthcare Without Harm, and she's now campaign lead for Global Climate and Health Alliance India. She has more than 2 decades of campaigning and advocacy experience in environmental justice issues, and her work focuses on providing legal, media, and scientific research support to the residents of pollution-affected communities and workers exposed to toxic chemicals. She's worked with several subnational governments and health professionals in developing climate and environmental health policies. I think she's going to be a really challenging talk for us for those of us here in the room and online. Shweta, welcome. So while my slides load up, thank you everyone. Good afternoon. It's a tough task to go after lunch, and I'll try my best to break the post-lunch slumber. My name is Shweta Narayan. For those who don't know Global Climate and Health Alliance, we are a coalition of over 200 organizations working on climate and health. Our agenda is to bring health into climate conversations and climate into health conversations. Yes, the climate crisis is not an easy topic to discuss. And obviously, I mean, it has come up in reference today. What I'll try to do with my presentation, I have tried to split my presentation into 4 parts. We'll look at the reality. We'll talk about the root causes of the reality, because as medical and public health community, we must look at what is fueling this crisis. We'll look at some of the impacts, which has already been talked about quite a bit, and then we'll focus on solutions. What can the medical and public health community do? And why should the medical and public health community act? So, part one, the reality. Now, before we even talk about the climate crisis, I think it's important to recognize that our planet, our home, is facing unprecedented challenges. We are facing a triple planetary crisis. That means we are losing our biodiversity, there's pollution, and then the climate is changing. In terms of just quick glimpse of how severe this crisis is, according to the Intergovernmental Science Policy Platform on Biodiversity and Ecosystem Services, we are witnessing a rapid decline of nature, could lose over 1 million species within decades. Now, how significant is this crisis of biodiversity? And it's important to mention the biodiversity crisis, especially right now when the biodiversity COP is underway in Colombia, where governments have come together to discuss and plan a strategy to protect the biodiversity and prevent the biodiversity loss. The significance of this loss is based on just one observation from the United Nations Environment Program. UNEP states that in context of the Sustainable Development Goals, loss of biodiversity is undermining efforts on 80% of assessed SDGs targets, making it even increasingly more difficult to assess progress on poverty, cities, climate, water, health. That's the impact of the interconnection of these crises. That's the impact of the biodiversity crisis that we're facing. And then, of course, there is pollution. Speaking about pollution in Delhi, I don't think this is a subject very new. It's air pollution, water pollution, land pollution is further complicating this crisis. Somebody was just telling me over lunch break that the air quality index in Delhi is over 400. Which is if regulatory mechanism was adept enough, this would be a hazardous situation which would require evacuation. That's the status that we're talking about. The World Health Organization safe levels of PM 2.5 exposure is between 5 and 10 micrograms per meter cube, and we are at 400 right now. Air pollution increases the risk of cardiovascular and respiratory diseases. We have water pollution that increases the risk of transmissible diseases like cholera and typhoid. Again, look at statistics. According to UN estimates, 9 million lives were prematurely lost in 2019 because of pollution. That's 1 in 6 deaths globally. We know, and increasingly we see scientific information that shows that toxic chemicals have invaded our food systems, our air, our water, even our bodies. Microplastics are being found in fetus. Microplastics is in practically every part of human body. Now we can find plastics, and that comes back to the question of what is fueling this crisis? And the third element of the climate crisis is very directly related to what is fueling this crisis. We know, and I would address climate change as climate crisis because that's the magnitude of the problem we're facing. Also because climate change was a term that was given to this problem that we have by fossil fuel industries to make it more palatable, make it less scary than it is, and just to make it softer. It is indeed a climate crisis. And as Bhargavi mentioned, increased episodes of extreme weather events, more frequent extreme weather events. As we speak today, again, on the east coast of India, Cyclone Dana has wreaked havoc. Last week, we saw what Hurricane Milton did in Florida. There is no dearth of evidence. In fact, I was trying to put together some slides about the magnitude of the crisis, and I do want to mention one thing in this context. It's often assumed that climate crisis is something in the future. It is not in the future. It's our lived reality today.
And it's important that we acknowledge and communicate this on a daily basis. This is not a crisis in the future. This is happening around us. And I tried to, this is not by any way a comprehensive list, but when I started looking at what were these crises that in 2024 we have experienced, here is the list. And again, it is not a comprehensive list. We are in October. We still have 2 more months in 2024 to get by. We have floods, we have droughts, we have typhoons, we have landslides, wildfires, heat waves. I live in Kerala. A neighborhood very close to where I live faced the worst landslide in its history, in the history of the state. And the magnitude, 3 townships were wiped away. I think that is our current reality. So climate crisis is not in the future. This is happening now. And this must be acknowledged and must be acted upon now. So yes, this is the reality. This is the problem. What is the root cause? And let's come back to the root cause. And I think the root cause that is triggering climate crisis is fossil fuels. Coal, oil, and gas is contributing to this mayhem that we are experiencing today. And when we think of fossil fuels, let's also remember that the impact of fossil fuels on our lives, on our health, is throughout its life cycle, from the stage of exploration to production, consumption, transportation, disposal. At each stage, fossil fuels have a absolutely devastating impact on human life. And it's not just the each stage, each life, throughout the life cycle of fossil fuels, but also throughout the human life cycles. So from fetus to elderly, they have an impact. And in next few slides, I'll kind of break this down further. Now, of course, the most common impact of fossil fuels is air pollution. And air pollution that is largely caused by the burning of coal, oil, and gas, according to estimates now, cause 8.1 million premature deaths annually. In terms of economic cost, because we have, through the day heard about health impacts. In terms of economic cost, according to a World Bank estimate in 2019, air pollution cost $8.1 trillion US dollars, the loss from air pollution. That's 6% of global GDP. That's the volume of the economic cost from air pollution alone. And what I want to share with you, that from fossil fuels, air pollution is not the only impact that we see. This slide basically attempts to showcase the documented health impact associated with fossil fuels. This is well-established research. This is not what I'm trying to say over here. I'm just pulling out from the research. And if you look at the impact from cardiovascular system to neurological systems, so respiratory system, carcinogens, neurodegenerative disorders, adverse birth outcomes, every part of human body and every stage of human life cycle is compromised because of the effects. And this is toxic chemical effects of fossil fuels. And also, let's take a minute to understand the scale of this problem. These toxic chemicals that are emitted during the life cycle of fossil fuels stay in the environment for decades. So the health impacts, and you're all scientists, you're all doctors and public health professionals. I know this would not be new to you, that when chemicals affect our systems, the effect is not immediate, chronic, or short-term, but it's intergenerational. So that's the magnitude of the problem that we are talking about. And these chemicals stay in our air, in our water, in our systems, and the industries will shut and leave, but they leave the toxic legacy of chemicals behind that communities pay with their health throughout and sometimes for generations. That's the scope and scale. And by no means I'm trying to scare anybody, but the situation is pretty scary, and we must acknowledge that. Now,
I've so far talked about the chemical harms of fossil fuel industry. I think it's also important to understand that it's not just the chemicals that has an impact from fossil fuel industry. It's also their social harm. The behavior of fossil fuel industry has a very tangible health outcome or an adverse health outcome. Now, these are some of the examples of human rights abuses, indigenous marginalization of indigenous people, their gender-based violence, their sexual violence, substance abuse, and there is enough evidence now that we can see from places that have fossil fuel infrastructure will report high levels of substance abuse, high levels of trafficking, high levels of sexually transmitted diseases, as opposed to the same city, another part of the city which does not have the fossil fuel infrastructure. In fact, there is recently I heard from a political representative from Los Angeles who was talking about the disparity that is so obvious in parts of LA where they have fossil fuel infrastructure and where they don't, and the average life is 10 years average life of people is 10 years lesser in neighborhoods which have the fossil fuel infrastructure. So that's the kind of disparity we are talking about. And then there is climate risks, and this is sort of like the dangers of fossil fuels is a situation that keeps giving. There is chemical harm, there's social harm, and then there's climate risks. Most of the fossil fuel infrastructure is located in coastal or low-lying areas. And that means that in an event of extreme weather events like cyclones, hurricanes, and floods, they are a risk to their communities. We have, as early as 2005 with Hurricane Katrina, one of the impacts that happened was an oil spill. That was in 2005. We are in 2024. The spill has still not been cleaned up, and the people are still affected because of that contamination. Increasingly, and I will request you all to do this in your spare time, just Google extreme weather events, floods, and oil spills or toxic releases, and you'll find many stories that will pop up which will correlate to these extreme weather events and the vulnerability that fossil fuel infrastructure poses on all of us. The fourth, this is a situation that keeps giving us different complexities. The climate crisis. We all know that fossil fuels are the biggest drivers of this climate crisis. We're seeing increased frequency of disasters, extreme weather events. We're seeing droughts. We are seeing floods, landslides. All of the stuff that I've just talked about in the earlier slides. We are also seeing shifting pattern of diseases. I mean, why the health community? We are now documenting diseases that were not previously documented in certain geographies. The shifting pattern in vector-borne diseases, the shifting patterns in infectious diseases. I was talking to Dr. Yogeshwar in the break, and I was like, scrub typhus, it has a correlation with warming temperature. And we need to document that because there is a clear relation between what we are seeing in our clinics every day and what we are seeing in the planetary situation around us. And it means more incidence of diseases. That means requirement for a different kind of a health system to tackle those crises, to protect people. That means different kind of medicines and drugs related to combating those diseases. It completely changes the way we design and run our health systems, and that's because of the climate crisis, and that climate crisis is because of the fossil fuel crisis. So, going a little bit more into impact, I think air pollution, extreme weather events, droughts, floods are extremely visible, extremely immediate. What's also happening along with that is water scarcity, food scarcity, malnutrition. We had panelists talk about the need to highlight WASH in antimicrobial resistance. We have communities that don't have access to clean drinking water, or coastal communities where the water sources have been destroyed because of salination of drinking water, and that's bringing its own complication of health problems. So we are seeing a complete upheaval in terms of health impacts as a result of the climate crisis. Now, I want to touch upon the point that Bhargavi mentioned in terms of the inequities of this crisis. The most marginalized people who have least contributed to this problem are facing the worst impact of the crisis, and that's a reality. This is an analysis of Global Climate Risk Index, which shows that 8 out of 10 countries most vulnerable to climate risks are low and middle income countries. These are countries that have least resources, least capacity to cope with this crisis. When they are battered by one extreme weather event or one crisis after another, they don't have the time to recover before they are battered again. And one case in point is Pakistan, where 2022 floods, and according to the National Disaster Management Authority of Pakistan, the 2022 floods impacted, destroyed or damaged 10% of their healthcare facilities. 10% of their healthcare facilities. By the time they had still not recovered from the flood, and you had 2024 heat waves that further compounded the crisis. That is the pattern that we will increasingly see in countries who don't have the resources, who are really vulnerable, and who have not even contributed to the problem. There is a there's a World Bank report that estimates that climate crisis will push over 100 million people back into extreme poverty by 2030, and much of that reversal will be because of negative impacts on health. That's why it's absolutely important that we collectively talk about this crisis and talk about ways in which we can tackle this crisis. Now, just coming back to the point that health systems are needed the most when people are in crisis. But in climate crisis, we see that the impacts that they have on health systems, they make them so dysfunctional that they're not even accessible when people need them the most. This is a picture from Chennai. In Tamil Nadu, I used to live there. And this is from the 2015 floods, when hospitals were evacuated because they were flooded. And patient care was suspended. Critical care was suspended. Medicines were destroyed, damaged. In 2018, in floods in Kerala, the damage and destruction to some of the health facilities were so much that it took years for them to recover. And that's the reality. So climate is a health crisis. It's also a crisis to the health system and healthcare services. And that's why it should be our business to talk about climate crisis. So then, what's the solution? And I would like to spend some time talking about it, because in my opinion, there are two-pronged solutions. One is the transformation of healthcare sector itself. And why the transformation of healthcare sector? Because while health facilities are at the forefront of responding to the crisis and are also affected by the crisis, it's a paradox, because the healthcare's own behavior, their own emissions, contribute to the climate crisis. Now, according to a research, the healthcare sector globally contributes to over 5% of global greenhouse gas emissions that trigger the climate crisis. This data, this number, means if healthcare globally were a country, it would be the 5th largest emitter. So, if the purpose of health community is to heal people, they cannot be contributing to the crisis. That's where the transformation of health sector begins. That's where health sector needs to incorporate low carbon care in order to reduce its own contribution, its own footprint into this crisis. We also need to build resilient health systems that can withstand this crisis and that can operate, especially when communities need them most. And that would mean powering health systems with renewable energy so that they can operate even when the grid fails. That would mean building capacity of healthcare workers so that they can respond to emergencies. That would mean early warning systems. We should have advisories. We should have early indication and alerts in case of any adverse episode. A lot was debated about the landslides and the failure of the early warning systems earlier this year. We need coordination. This is the health sector needs to coordinate with other departments, other local governance structure in order to respond to the crisis. And so we need to build low carbon, climate resilient healthcare. Even more important than, I'm not trying to equate one with another. It's important to build low carbon, climate resilient healthcare if we were to provide care to people in crisis. At the same time, I would say it's not enough, just enough to build low carbon, climate resilient healthcare, because we cannot adapt our way out of a 2-degree or a 3-degree warming world. That means we need to address the root causes. And we have within us the health community is a very powerful, trusted community that can take on this task of addressing the root cause of the crisis. Because there are other sectors and their behavior also have an implication on health. So the healthcare sector can be transformed, but if other sectors contribute to the crisis and to the adverse health outcomes, the burden on healthcare sector will not reduce. And that's where the role of health professionals come in advocating, in addressing the root causes of this crisis. Also because health professionals are among the most trusted messengers, and this is the data. This is the Global Trustworthiness Ranking from 2023, which puts doctors, I would not just say doctors, I would say doctors, nurses, frontline responders, community health workers in this category who are among the most trusted. And it's not very surprising that politicians generally are the least trusted in this ranking. So that's the advantage that the health community has. More importantly, and I'm often asked this question, climate crisis, climate change, aren't the policymakers responsible for taking action? What role can health community really play, right? Now, and this is my favorite part of the presentation, by the way, towards the end of it, saving the best for the last. There is a rich history in the health community of over 150 years, where the health community has played a very significant role in shaping the society the way we are today, in shaping democracies the way they have evolved. And I would like to take 3 case studies of that rich history and invoke those case studies to make a case that why health community should advocate for in the context of climate crisis. This is a case study from 1854. With cholera. And I will not go into the details because I think all of you are experts over here. But it's surprising that before 1854, before it was established that cholera was caused because of contaminated drinking water, it was popularly believed that cholera was caused because of stinky odors. Yes, you were surprised. So was I when I was researching about it. But it was a public health medical epidemiologist who actually mapped out the disease pattern in the communities by talking to people who were affected, by talking to community members, to talking to religious leaders, to find out that, and this was pre-GPS geotagging exercise, found out that the contaminated source of water from the hand pump in Broad Street was the source of disease. And symbolically, there was a lot of resistance to this idea. There were a few years of advocacy around it, but symbolically, the hand of that hand pump was removed, and that pump is still there today as a living example of what the role health community has in advocating for better health, better public health. And this was not it. The Sanitation Act, the urban planning, that followed, the laws that followed, were a direct consequence of this data-based, local, community-based advocacy on public health. So that was 1854. Evidence from the communities influenced what Public Health Act, the Sanitation Act, the Urban Planning, and also influenced in holding the companies that were contaminating drinking water accountable in 1854. My second example is from the 60s, which is occupational health example. With black lung disease as a severe issue among the coal miners. And it was interesting, again, another shocking fact. A lot of the coal mining companies were actually saying that black lung disease was good for the coal miners because it prevents tuberculosis. This life-threatening disease was being promoted as something okay and good for the coal miners. It was 3 doctors led by Dr. Donald Rasmussen who worked at the Miners Memorial Hospital, who looked at over 40,000 lung x-rays to come to a conclusion of how dreadful black lung disease can be, and their data, and that data was not just limited to the research that they did in the hospital, but with that data, they informed, they educated the coal miners, they even joined the coal miners in the picket lines for asking for better policies. They also testified in courts and senates and were instrumental in the Black Lung Disease Act of 1968 in US. My third example over here, which is, and the reason why I'm taking a diverse range of examples just to show the role that health community can play. This is from the 1980s with the International Physicians of Prevention of Nuclear War, the peak of Cold War. A cardiologist from US and a cardiologist from the erstwhile USSR came together, recognized how serious and dangerous the threat of nuclear war can be, and in the health community reframed this political issue into a health issue, mobilized thousands of doctors around the world, so much so that in 5 years, in 1985, they were awarded the Nobel Peace Prize. And the citation clearly states that converting or reframing nuclear crisis and nuclear war into a health issue was the reason why we were able to avert a catastrophe and why they need to be recognized. Doctors, what were they talking about? Nuclear war, right? So doctors, why shouldn't, and health professionals, why shouldn't they talk about climate crisis? It threatens the very existence of life on this planet in our communities. I think if anybody who has the mandate to talk about this crisis, it's the health community. So just quickly, the elements, and I think from the meta-narrative to some of the actionable points, some of the commonalities in all of these movements that we saw were the presence of evidence-based knowledge, education of impacted stakeholders and public, legal action, policy change, cross-social solidarity, mass mobilization and support. That said, I'm not expecting everybody to get out on the streets and start rallying. The health community has a role. We might not be leading all those movements, but we have evidence that we have from our clinics, from the communities that we are serving. That evidence can be used to strengthen community movements, grassroots movements, civil society movements. And that evidence can also go back into policy making with evidence, with science and evidence informing policies that are progressive, that demand climate action. I would end with saying that health is a very powerful tool. And it's a very important and a shared concern. It's an argument that can bring a diverse group of people together. And we are looking upon the healthcare professionals to lead action to tackle this climate crisis. Our lives, our children's lives, and our future depends on it. Thank you.
Thank you so much, Shweta Narayan. What an incredible call to action for us all. Now, we are running quite over time, so I'm going to go very swiftly to the next session, I'm afraid. And a concept that, and can I invite Dr. Aqsa Sheikh to come? please, and all the other panelists for our next panel, which is on health inequities, barriers to healthcare access amongst populations vulnerable to structural violence. So that's Dr. Bhavya Fernandez, Antara Das, Shireen D'Souza, and Dr. Sankalpa Satapathy. So a concept that has been woven through many of our sort of sessions today, including the keynote speaker, is that of structural violence, where some social structure or social institution may harm people by preventing them from meeting their basic rights or needs. This is an issue often overlooked by humanitarian organizations, and I'm really grateful that it's being highlighted in our agenda today. So I hand over now to Dr. Aqsa Sheikh.
Thank you, and a very good afternoon to everyone. And it's really a pleasure that we are having a discussion on a very vital topic, which is cross-cutting across all the themes of health inequities and how the structural barriers that affect the marginalized communities are leading to the decreased access to healthcare and how that is unjust and inhuman. And we know that when it comes to health access, there are a lot of factors and markers of our identity which determine our access, whether it is sex, gender, our sexual orientation, our ability, the languages we speak, and so on. But it's also very important to understand that these are also intersectional, and we do not have just one identity of, let's say, being a person with disability or a woman or a transgender person. But we may have multiple identities, and they may compound the inequity further. So today we'll be focusing more on the gender aspects. We'll be looking at the health inequities which are due to the factors of being a transgender or a gender diverse person. We'll be looking at women with disabilities and how that experience affects their access to healthcare. And this is something which is very important in the context of Asia and especially South Asia, which has a cultural aspect or social acceptance of transgender, hijra, kinnar communities and other social and cultural identities of transgender persons. Or how disability is often looked at a very different lens when it comes to South Asian communities from an angle of charity rather than as a rights-based issue. Another important aspect is that India is one of those countries where we have a law for transgender rights, which was enacted at the same time when we were hit by the COVID-19 pandemic. And we also have rights for persons with disabilities. And while we have rights and legislations in place, we also need to see how the promise of healthcare access is being translated into. So we'll be looking into that. And also very interestingly, the research papers that we'll be looking at today are looking at, not HIV or STI or the typical focus areas which are associated with high-risk groups like transgender communities or men having sex with men. But the focus is now on mental health, is on non-communicable diseases, the lifestyle risk factors, and so on. And a very important, underlying question that all of you should ask is that who should be doing the research with the transgender community or with the disability community? We all need to look at our own privileges and see, as an able-bodied person or maybe as a cisgender heterosexual person, do I really have a right or the tools or the right intent to do research with the trans community, or how we can empower the communities to determine their own research areas and do that research, and how we can make the research more useful, and how at the end of it the lives of these communities become better. So with all those questions and perspectives, we'll now look into the presentations by our 4 panelists today. The first one that we have is by Dr. Bhavya Fernandez. They are a research officer with the State Health Systems Resource Center, Kerala, and they'll be speaking on risk factors for non-communicable diseases amongst the transgender community in Kerala. Over to you, Bhavya.
Very good afternoon, and thank you so much for the opportunity to be here today.
This work that I'll be presenting is actually based on my thesis, which was done under the guidance of Dr. Atal Goitande. So, as we all know, trans people, they're persons whose sex, which was assigned at birth, is incongruent with the gender that they personally identify with. And generally, across the globe, trans people are considered to be a very marginalized community. So, where I'm from, which is the South Indian state of Kerala, government is actually doing a lot to make society as such more inclusive for trans people. However, because of the largely heteronormative way of society, they're still very marginalized. So even when it comes to research, research in the trans community is mainly limited to like sexual health or mental health. So what we wanted to do with this study was one, the first objective was to determine the proportion of trans people who had risk factors for non-communicable diseases. And the second was to determine the barriers that trans people faced when accessing healthcare. It was a mixed method study with a quantitative aspect being a cross-sectional survey, and the qualitative aspect was done with in-depth interviews among self-identified trans people above the age of 18, and we had requisite ethical clearance from Sri Chitra Institute. The sample size for the quantitative aspect was calculated to be 120, and for the qualitative aspect, we did purposive sampling of 13 trans people. So how we went about this study is we had multiple conversations with trans people, activists, community-based organizations, and departments such as the Social Justice Department and National Health Mission. Based on these conversations, we chose 3 districts from Kerala to conduct the study. And we prepared a structured interview schedule, which was shared with the community members based on their feedback. So it was an iterative process. Based on their feedback, we made multiple corrections till both parties were happy. So in the 3 districts, we approached the community members at multiple venues where the community was gathering, like medical camps or other festivals or events, or even in their houses at some time. So talking about our results, the mean age of our sample was around 33 years. Majority of the participants were trans women, and majority lived in urban areas of Kerala. Only 31% were staying with their families, and the respondents faced a lot of discrimination, even if not from their immediate family, from the extended family, which led them to stay at different places. 60% had an education of high school or below, and this is a very significant finding in a state like Kerala, which is actually renowned for its educational achievements. So many respondents faced discrimination at school level, which led them to drop out, not just from fellow peers, but also from teachers and other higher authorities. 67% were occasional earners or unemployed, and many reported facing difficulties in finding jobs. So the first objective was to determine the proportion of trans people with NCD risk factors. Here what we did is we compared the proportions that we got from our sample with a study that was previously conducted in the cisgender community in Kerala. And as you can see from this table, all the modifiable risk factors like tobacco and alcohol use is quite higher in the transgender community as compared to the cisgender community. Even the metabolic risk factors like being hypertensive or diabetic, the proportions are almost the same, but the mean age of our sample was almost a decade younger than the mean age of the cisgender sample. So both tobacco and alcohol use was around 40%. It was more or less like a maladaptive coping mechanism. So, and many people also were forced into, especially people who were in sex work, they were often forced into it by their clients. Majority had a very poor diet. They did not get the recommended fruits and vegetables, either because of financial reasons or because of personal preferences. Physical activity, only 44.2 were physically inactive, which was measured using the GPAQ-2. Here also, it was difficult for them to go, even if it was just a walk or going to the gym. Because of the discrimination, the community members found it difficult. 26% and 10.8% were overweight and obese respectively. 30% were hypertensive, 18.3 were diabetic. So now we move on to the second objective, which was to look at the barriers that to healthcare seeking that trans people faced. So what we did is we divided the barriers into those within the healthcare system and those outside the healthcare system. Within the healthcare system, there were infrastructural barriers such as inadequate toilet facilities, which was reported by around 39% of respondents. Forms were another issue because earlier most forms had just two options, but now slowly that change is coming about. A third option has been added. There were also, the government of Kerala has actually established transgender clinics in certain government hospitals, but there were many shortcomings reported. The functioning was very sporadic. And there were also barriers due to personnel. Almost 80% of respondents felt that healthcare providers were inadequately informed about trans people, and 55% felt that they were not friendly enough to trans people. So they were asked very uncomfortable questions, like things like, okay, can you have sex like a normal person? Those kind of intrusive questions the community members often faced. 42% respondents had faced discrimination in the past 1 year at a health center. And this discrimination, it presented in different forms. It could either be like a rushed consultation, in some cases, delayed consultations, or even sometimes outright refusal of treatment. Only 26% had a regular doctor. And this again was difficult for the community members because they had to keep opening up to different people every time. Demeaning looks from the cisgender community were also very hard for the community members to stomach. There was no protocol in place for the treatment of transgender people. So in case someone had to be admitted to a hospital, there was always a confusion of whether, do you admit him in the male ward or the female ward? And also barriers to accessing mental health care were reported because government hospitals were way too crowded, so they didn't get the space that they needed to talk to the doctors, and private counseling was often way too expensive for community members to afford. The barriers outside the health system, the first one was financial issues. 84% of them did not have any active health insurance. And the government, the Social Justice Department actually provides reimbursement for sex reassignment surgeries and hormone therapies. However, this reassignment is reimbursement is provided only after the procedure is done. So what happens, like one trans woman that I spoke to, she was an IT professional. She was making good amount of money. But because she had to cough up that initial amount for the surgery, she actually started doing sex work just to make up that amount. It's not because she wanted to, she just had to do it. There were also geographical barriers. So in Kerala, how it is, only few centers have services such as SRS and HRT. So people have to travel long distances, and this again adds to the direct and indirect costs. Some respondents also had a fear of side effects of modern medicine, so many used like natural remedies or home-based remedies. This, to the best of our knowledge, was the first such study in Kerala to look at NCD risk factors, and the mixed method kind of helped us to understand the community members better. The limitations were that it was not a random sampling, and social desirable bias could also come into play. So some actionable points from our study: we need to have more awareness classes, opportunistic screening, and formation of peer support groups for the community. It's important to include more content on the health of transgender people in the medical curriculum, and also to have nodal contact people at every government hospital. And finally, we need larger, more representative participatory research studies. Thank you.
Thank you, Dr. Bhavya. We'll be taking the questions towards the end, but that was really very insightful to look at what are the barriers that trans community members face within not just their households and society, but also the healthcare systems where they go for healing themselves. We'll now move on to the next presentation, which is by Antara Das. She's a psychological counselor from University of Dhaka. And she'll be speaking on the association between the contemporary societal experiences and mental health conditions in Hijra community, a case study from Bangladesh. So they'll be joining us online. So if we can have that shift.
Hello everyone. Am I audible?
Yes, you're audible, but we can't see you on the screen. I think they'll have to switch the screen.
Am I visible to you?
Not yet. Slides are visible, but not you. Is your video on? I hope so.
Yes, yes, my video is on.
Yes. Oh, yeah, we can see you now, but not the slides.
Okay. Mm,
But no issues. I think till they fix that, you can start describing the study.
okay. Now I think you can see my screen too, right? The presentation. Okay. I think I can start, right?
Yeah,
The
sure. Please go ahead.
Okay. Hello everyone. My name is Antrada Shuntu, and here I am joining you from Dhaka, Bangladesh. And I'm presenting the research on the behalf of my team. Two of my co-researchers are MD Rajal Rabbi and Priyanka Sarkar. So I'm moving forward to the introduction. If I tell you more about the research title is Exploring the Contemporary Societal Experience and Their Impact on Mental Health of Hijra Community, a Quality Study in Dhaka, Bangladesh. So, many societies basically adhere strictly to male or female binary that recognizes individual as either men or women. By providing two entirely separate choices of gender identification, this arrangement maintains conformity and restrict non-binary gender. So Hijras are one of the community here in Bangladesh. They couldn't be described under the traditional concept of male and female gender identity. So due to being unable to a part of mainstream society and facing continuous social exclusion at many levels, the Hijra individuals often develop a new way of living and custom. So in Bangladesh, Hijra person face different kind of pressure from society, and as a result, they kind of develop new ways of like a coping skill to survive in this situation. Can you see my screen? The presentation is available.
We can't see the slides yet, but
Okay.
I think we can go ahead with you speaking about it.
Okay. So now tell me more if I introduce you more about my research method. So for that study, we basically had two basic questions. Number one, what are the current socio-cultural experience of Hijra people in Joshua city? And another word, what are the impacts of socio-cultural experiences of mental health of Hijra individuals? Because as per we are aware, there we couldn't find no studies that looked at the relationship between contemporary societal experience and the mental health of Bangladeshi Hijra. Despite numerous global studies finding in the Hijra people, we found that from the study that mental health distress is very common in this community. But here in Bangladesh, Joshua city, we wanted to see whether there is any correlation between that or not. So for the study, we basically adopted a qualitative approach. And for that study, we interviewed 20 Hijra individuals in Joshua. And all the participants we selected through non-probability purposive clamping. And for the process, we followed the APA guidelines for the research of transgender and gender non-conforming people that has been given in 2015. And after the collecting the data, we have followed verbatim transcription and inductive reflective thematic analysis we carried out for the data analysis, and we did it manually. Can you give me 1 minute, because I'm trying to share the PPT too, because there is something important, I guess, to see. Yeah. Can you see it now?
We are trying it. I think it should be done in a minute.
Okay. So now I'm moving forward to the findings then. So for here in the study, we found basically three themes after inductive thematic analysis. There were three themes. Number one was encountering bullying, exclusion, and violence in the society. And here we got four sub-themes. They are negative labeling based on gender identity, exclusion and violence from family and society, psychological impact of bullying and escalation, and mental health deterioration. Number 2 was disparities in education, employment, and health settings. And here we got 5 sub-themes. Educational disparities and discrimination, lack of job security, workplace bullying, exclusion from proper medical treatment, and psychological impact of discrimination. And number 3 theme was enduring neglect in relationship. And there we got 3 sub-themes that are familial rejection and abuse, romantic relationship exploitation, psychological impact of neglect and abuse. So I want to mention some of the voice that we like statements from our participants. So our participants basically mentioned encountering bullying, exclusion, and violence in the society lead them to experience emotional distress, isolation, low self-esteem, and fear of public places. So one of our participants, age 22, mentioned all kind of bullies nearby people make me feel very low. I often avoid meeting people and stayed alone in the corner of the room. And I always feel isolated and scared while coming out in the public. So here you can see in the statement that the participant was so horrified with the public and like a public places. Used to stay at home and used to avoid to involve in other people. According to some of our participants, they used to face disparities.
Antra, is your video on? Can you check if your video is on? They are making a live caricature of you, so you'll miss out on that.
Okay.
Done already. Lovely.
Okay.
Yeah,
Okay.
please
I
go
can
ahead.
see the screen. Yeah. Okay. So okay. So I'm going directly to the conclusion. So from the study, we basically found that the impact of contemporary societal exposure on mental health of Hijra individuals in Bangladesh. So our participant mentioned being very vulnerable to bullying and violence from both their family and community. Hijra individuals, they used to experience low self-esteem and loneliness. And some of our participants also mentioned the development of feeling of hopelessness, guilt, and isolation, and suicidal ideation as a mental health consequence they got from disparities of education, employment, and healthcare. And we also found in our study that enduring avoidance in relationship by family members and romantic partners lead the Hijra individuals to low self-esteem, feeling of loneliness, guilt, and negative coping mechanism like substance abuse as a result of avoidance. So here in the studies, we have some kind of a limitation. Number was limited generalizability as there were 20 participants. So, and they are also from just one city of Bangladesh. So we believe this is not the representation of whole population. Number 2 was lack of substantial statistical support. The study was wholly qualitative. So I think there is a lack of substantial statistical support and the possibility of social desirability bias. It can one kind of limitation. And number 4, lack of funding. We see it as a limitation from our side. And here I also want to mention some of the recommendation from the researcher perspective. As 3 of us, the researcher, we are mental health professional, and we wanted to recommend something from our side too. So we believe to provide mental health support, a national psychological support team specialized for helping the Hijra individuals can be created. And peer support group meeting like virtual emergency emotional support session can be arranged. And mental health awareness, human rights, and personal development related group session can be offered within the Hijra community. And we also believe emotional literacy can be integrated in the mainstream education curriculum so that every individual can develop one kind of empathy for this community or like for the marginalized community. Here we want to acknowledge all our participants and the people. And here is the reference.
Yeah, thanks, Antra. And
sorry for the mess. I think for the time.
no, actually, we are sorry for the technical glitch from our side. But thank you so much for sharing these findings, and really thanks to the study participants for being so vulnerable and opening up about the challenges that they have been facing and its impact on their mental health, and looking at the solutions that can be provided. Continuing in the same theme, but now talking about a further layer of inequity which is being added by public health emergencies, we will be now having a presentation by Sharon D'Souza. They are a research coordinator with Sangat with the I Hear initiative, and they'll be speaking on trans affirmative mental health provision during public health emergencies, sharing insights from the COVID-19 pandemic from Indian perspective.
Thanks.
Over to you, Sharon.
All right. So the title of my presentation is Transformative Psychosocial Care Provision During Public Health Emergencies, Insights from the COVID-19 Pandemic. I would like to give a trigger warning for mentions of mental illness, stigma, and violence. So the findings of the present study are part of a project called TransMH Prep that is being funded by the Gender and Public Health Emergencies Working Group at the Simon Fraser University. The TransMH project is hosted at the Initiative of Health Equity Advocacy and Research at Sangat, where we've been working towards achieving health equity with marginalized communities, specifically the LGBTQIA+ community and the disability community. And through our work during the pandemic, we've identified a lot of stressors, a lot of intersecting challenges for the trans community. Of course, some of these are accessing challenges already mentioned by some of my panelists in accessing routine healthcare services, and also challenges in accessing mental health care services. So this work led us to sort of document some of the experiences that the community members were having with challenges of access, challenges of violence that were compounding in mental health problems. Our studies and a lot of other studies, just to give everybody context, talk about the exacerbating impact of the pandemic on the trans community. So the compounding impact of stigma, social isolation, healthcare inaccessibility, both mental health care, gender affirming care, and mental health care inaccessibility, disrupted livelihoods and economic insecurity, and also specifically distancing from chosen kinship, and a lot of violence in family spaces, natal family spaces, intimate partner violence, led to a lot of reported mental illness in the community. People conceptualize it both clinically and non-clinically. So in words like loneliness and isolation, of course, but also clinically in terms of depression, suicidal ideation, etc. So a lot of documentation has happened around the neglect that the community experienced during the pandemic, and how it was actually forms of community support that were predominantly forms of care during this time for the community. So our project was trying to understand these forms of care that the community was receiving during the pandemic, learning from them and understanding how this can help us structure health systems for the future. So some implications beforehand that we were thinking of were one of articulating gaps in the system when we look at public health emergency responses. So who are our systems designed to support, and who's sort of left out of these conceptualizations of care during public health emergencies? What are the unique challenges, some of which I already discussed, that the trans community faces? What are the shared challenges that the trans community faces with other marginalized communities? And how can we learn and help this to design future public health emergency responses? So the aims of this study were the following. So we wanted to explore experiences of mental health professionals and civil society organizations, CBOs and NGOs, in supporting trans and gender diverse people during the public health, during the COVID-19 pandemic. And we wanted to use this developed best practices for providing trans affirmative mental health care support during the pandemic to ensure pandemic preparedness for the future. So the methods, so the study was co-led by community members, and I'm also queer non-binary, and all my colleagues are also, and we also had a community advisory board that was very key. They brought in both public subject matter expertise and were also from the community. So we obtained our ethical permissions during the beginning of this year. We've conducted 18 interviews with MHPs, peer support providers, CSOs, CBOs, and using a framework analysis, using a framework analysis, we've prepared a series of best practices. Another layer of sort of making this participatory was taking this first draft, because we are speaking to care providers, and taking it to the community and asking them, how does this work for us and what else would we like to do? So first we spoke to care providers, then we created a first draft of the best practices. Then we went back for a consultation to community members themselves. They provided their feedback, and we're currently in the process of incorporating that. So it's an ongoing project. So just in terms of demographics, there was a mix in terms of professions, and we really wanted to broaden the scope of what we're calling psychosocial support, right? So we had psychologists, psychiatrists, clinical psychologists, psychiatric nurses, peer support providers, CBOs and NGOs, representatives from those organizations. The age range was from mid-20s to early 50s, and the work experience also ranged from people who had 3 to 4 years of experience to people who had 10 to 15 years of experience. And the mode of practice for some of the people who were providing therapy was, of course, online, hybrid. But for people who were providing aid or crisis support, it was also in person, of course. And the states were Tamil Nadu, Delhi, West Bengal, Uttar Pradesh, Karnataka. But as you can see, largely in urban geographies, you were able to speak to people where there's more concentration of services. And most of the people that we spoke to were also from the transgender. This to the what largely the best practices document was looking like, where we took it to the consultation this at the beginning of October, in fact. And we had this consultation, and we've now received more feedback. And I'll quickly take you through the findings. So as discussed in the intro, also the support and care providers that we spoke to noted that there was an increase in natal family violence, forced conversion therapy, and a loss of livelihood. And a few challenges already pointed out by a lot of panelists today were the overwhelmed work healthcare system, a lack of training of healthcare providers, and a lack of support of CSOs and any centralized response for supporting the community. So I'll go on to the best practices. So the first thing is like the kind of psychosocial support that we might envision for a public health emergency like the pandemic. So first is like the key element was community-based approaches. So in fact, the government was, or the systems were a lot farther from the community than community leaders and CBOs. So there was a lot of active outreach. Even therapists who were not used to doing community outreach in that fashion said that they had to do more community outreach directly and reach out to the transgender diverse community. Some ways of doing community-based mental health projects were, of course, like satellite camps, networking with grocery stores, local grocery stores and pharmacy stores to provide immediate aid. And the next best practice was sort of making sure we have systems in place to provide low-cost, timely mental health support. So queer, trans, affirmative, and anti-caste mental health services, rotating helplines, crisis intervention infrastructure, and access to medication, similar to the collaborating with pharmacies to provide medication, psychiatric medication, or gender-affirming medication. The third is online support and community groups. So this is really important because we usually think of MHPs as like psychologists and psychiatrists. But in the pandemic, a key element was sort of peer support providers who are not trained in the masters in psychology degree, but are people from the community who are trained in providing counseling support, counseling first aid. And also a key element here was informal support groups. So these are not group therapy. These are people coexisting online and using arts-based methods to spend time with each other. And these were also in response to community people saying that we might need more of these spaces. So they were very responsive in that sense. So connecting it to the first point of community outreach, where we're sort of trying to understand what the community wants and then responding to it by, setting up these informal support groups. Then the second is, of course, about the people who will provide all of this care. So there is, of course, a lack of training within healthcare and mental health care professionals, not just with respect to being trans-affirmative, which people have pointed out on the panel before, but also in response in terms of how things might shift in your practice of providing therapy in public health emergencies. What kind of flexibility you might require? What is the competencies you might need for teletherapy? What is the competency you might need for just navigating the online systems? So we've been able to list a lot of these competencies that I can share with you at the end of the project. Then crisis management competencies as well. And one thing that everybody has said is to set up referral networks beforehand for the community to understand which lawyers and which therapists would be of support to the community. And of course, sensitization of hospital staff, because a lot of psychosocial care is also embedded in the hospital setting, not just online services. Then in terms of provider well-being, a lot of what we were hearing about, and we've talked about the overwhelmed health system, is that doctors were also burnt out and all the health professionals were burnt out. So how can we also ensure that there are systems in place to ensure well-being? So as much as possible, even of course, as much as possible. So there are, of course, there need to be sort of public health emergency protocols in place and a role division that is clearly defined. A lot of people were saying that we were doing 4 or 5 different roles at the same time at the hospital because that was what was required. Then, of course, rotation and fair remuneration, and also support spaces for providers, doctors, and MHPs, and investing in training and recruitment and also regulation in terms of caseload. Another key thing to take away was that, we can't talk about psychosocial care without talking about economic livelihood, safety, security. So a key element, of course, the Ministry of Social, it's time. The Ministry of Social Justice gave 1,500 rupees budgeted 1,500 rupees for allocating to the community, but also to ensure the uptake of these services, because there was an actual challenge in taking up the services, creating temporary housing for people who face violence and challenges to safety, addressing sort of neglected intersections like disabled trans people, people from oppressed caste groups, sex workers, and denoting HRT as an essential life-saving medication, which it was not, and it was really challenging for trans people to access it. And of course, funding the work of community-based organizations and community leaders, and of course, looking at aid as more holistically in terms of rent and utilities, and not just sort of the aid amount. So the limitations are, of course, that it was located in a lot of urban centers, the service providers that we were speaking to, and it was drawing on the example of the pandemic, which is not always transferable to, say, the floods that we were speaking about in Wayanad, etc. So we've been asking about feedback for that in the consultation as well, and a lack of course, governmental perspectives in this. So finally, I'd just like to talk about how mental health is intertwined with economic safety and other needs of the community, and a holistic approach is required, and not just a sort of mental health specific approach. A psychosocial approach is needed, and it requires us to invest in the community now when the public health emergency is not active. So thank you. Yeah.
Thank you so much. Yeah, you didn't exceed much time. It was perfectly in time. I was scaring you. Okay, so I have been also a part of this project, and 2 findings that were really very important was, that economic support can lead to good mental health in public health emergencies. I mean, ultimately, you go back to the basic things like food, shelter, safety, and how that was so important. So a counseling session can't, take care of your hunger, for example. And second important thing is that generally we believe that in disasters, the help will come from outside, that it's the communities who are supporting each other in the absence of any solid government support. So that was really a very helpful understanding from the community. So after 3 presentations from trans and gender diverse communities, we now move to a very interesting presentation, which is on women with disability. Dr. Sankalpa, who is an assistant professor of social epidemiology from Institute of Public Health Kalyani, will be speaking on violence in the lives of women with disabilities from Odisha in eastern India.
A very good afternoon to all of you. Post lunch session, last speaker of this particular session. So I'll keep it like short and sweet. I'll be talking about the ubiquity of violence in the lives of women with disabilities in Odisha. So, violence against women is particularly seen as a private matter. However, it is being increasingly recognized that it is a public health issue as well as a human rights issue. Moreover, the hegemony of masculinity and able bodiedness renders women with disabilities in a marginalized position, making them more and more vulnerable to discriminatory acts. So, for example, in comparison to men with disabilities, women with disabilities face increased instances of violence on account of their gender as well as their disability, which is a sort of double discrimination. So, the aim of this particular study is to investigate and identify the various forms of disability, the various forms of violence that these women with disabilities encounter in their daily lives, both within and outside their homes. For this purpose, in-depth face-to-face interviews were conducted with 27 women, 19 women from the rural areas and 8 from urban areas of Odisha, which is in the east of India. And these were 27 cisgender women with benchmark locomotor disability. So they had some form of restriction in their physical movement and they had no mental or intellectual impairment. They were mostly from the age of 18 to 60 years of age. Now, physical violence, which is the most commonly recognized form of violence. I'm not going to focus more on that, but rather the more inconspicuous forms of violence. So let's take the first example of Jogita, who is a 23-year-old woman with cerebral palsy. So she has a waddling gait. So she says, whenever I meet male colleagues outside office, I pretend as if I do not know them, because if my father comes to know of it, he will use words that a father should never use for his daughter. So these are the forms of bullying, name calling, and social ridicule that the women with disabilities have to encounter every day in their lives. I'll like to give a small example. Particularly in the rural community, people with disabilities are not known by their names, but by their particular disability. So in Odia, a person who is walking with a limp or has a physical deformity is called Choti. So even the parents are kind of termed in those references. So like it will be Chotira Ma, knowledge Chotira Bapa. So it's the mother of the woman who has a limp, or the father, or there goes the father of the woman who walks with a limp. Coming to sexual violence. Now, in case of sexual violence, I do not find many women who had this sort of experiences, but there was this case of a woman, Iravati. She is a wheelchair user. She was molested as a child by her male caretaker and also as a young woman by the ambulance driver. A very interesting case of sexual violence, which puts an end to your school career, came from Beena, who is a 31-year-old woman with post-polio residual paralysis. So she says that the boys would wait on my way to school. When I fell down, they would rush to help me so that they could touch me with the wrong intentions. And she stopped going to school after that when she saw that the number of times she was falling while on her way to school increased because of her increasing disability. She stopped going to school. So that was the end of her education and employment, future employment. Coming to neglect. Now, violence is not always a action that has to be taken. It can also be perpetuated by a passive inaction. So here what happens is you are withdrawing the services or the care that that particular person needs. My father refused to pay for surgery, which would have helped my gait, in the hope that I will die sooner or later. He did not pay for my education either. So this comes from Jogita, who is again the lady that I spoke about earlier. Again, the agency of these women or the voices of these women have been silenced. Bina, she was married against her will to a drunkard who beats her after drinking. So I would like to take a minute and mention this particular instance where in rural communities in particular, families with women with disabilities, um, usually what happens in the Indian community is that after marriage, the woman goes to the leaves her natal home and moves to the in-laws place. But in rural communities, what happens is the family looks for a man who would stay with them in the bride's place as a stay-at-home son-in-law. So this person was also that, and he had kind of married her in the hope of getting the property of that of the woman. Again, coming to Iravati, who is a wheelchair user, she, as a teenager, she had long, luscious black hair, and her doctor advised or suggested her parents that why do you need to keep her hair long? You can cut it off for proper management. So the in a way, you are desexualizing the woman in the pretext of managing her condition. Again, Mona, she is currently working as a rehabilitation professional. She says that she was traumatized by a particular incident in her college, in her teenage years. So she lost her left leg due to an accident as a child. So she wears calipers, and she said that she was asked by the rehabilitation professionals to squat wearing the calipers, and they took a photo and they displayed it without her consent, and also without the black patch that we put over the eyes to protect the privacy. They did not look into it. So she felt very traumatized by that. Again, this is a form of structural violence where Tini, she is currently a professor at a rehabilitation college. She says that she got through the entrance examinations for medical and engineering courses, but the doctor, when it came for a medical examination for entry into the colleges, the doctor declared her unfit. So she kind of fell into deep depression. Now, in conclusion, I would like to say that physical violence is not the only violence that these women encounter, which is a fact in their lives. There are a lot of women when I interviewed, they said that they were beaten up by their family members, the brothers, the wives of their brothers, or the parents, or their uncles, even the community members. But which is very often researched about. But I wanted to look at the more overt ways of violence which are occurring in their lives, which can be both intentional and unintentional. And this occurs within the family, the community, and the healthcare system. The inherent structural violence which keeps happening against them because of their gender as well as because of their non-normal body. As I mentioned earlier, it is because of the celebration of masculinity and the able or the good human form that we have. Here, I would like to also take a moment here to explain that certain families, in the pretext of protecting their daughters from being ridiculed in the society, do not allow them to go out of their homes. They keep them isolated within their homes. So it kind of prevents them from having a social life. So in all these cases, what we see is that the violence against these women, they have health consequences. Also, they prevent these women from having social and economic participation within the society when we are talking about human rights and an inclusive society. So here, financial empowerment is not enough. So we have a majority of the policies that have been taken up by the governments are usually looking at the financial empowerment, but it's not enough. For the actual empowerment to happen, it has to happen by looking at the attitudes of the society itself. So sensitization programs are very important. And before sensitization can begin, there is a research gap. I'm so sorry. There's a research gap. So this research gap can only be filled by taking a participatory research approach, where the women with disabilities come together along with the researchers to examine and identify the types of violence that they encounter in their everyday lives, and then sensitize the healthcare professionals about them. Also, they also counsel the ground health workers, the ASHA, the ANMs, the nurses, the doctors, the public health professionals, everybody, so that people are aware of it. And then from from the healthcare professionals, it trickles down into the, not trickles down, basically the healthcare professional takes it upon them to educate the people about the various forms of violence, so that the women themselves identify what kind of violence that they are encountering in their lives. Because in a lot of cases they said that it's okay, the violence, the neglect that I'm encountering, because this is what my fate is. They are attributing the violence that they're encountering to their fate. This is not fate. This is not how we talk about human rights issue in the 21st century. Again, we have to take assessment skills. We have to sensitize health professionals to take up assessment skills, so that they can identify the signs and symptoms of abuse if these women encounter. Also, the services that we have should be responsive for empathetic and survivor-centered care for these women. Thank you. The limitations are the intersection. Thanks.
Yeah, thanks, Sankalpa. And we'll be taking a few questions from the audience. So if anyone has questions, think of them and be brief. But before we go to that, really thankful to all the four speakers, and just reminding you of the topics that they spoke of. So we had Bhavya speaking about NCD risk factors in the trans community from Kerala. We had Sharon speak about trans affirming mental health care, especially in public health emergencies like COVID-19. We had Antara speaking about societal experiences and its effect on mental health of Hijra community from Bangladesh. And we had Sankalpa speak about the violence that women with disabilities face, and not just physical, but different types of violence from natal, family, healthcare systems, and so on. So if anyone has questions, we can take maybe a couple of questions. Before we, yes, so we have one hand over there. Anyone else wants to ask? Can we have the mic there, please? Excuse me. You'll have to maybe raise your hand a bit higher.
Excuse me. Thank you. Please.
Hello, and my question is for Dr. Sankalpa.
Can you please introduce yourself?
Yeah, hi. My name is Maria Malavi. I am the editor of First Check, which is a health news digital platform. Dr. Sankalpa, my question to you is that a lot of the violence that you spoke about is also meted out to sometimes able-bodied women as well. So could you just be a little, just wanted to know, how was it different for your sample of disabled women or women with disabilities? And how is that different from the kind of violence that able-bodied women also face?
Sure. If there are any more questions, we can maybe combine. Otherwise, we'll go to Sankalpa. Yeah. Yeah, we have one more question, so maybe we can hear that before taking the answer to the first one.
This is Pooja. I'm a psychologist. Again, the question is for Dr. Sankalpa. You mentioned the sexual violence, you couldn't find much. Was it like not shared by the people? Or, they were very scared to share? Because again, we know about the disability. If they open up already, there's so much of stigma, so much of victim blaming is there. Is there something which you would think of, that they couldn't share what is happening to them?
Okay, thank you. So we have two questions for Dr. Sankalpa, and we'll be also having a few discussion from Sharon and Bhavya on community-based participatory research, something that I was referring to in the opening remarks as to how the communities can be engaged in their own research, determining the research priorities and how we can have more participatory research with the involvement of the public system as well as the community-led organizations. But first to Sankalpa.
Yeah. Am I audible? Okay, coming to your question, Mariam, right. Like I mentioned, the incidence of this violence against women with disabilities is much higher compared to other sections of the. I'm not denying that these are the same kind of violence that the women without disabilities also endure, but the incidences are much higher, and the way they go about it is the way of addressing them is much the chances of addressing them is much lower in their cases. So like so I'll talk about this lady that I constantly refer to. She's yeah, Jogita. Thank you so much. So Jogita, if you see her life story, she has been constantly neglected by her family, but she is now an educated graduate. She's a graduate and she has a she works at an NGO. She got married, she has children, and all of this. But this is a one-off story. Rest of the people, they did not have those opportunities, or the, I would not say opportunities. It is the coming together of all the circumstances that this woman had. Her willpower, she is very strong-willed individual, but also the other circumstances that came together, which became favorable for her. She fought against it. There are the other 25 participants who couldn't, or they couldn't come to that particular stage of life where she is. I'm not comparing. Everybody's life's journey is very different, and wherever they are, wherever they are, but it's a qualitative study, right? So it is very contextualized. So I'm not kind of comparing that this one was better or that was lesser, nothing like that. It's just contextualized. Um Pooja, yeah, Pooja. The fact that can you please repeat your question, Pooja? Sexual violence. Yeah. Yeah, the sexual violence that you were talking about, actually, these women do not venture out much. So even if the sexual violence, the extreme, maybe my wordings were not correct. Extreme cases of sexual violence I did not find, like rape or sexual assault, molestation, yes, name calling, yes, eve teasing, yes. But also, on the other hand, a lot of the women that I spoke with did not venture out of the house. Basically, they did not venture. What the families did not allow them outside the houses. So the other things, if it has been happening within the family and they have not spoken about to me, that could be a limitation of my study. Thank you.
Thanks, Sankalpa, and thanks the audience for those questions. We'll be skipping the responses from Bhavya and Sharon in the interest of time, but do find out the answers from them in person over coffee later. Just to summarize, I think a few takeaway points from this discussion is involving the communities in setting the research priorities for them, engaging the communities, looking at the violence within the healthcare systems and how in future healthcare trainings and building of our systems, we can ensure that they're violence free and they are affirming of the gender of people, whether they are a man, woman, trans, or gender diverse person. And very importantly, to be always prepared for public health emergencies, because as Shweta mentioned, we'll be moving from one crisis to another before we can even recover. Thank you very much, Antra, online, and all the panelists over here and all my lovely audience here. Thank you.
Thank you again for an incredibly thought-provoking session. We are running massively over time, ladies and gentlemen. We're going to have a 15-minute break, but I really hope you do come back in 15 minutes so we can get going with the last session and try and finish within a semblance of time. So 15 minutes for tea and coffee, and then please be back here for a really exciting final session focused on conflict and health. So see you back here.
Більшість лікарень зруйновані, їм потрібна допомога, їм потрібно служати і перевозити пацієнтів в більш спокійні місця.
Чому вимоги видав на самоту пацієнтів переважно з сполучними пораненнями після вибухових травм. Видамо після служіння
Нічого, спокійно, не було. Так, правильно.
pain was mother. And they said that there's no pain. You cannot imagine that. Think about it, you cannot do more. The hospital was surrounded by the snipers. Many people were injured and killed.
But I'm saying that the one who passed away in a few days was very lucky. They didn't witness a to finally change and love. We moved the staff, our colleagues from the shelter to the new shelter, and of course they were asking if we were there. And I cannot say to my staff that this place is safe. I mean, there's no safe place in Gaza.
Always continually like college, what to call graduate.
My son was convinced he days ago, my family didn't have any. I didn't just talk to me. I'm afraid that I will die from hunger. I will see you drink and between my hands because somebody touched you and he couldn't save me.
Більшість лікарень зруйновані, їм потрібна допомога, їм потрібно якось допомагати, і ми перевозимо пацієнтів в більш спокійні місця.
Якщо маленька, пацієнтів приватно поранення після травм. Вони знаходять і не можуть представити. Десь треба зробити.
Нічого, спокійно, не було.
take him and face to his mother and his sister because there is no space. You cannot imagine that this is our best. We cannot do more. The hospital was surrounded by the snipers. Many people were injured and killed.
I've been saying that the one who fought for running the 2 days, we're really like they didn't put us a thing to find things and all. We moved there with half our colleagues from the center to the new center, and of course they were asking if it was safe. And I cannot say to my staff that the place is safe. There is no safe place in Gaza.
To correct it. But I think that of my was at the morning.
My son asked me few days ago, Mom, can we leave Jordan? I really just want to let I'm afraid that I will die from hunger. I will see you dying in between my hands because somebody shot you and we couldn't save you.
Більшість лікарень зруйновані. Їм потрібна допомога, їм потрібно якось розважати, і ми перевозимо пацієнтів в більш спокійні місця.
Тебе відбулося? Ось, якщо болиться, то много все. Ми ведемо у нас на борті 7 пацієнтів, переважно додатковими пораненнями після травм. Веземо з міста Слов'янськ, транспортуємо до місця Дніпра. 3 години. Десь 3 години.
Нічого, не спокійно на даний хвилин. Це взагалі реанімаційна машина. Ми сподіваємося дуже важких пацієнтів, критичне обладнання, яке може нам саме допомогти. Це сама, це ЄВЛ, це монітор, є дефібрилятор в крайній случаї.
Amputate him and face to his mother and his sister because there is no space. You cannot imagine that this is our best. We cannot do more. The hospital was surrounded by the snipers. Many people were injured and killed.
And I'm saying that the ones who passed away the few days were really like they didn't put respect to find things and lost. We moved there with half our colleagues from the shelter to the new shelter, and of course they were asking if it was safe. And I cannot say to my staff that this place is safe. I mean, there's no safe place in Gaza.
Awake, like crying, how to correct it. But I think that there is more things.
My son was asking me few days ago, Mom, can we leave Jordan? I really just want to let I'm afraid that I will die from hunger. I will see you dying in between my hands because somebody shot you and he couldn't save you.
Більшість лікарень зруйновані. Їм потрібна допомога, їм потрібно якось розважати, і ми перевозимо пацієнтів в більш спокійні місця.
Болить, якщо болить, кажи. Ну, ногу хто? Ми веземо нас на борту 7 пацієнтів, переважно алкогольними пораненнями після кров. Виходить на Слов'янський, та Тихий. 3 години. Десь 3 години.
Нічого, не все вступив на дану хвилину. Це обладнання, яке може нам допомогти. Це інфузамати, це ІВЛ, це монітор, є вентилятор на крайній случай.
Him in base with his mother. And there's no pain. Cannot imagine that this is our written cannot do more. The hospital was surrounded by the sniper. Many of people were injured and killed.
Amazing. And I'm saying that the ones who passed away in the Philippines, very much, they didn't choose to require things and God. We need to go and respect our police from the center to the center. And of course, they were asking me one day. I mean, I cannot say to myself that this place is safe. I mean, it's not this place in Gaza.
The phone is away finally, but I start to have it. I'll play a little touch the phone thing.
My son was asking me few days ago, Mom, can we leave building? I really just want to live. I'm afraid that I will die from hunger. I would see you dying in between my hands because somebody touched me and I couldn't save him.
Більшість лікарень зруйновані, їм потрібна допомога, їм потрібно якось теж вважати, і ми перевозимо пацієнтів в більш спокійні місця.
Болить, якщо болить, кажи. Ну, ногу хто? Ми веземо нас на борту пацієнтів, переважно алкогольними пораненнями після кров. Ведемо на Слов'янський, місце 3 години. Десь 3 години.
Нічого, не вступив на дану хвилину. Потім може бути пацієнтів, передати це обладнання, яке може нам допомагати. Це ІВЛ, це монітор, є вентилятор на крайній случай.
Him in pain with his mother and his sister because there is no space. You cannot imagine that this is our place. We cannot do more. The hospital was surrounded by the sniper. Many people were injured and killed.
That the ones we passed away in the 2 days were very much physical weakness. He was finding that things and wrong. We moved to Korea. We stopped our colleague in the shelter, to the new shelter, and of course they were asking if it was safe. And I cannot say to my staff that this place is safe. I mean, there's no good place in Gaza.
It's outcrying, out of
My son was asking me few days ago, Mom, can you read God's name? I really just confident. I'm afraid that I will die from hunger. I will see you dying in between my hands because somebody took you and we couldn't save you. Man. And she thought to goodness, right?
Більшість лікарень звільнення, їм потрібна допомога, їм потрібно якось людей вважати, і ми перевозимо пацієнтів в більш спокійні місця.
Болить, якщо болить, кажи, допомога все. Ми веземо на борту 7 пацієнтів, переважно з осколочними пораненнями після травм. Ветрут, міста Слов'янськ, міста Дніпро.
If everyone could start making their way back into the room, we're going to start in just a couple of minutes. So please do start making your way back into the room. If we can start making our way back into the room, please. We're going to start the final session. If we could get the speakers for the final session up onto the stage as well. Bala, Shweta, Rishika.
Guys, we got 30 minutes. I know. Okay, dismiss. No, it's not really. This.
Hello. If you guys want to be in the room till 6, we are happy to have you here.
You're going to give 30 seconds for the last stragglers to come back. Can someone maybe just go and do a bit of a quick shout outside? Yeah, using a mic or something.
Even some of the organizers.
Exactly.
Okay. Right. Welcome back, everyone. Welcome back to those online. This is our final session of the day, which kind of brings us back to where we started, about the human cost of violence, healthcare challenges for populations affected by conflict. And I think as we can see from current events in Gaza, Sudan, the DRC, Central African Republic, and many others, conflict remains the key accelerator of any humanitarian crisis, driving around 80% of current humanitarian need. And what's been very interesting over the past 2 decades is that these conflicts have been increasing in both duration and in size. And as we're hearing today in our newspapers all the time, as many of our colleagues from MSF have experienced, governance and international humanitarian law are increasingly being disregarded, with the attacking of civilian infrastructure and weaponizing of aid and resources such as water, as we've seen in Syria, healthcare, as we see in Ethiopia and in Gaza, and using sexual violence against women and girls as a tool of war, as we see in DRC, amongst so many others. And conflict not only contributes to this steadily increasing caseload, but it also leads to increasingly dangerous operating environments. Aid workers, including doctors, Doctors Without Borders, all other allied health professionals, continue to be targeted with violence, hampering humanitarian access and our operations. These attacks deprive people of urgently needed care. They endanger healthcare providers and they undermine healthcare systems. By the middle of 2024, there were over 125 million people forcibly displaced, which is a record high. That's almost 2% of the world's population being displaced, of which almost half are children. These are terrible statistics about the current humanitarian state of our world. And so with that as a backdrop, I welcome the chair for this session, Dr. Fairat Mantu.
Thanks, Bhargavi. Bhargavi, I will put a face to what is happening around the world. But I'm going to take it a bit further. So we all know Ukraine, we all know Gaza. It's so fresh in our memory. We talk about Sudan. Some of you know about it. Some of you know that is somewhere on the world map, but no one is talking. We're talking about tens and millions of people who have been forced out of their homes, even out of their country. But there are also contexts, the Sudans of this world, the South Sudans, the DRCs, Democratic Republic of Congo, Central African Republic, Afghanistan, Yemen, Syria. So these are those situations, those countries which have been at protracted crisis for long. So that would mean that how it started is not same, but there are different manifestations of what conflict and war does to our population. Any trauma does not leave us unaffected. It is something that is felt not by the current generation, but the generations to come. So we have three wonderful researchers today who are going to talk about the human cost of violence. And without much ado, I'm going to invite Dr. Bala Vansip, who is an independent researcher based in Oxford, UK. He holds a doctorate degree in geography from University of Singapore. And I'm not going to read the entire bio of her, but he has been associated with Action Northeast since 2011. And he's going to talk about something which is a learning, not only out of a research piece that has been done and how it has been implemented. What do you think about it? Bala, could you start?
Okay. Research project. Our study focuses on engaging that. Could you stop the sound there?
Can hear you. We are going to be a bit strict on time, so about 10 minutes. Nice.
Click on my presentation. I'll walk you through the background. Sorry. I think I'm hearing the echo from there.
We are hearing you fine.
Okay, a brief overview about the context of borderlands. Since India's independence in 1947, several of the northeastern
Bala?
Yes.
Please go ahead.
Okay. Hi, everyone. I'm here on behalf of the ANT to share the findings from our research project conducted in 2016-2017. So our study focuses on a region that has long been affected by conflict, and we examine how this conflict has affected health systems and shaped the lives of the people living there. So this study was initiated as part of the Closing the Gap, an initiative of the Achyuta Menden Center for Health Science Studies. So as part of the Closing the Gap initiative, we responded to a call for research on developing a collaborative project on health equity and tribal health in India. So before going into the details of the study, I just want to give you a brief overview of the context of Bodoland. So since India's independence in 1947, several of the northeastern states, including Assam, have experienced armed conflict, and this includes Bodoland, which is located in the western region of Assam. And Bodoland is currently governed by the Bodoland Territorial Council, which is an autonomous body to grant some degree of autonomy to the Bodo tribe. Now, the Bodos are considered the majority of the population and are recognized as scheduled tribe within Assam. The Adivasi, the Bengali Muslims, Rajbangshis, Rabhas, and Nepalis, they form the rest of the population. As this timeline shows, it shows the struggle for a statehood or Bodoland, which lasted for decades and transformed the region. It started in the late 1980s and it continued until the early 2000s. So the agitation in Bodoland emerged largely to resist the cultural hegemony of the ethnic Assamese, and the Bodos kind of demanded recognition of their cultural and linguistic heritage, as well as greater opportunities for economic development, which they felt they had been denied. Whereas non-tribal populations are denied formal access to land ownerships as well as political representation within Bodoland, which leads groups like the Adivasis and Rajbangshis to demand scheduled tribe status to avail protective benefits similar to the Bodos. Now, I just want to highlight here that the Adivasis in Assam are not recognized as scheduled tribe as compared to the Adivasis in the central part of India in places like Jharkhand. So all these issues and complexities have led to Bodoland to become a very fragile state, while today, Bodoland has entered the third peace accord, which was signed in the year 2020. So we can say that Bodoland is a more peaceful place, but the effects of the conflict still linger. Next slide. So conflict and state fragility are key drivers of health inequity in conflict-affected areas, yet the violence and conflicts often gets overlooked as public health issues in both research and policies. So while there's considerable research on the impact of high-intensity wars on health systems, studies on long-term, low-intensity and repetitive conflicts are scarce. So in northeastern India, most conflict research focus on immediate crisis or the displacement of people. In Assam, the emphasis tends to be on migration, ethnicity, and identity, with little attention to the long-term health effects of ongoing conflict. So where health inequities are studied, they often rely on quantitative data, leaving gaps in understanding the deeper long-term health risks and vulnerabilities in fragile conflict-affected areas. So to fill this gap in our research, our study sought to answer like 4 main research questions, each centered around understanding how the conflict shape health systems, healthcare access, and the well-being of the people in this region. Now, to answer these research questions, we used an in-depth qualitative approach. We focus on villages that had been deeply affected by the conflicts in the year 1996, 1998, and 2014. So by using a snowball method, we relied on our local informants to identify participants, and the study extended beyond the ants intervention areas to cover places where population have resettled after the conflict. Could you please go back to the previous slide? So the first research question examined the intersection of politics and health systems. And here we use the example of the Shantipur State Dispensary as a case study, which was founded, this dispensary was founded in 1972, which was functioning just as well or badly as the rest of the health system in Assam. So a doctor we spoke to recalls that before the conflict, this Sidley block where this dispensary was located had 11 dispensaries and 1 PHC, all fully staffed. So, however, once the agitation began, things changed. The health centers were destroyed, doctors fled, especially the Assamese doctors. Health personals and even health basic services like electricity were cut off. So one of the doctor we spoke to who used to work in one of the dispensaries, he remembers that he had to conduct deliveries using a torchlight. So most public services and infrastructures in the area were affected, such as the schools were burned down, public government offices were burned down. This period in the 1980s and until the middle of late 1990s, we see the period of total boycott and destruction of government infrastructures. So in next slide, in the conflict-affected regions, the fragility raises vulnerability, and one of the clearest impact of the conflict was the displacement of people, especially young girls, who often drop out of school and become vulnerable to abuse or trafficking. So here I'd like to share the stories of 2 women, Rashmi and Sita Soren. Rashmi and her husband were affected by the conflict in 2014. So both of them were daily wage laborer. But one day, Rashmi's husband went to work in a nearby village, unaware of the violent conflict about to erupt between the Bodo and Adivasi communities in 2014. So he went to work but never returned home. So the search teams found his clothes and shoes, but never his body. Rashmi believes that he was killed during the conflict, but without the proof, the authorities denied her any compensation. So fearing for their safety, Rashmi and her children, they fled to the relief camp. Life there was harsh. Her husband's body was not recovered, so there was no compensation. And on top of that, Rashmi's health, which was already fragile after giving birth a month earlier, worsened. And tragically, her infant daughter also fell ill and passed away in the relief camp. So at the time of this research, Rashmi continues to work as the daily wage laborer. She also has a small kitchen garden which she sells her produce. So on a good day, she makes about 150 rupees, just enough to buy rice and basic essentials. But she owes a lot of debts to her shopkeepers in the nearby village. So this was in 2016. The second story that I want to highlight here is Sita Soren's story, who, after returning from the relief camp in 2010, now Sita was the second daughter who left home to work as a housemaid in Bhutan, because this research was conducted in the border of Bhutan, a place called Deosri. So she went to work in Bhutan, and Sita's husband used to go and collect their daughter's payments from the employer. But one day, her cousin had eloped. So there were two sisters. They went to work in Bhutan, and one of them eloped with a boy from the village. But when her father went to collect the wage, they found out that she had disappeared too. Now, Sita's first daughter, when she died in 2015 while pregnant, and after returning from the relief camp. Now, with one daughter dead and another missing, her third daughter, which is a child from her second marriage, has also left home. So her third daughter went to work as a maid in Arunachal Pradesh in March 2016, despite her mother's warnings, Sita's warnings not to go. But 6 months later, her friend returned, telling Sita that her daughter would come home the following year. But there has been no contact, and Sita waits anxiously, unsure if her daughter will ever return. So these stories of Rashmi, Sita, and there are many more other stories which I can highlight today, but these stories kind of reflect the broader struggles faced by the displaced population and the losses these communities suffered, especially the social, economic, and which these conditions which kind of perpetuated poor health and standard development. Let's go to the next slide. So another striking finding from our study is the heavy reliance on informal healthcare providers. So in conflict areas like Bodoland, where the public health system is either inaccessible or ineffective, people turn to traditional healers, pharmacies, basically informal pharmacists, NGOs, and government hospitals. One story that stands out here is that of Ganesh Hansda, an Adivasi man who runs a pharmacy in the Deosri relief camp, which you can see in the photo. So he's been providing medical care since he was a teenager, learning the trade from his uncle. He learned to administer saline and noted that people in the camp prefer medicines over traditional healers unless they don't recover. So his pharmacy becomes the first stop for many, even before considering a government hospital. As you can see in the quote by Lucy and Mary, who testify that they said that, you know, they prefer to go to him because the doctor in the dispensary just writes the names of the medicine on a slip and sends them to the pharmacy. So they might as well just go to Ganesh to get medicine. So they normally refer to the dispensary as the hospital. So for many, the hospital is just too expensive and inconvenient. And with the public health system in shambles, back then, post the 1996-98 conflict, NGOs like the MSF had stepped in during the most critical moments. And actually, it feels very surreal to be presenting this report today and share that the people in the region remember MSF for its role in tackling malaria. The people we often spoke to, and this was in 2016, and they often referred to MSF as the NGO. Of course, they don't remember the name. They always refer it to the NGO that was there after the 96 conflict. Next slide. This is again the story of Sarna, who is the only child of Binod and Lucky, who was born in a relief camp during the 96 conflict. So Sarna now is a second generation child who's living in the relief camps, who was displaced twice. She died because of pregnancy, but then it started off with a very mild illness of having fever, swelling, and weakness, but without medical checkups, her health declined. They went to an ASHA worker who urged them to visit the state dispensary, which is 10 kilometers away. But when they went there, Sarna was diagnosed with malaria, but was not given malaria medicines, but only given vitamins. So it kind of exacerbated her illness and weaknesses. So her family, they planned to move her closer to a better healthcare, but they struggled because of delays and lack of money. So even they sought help from a traditional healer who advised immediate hospitalization, but Sarna's condition only worsened. So by the time they arranged for money, arranged for an ambulance, it was already too late. And by the time they could really finally arrange the money for the ambulance to come, like Sarna had already passed away. Next slide. So at the heart of all these stories is the theme of governance, or rather the lack of it, I would say. In fragile conflict-affected areas, essential services that should be provided by the state are compromised. People who are already affected and are vulnerable, and they need that extra support and services to help them to cope and not fall prey to ill health and being. And they find it nearly impossible to hold the government accountable for failing to provide even the most basic services. So the schemes that are meant to alleviate poverty or provide food and healthcare often don't work as intended, leaving most of these people who have been displaced to fend for themselves. The next slide. In conclusion, the conflict in borderland has left deep scars on both the social life and the health systems. And as we've seen, it's not just the physical destruction of infrastructures, but also the loss of trust in public services that had a lasting impact. So families affected by conflict face multiple layers of vulnerabilities. And we see that poverty, powerlessness, economic, environmental degradation, mental stress, and poor governance push them to the brink. Limited resources and a failing health system push people towards varied, often delayed treatment options. Even minor illness can quickly become health catastrophes. So while NGOs may have stepped in to provide temporary relief, the long-term solution must come from rebuilding governance and strengthening systems to ensure they can withstand future crises. Thank you for listening, and I hope I'm still within time.
Thank you very much. What we hear very clearly is that conflict doesn't have a start and an end. There needs to be long-term strategies to look at it. Moving on to the next speaker, Dr. Shweta Sen, who is an assistant professor at Bengal School of International Affairs, representing the she will learn those. And I had asked her actually for a long while, but given the time constraint, I would really like to see that what she's going to present is that the research that is undertaken to investigate women's experience in conflict with respect to intervention between conflict, gender roles, and mental health. Over to you, Shweta.
Thank you. Am I audible? Am I audible? Yeah. Okay. So first, I want to thank MSF to give us this opportunity to present our research. This project is part of our ongoing project. This presentation is part of an ongoing project while we are looking at IDPs from Manipur and refugees from Myanmar who are residing in Mizoram and Manipur currently. So we are looking at the issues and vulnerabilities they face every day. And not only that, we are trying to document how they exercise agency during conflict. So a little bit of background about this issue. So since 2021 military takeover of Myanmar, tens and thousands of refugees fleeing war, violence, and persecution have taken refuge in Mizoram. According to the latest government estimate, at least 10,550 refugees are staying in 101 relief camps in 9 districts of Mizoram, while 9,300 others have taken shelters with their relatives, friends, or in rented accommodation. With a fresh spate of violence in 2024, Mizoram witnessed an influx of 1,500 more civilians, bringing the total number of refugees in Mizoram over 35,000, which includes 10,900 women and 13,310 children. The situation is dire. While the effects of conflict-induced migration on civilians have been well documented, the suffering of young mothers often go unnoticed. Pregnant women and children represent an especially vulnerable group, facing higher risk due to unhygienic living conditions, language barriers, unfamiliarity with the healthcare system, and gender poverty. The difficulties are further compounded by their multifaceted experiences with violence, such as separation, lower levels of education, loss of social and communal support mechanism, and an increased risk of are presently focusing on the broader needs and requirements of refugees. There is an urgent need to document and address the effect of this complex humanitarian crisis on one of the most vulnerable population of the refugee community, which is the young mothers. Mainly because granular micro-level data on how women refugees continue with their everyday activities during transit or after settlement in host countries are very scant. In other words, there is not much written on what life looks for pregnant women and women with children fleeing war. What are their needs are versus what is provided to them. To this end, we as in the practitioners, the researcher and practitioners in OP Jindal Global University and Coordinates research team. Coordinates is a humanitarian organization working in Mizoram as well. We have 129 women in general and 40 pregnant and young mothers between June and August 2024, mainly focusing on their living conditions and well-being. To that effect, we have gathered information on three aspects of their displacement experience. First, their mobility pattern, that is their places of origin, date of arrival to the host community, and the documents that they have with them, which they have lost, and effect of this lost documents on their everyday life. The second aspect relates to access to humanitarian assistance and camp condition, where we look at aid providers, forms of help received by these refugees, food security and sanitation condition of their settling. The third aspect, access to healthcare services and barriers to access, is where we have inquired about the existing health needs and access of women and children and how do they access healthcare despite the existing challenges. So this is the unit of analysis and everything. I'm keeping it short, so I'm moving on to the key findings. Places of origin from the survey finding, it is estimated that over 45% originated from Chin state, with Matupi township being the most frequent place of origin for refugees. Other than Chin state, a significant number of refugee women came from Sagaing region, especially Mayung and Kalemo district. One interesting fact that is coming out of the data is that many refugees have chosen to travel to Mizoram owing to their pre-existing ethnic or community or familial connection. In other words, migrant networks work as a channel of information and create pull factors that facilitates or induces more flight to these particular areas during conflict. Of the 129 women surveyed, only 14% are from Manipur. They are, as in their Manipur IDPs, which are internally displaced population. The rest of them are from Myanmar. Among them, 30% of the female population do not possess any documentation, and approximately 40% lost them during attacks or while fleeing. Only one respondent holds a Mizoram issued refugee card. Still, this card is only recognized within the state of Mizoram, effectively reducing their access to essential education, health, and livelihood services. The respondents that we survey consistently say that they consider this to be a pressing concern. I want to highlight two of the experiences, the qualitative data that we have. Miriam, name change, told us that she was unable to procure a birth certificate for her newborn daughter after giving birth at a government hospital, while Jackie said that her two children are presently out of school as she could not register them without any corresponding documents. Both are from Chin state. In terms of access to resources, the survey establishes that over 77% of the respondents have received aid, mainly in the form of shelter and surprisingly or unsurprisingly, the help came from civil society or faith-based organization, mostly, in other words, informal actors, such as teen churches, Baptist Church of Mizoram, Zoram Entu Powell, and Young Mizo Association. Despite the help, over 34% of the women reported deplorable living conditions, such as crowded space, lack of proper sanitation facilities, etc. And as many as 80% of women experience food insecurity in the past 6 months. A bit of data on their water access. Most of them don't have access to drinkable water. They face many health challenges because of the condition of overcrowding, inadequate infrastructure, lack of proper nutrition, and poor hygiene. The survey says that most of them suffer from respiratory diseases, diarrheal diseases, and tropical diseases. So as a part of our survey, we wanted to understand how many times, what are their chances of accessing healthcare. When it comes to healthcare accesses, financial barriers are a major hurdle for these families. As you can see from the slide, most of them only seek healthcare when it's absolutely required. And if they seek healthcare, most of them have to spend at least 500 to 1,000 rupees for it, which is a considerable sum of money for these refugees. So financial barriers are a major hurdle for these families when it comes to accessing healthcare services, mainly primary care treatment for non-communicable diseases, child healthcare facilities. Almost 98% reported relying on savings, borrowing money, or cutting back on medical visits to manage the financial strain. Yeah, okay. So in the past 6 months, 46% of the respondents stated that their children had no assistance from the community health center, primary health center, or district hospitals. Only 14% mentioned receiving help, such as vitamin C, A supplements, immunization, etc. So what's next? The conclusion. We all know that displacement adds a significant burden on the fleeing population, especially because conflict and migration reduce their previously accessible social and communal security nets. Conscious efforts need to be made to instrumentalize a robust monitoring and surveillance system in Mizoram, which is severely lacking at this moment. Although there is a highly localized and volunteer-driven response mechanism in place, it is overburdened, underfunded, and overstretched. We all know that there is an escalating violence going on in Rakhine State, which might result in more influx of refugees in Mizoram. The need of the moment is a large-scale and sustained level of assistance alongside constituting a culturally rooted intervention system that includes integrating that the mentioned informal agencies with formal actors. I'm not going to go through this, but this is a 3-part project. The first part is on quantitative data. Then we are using FDGs and SSIs to figure out what is happening in Myanmar. Basically, what are their health access in Myanmar, what kind of access they have while transiting, and what is the access they have in their host countries, host communities. That's it. I'm going to keep it short. I hope it was short. And yeah, thank you.
Thank you, Shweta. We know that we rushed you through it, so hope we have an opportunity at least for one question as we go. I'm going to invite Rishika Deshmukh, who is a Master of Public Health with specialization in humanitarian relief and international security from OP Jindal University. And what she's going to talk about is the impact of protracted conflict, and her location of her study is Kashmir. She's looking at women's mental health during pregnancy and identify coping mechanisms using a socio-ecological model. Over to you, Rishika.
Thank you. I hope I'm audible. So this is my master's thesis that I'm going to present today. Without further ado, let's dive directly into the topic.
So this is the outline of the presentation. Let's start with the context. Women die during and following pregnancy and childbirth during 2020 year. The number was 287,000. Very common causes of maternal mortality is excessive blood loss, infection, high blood pressure, unsafe abortion, obstructed labor with chronic conditions such as hypertension. Pregnant women suffering from anxiety face higher risks and higher risks of gestational hypertension like preeclampsia and eclampsia, indicating a strong link between mental health and pregnancy complications. Hence, maternal mental health is a global public health concern. Despite India's reproductive, maternal, neonatal, child, and adolescent health program and the National Health Program, mental health program, have not effectively addressed maternal mental health. India's National Mental Health Policy, launched in 2014, aims to destigmatize mental health issues, but it certainly leaves out perinatal area. This gap is even more pronounced in conflict-affected areas like Kashmir, where a prolonged conflict since 1947 and beyond it, even before it, has severely impacted the mental well-being of population, particularly women. Studies in Kashmir reveal high levels of depression, even calls it mental health epidemic. Anxiety and PTSD among general population, with women disproportionately being affected. Women in conflict zone often suffer in silence due to social stigma and lack of access to appropriate care, further complicating their health outcomes. So my research questions were how Kashmiri women's maternal mental health is impacted by conflict. What are the coping mechanisms deployed by conflict-affected women? The methodology is very simple. I interviewed them on telephone. The age group was 21 to 65. So these are women who delivered during the conflict. I called them and they responded accordingly with great enthusiasm. This is the interview guide. I'm not going to dwell into it further. Let's just really go with the shortage of time. The framework is socio-ecological model that's been used with intersectionality added onto it. This is the basic demographic of the participants. And you can see they range from extremely educated to illiterate. And then there are children that they're managing, and almost covers the area of Kashmir, northern, southern, and central. And there are 4 widows. So findings of my study were mental health and psychological support. First of them. So the pervasive feelings of powerlessness, high levels of stress, anxiety, depression, and suicidal thoughts among widows and pregnant women reveal a severe gap in mental health support. Meher, for example, says this after she has wiped her tears. She says, खामोश होकर मैं सब बातें सुन रही हूँ और देख रही हूँ, ना मैं कुछ कर सकती हूँ, ना किसी को कुछ बोल सकती हूँ, ना किसी के खिलाफ कुछ आवाज भी उठा सकती हूँ, किसी के बारे में कुछ बात नहीं बोल सकती. I'm quietly listening to everyone speak, and I'm also watching everything. I can't do anything, nor can I say anything to anyone. Neither can I raise my voice against anyone, and I can't even tell anyone about anyone. She cried more and said, my eyes are burning from crying so much, but I have nothing left except tears. The powerlessness in her voice was very much evident. Second came out as economic support and financial stability. Widows becoming the sole breadwinners and facing economic hardships underscores the lack of adequate financial support and employment opportunities. For example, I'll again take Meher's example because she is the sole breadwinner. Her grandma is also dependent on her, and her children are also dependent on her. And she was a very recent widow. And since they lost the father, the kids got into depression, and a lot of stuff was going on, and the medicinal expenses, everything just fall onto her. And the SRO job that she got only paid her 29,000. Healthcare access and quality. Delays in medical checkups and inadequate healthcare services during curfews highlight the critical need for improving healthcare accessibility and quality. In spite of curfew cards, passage cards being installed to the pregnant women and for healthcare checkups, yet these delays happened. Fatima, for example, after her husband died, there used to be curfews. वो time encounter का दौर चल रहा था. That time was when the encounters were at the maximum. Couldn't get vehicle. There was no old person at home since I was living at my brother's house.
So me and my children were alone. We couldn't even go to my parents' house. I used to go for checkups during my first pregnancy after 2-3 months. Then during my last child, I started going after 1 to 1.5 months. That too because of Sakti, which is curfew. Social support and stigma. The stigma and social norms restricting women's employment and autonomy emphasize the need for societal change and greater acceptance of women's role as active economic participants. So, Fatima was a Kashmiri speaker. Her daughter was translating, and she sort of told her narrative while she was trying to go out and earn because of the financial unavailability at her home. So, this is what came back to her was the community feedback that was people are going to make sort of stuff if she goes out earning, and that would have been impossible for her to earn. So she stopped. Policy and institutional support. The insufficiency of relief measures, pensions, and employment benefits for widows indicates a significant policy gap. For example, Afreen mentions about RGF, returned guarantee funds. We get RGF, which is 8,000 rupees per month. This comes in our account. Whereas Meher argues that no pension is given at all for SROs. They don't even get pensions. Role of Asha in Anganwadi was very much visible as there were very contrasting views about it. Whereas, like Faiza says that Asha in my area was namesake. They didn't give us reminders for immunization or checkups. They just fill their cards in case of interview. In cases of illiteracy, women need Asha workers, and their role becomes very prevalent. Whereas if you see Najma's statement, she says that Ashas were really helping. So there are varied roles that Asha plays at places where they were. Impact of conflict on children. Meher, again, a very recent widow, her husband died and her kids went into depression, and that was a really, really depressive phase for the whole family without a male support. She became the only breadwinner in the house. Not just that, but one participant that I am not mentioning here, and she ends up saying something about how she used to be very much terrified when curfews used to happen and she couldn't sleep all night while she was pregnant, and yet she had hypertension. She developed hypertension. So the remedy that comes out would be explained in the further slide. But what she sees is that when she delivered her baby, she says that her child is very much, she says it's OCD, but the fact that she's able to recognize it is also something, because she says that he keeps washing his hands, he keeps fidgeting his books, he's so underconfident, and she blames it all on herself because what she went through during conflict, her hypertension, caused that to her child. Coping mechanisms to stress release. One of the strongest one that came up was praying and spiritual practices. Preeti, who was a Kashmiri Pandit, said that I used to pray a lot as that's the last resort. Faiza, they used to listen to Zakir Nair's speeches and offer prayers. Family support and behavioral distraction was one of the things that was observed. Indulging in work helped Najma. Home remedies in case of Faiza were when she was very hypertensive and she wasn't able to sleep for longer hours. What her father did was he used to take water from the pond in front of her house, which was really cold, and put some pine leaves in it, and then used to dip her feet in it, which helped her sleep for 3 to 4 hours. Now, if you Google about pine leaves and their effects, it's a stress reliever. So that was one home remedy that came out. Conclusion, I think there needs to be a holistic approach towards maternal care, not that you separate everything and send women to different institutes, rather than put them all together in one. Ensuring healthcare access during conflicts, training healthcare practitioners in mental health, strengthening community-based support networks, economic assistance for widows, routine health, mental health screening, and comprehensive care. Thank you.
Thank you, Rishika. You bring another aspect into the human cost of the conflict, which is intergenerational trauma or the impact the conflict can leave on generations to come.
I know that this is the last panel. I know all of you are exhausted with a very long day, but I would like to do justice with this panel. So I would really request if there are any questions, please raise your hands. Yes, please. If you could take the mic. If you could briefly introduce yourself and who the question is for.
To Siddharth Tara, I'm chairperson of Progressive Medicos and Scientists Forum. We are mostly a policy think tank, but we also organize health camps, relief camps for protest, and also for displaced people in conflicts and all. So last year we had, after the religious ethnic violence in Manipur, few of the refugees, they came to Delhi, and their locations were kept secret so that tribes of the opposing tribes, they do not get access to their Delhi addresses and target them. So we had to very secretly go to help them, other different tribes. So as doctors, we are like, we don't have any, we don't pick a side, we serve them all. So there was a lot of mistrust among the displaced people, because they, as far as the governments, both state and central, they were concerned, they were all complicit in their fate, according to the victims. So they did not want to trust the Delhi hospitals or any central or state government hospitals. They wanted health services there itself, in the churches they were there. So when it comes to acute injuries and acute illnesses which are seen with displaced people in camps, like diarrhea or musculoskeletal problems, we took care of that. It was not a big issue. The main problem with what we faced with these displaced people was the sheer volume of emotional trauma and the psychotherapy that they needed. But again, the problem happened is the language barrier was there. It was hard to. Northeast is a very linguistically diverse place, and to find a qualified psychotherapist in Delhi was our main challenge. And also because these locations were very secretive, we couldn't advertise in papers or even in our groups. So that was the main problem. And when it comes to normal illnesses like diarrhea or something, so we can ask one person who can interpret others, but not any. But nobody will agree to like a whole group, because when it comes to psychotherapy, they have to express their vulnerabilities, insecurities, anxieties. So nobody will want to express. Well, one person cannot have access to these things, so very personal things of all the people in that group. So that was the challenge we faced. How can Doctors Without Borders help in those situations? And are there any guidelines? How should we deal with that?
Okay, I didn't know that it was a question for me and not for my fellow panelist. Maybe I will come to your question, but I would actually ask Shweta to reflect a bit more on the ethical considerations of the vulnerability, language issues, and everything. So if you could talk a bit more about that.
So this is a funded project by Accept. So what we did is the whole idea is localization, right? We are just the data analyst, and I'm an assistant professor of politics. Okay, I'm not related with the medical public health services at all. The data that has been collected are by our partners on ground. We have an organization called Next, which goes back to your question. Yeah, while we were surveying, there were considerable, significant amount of stress that we can see that the refugees are going through, IDPs are going through, right? And we have a system in place, but it's very informal. It's by the Nest organization. They have their own people on ground, and they are providing healthcare, not healthcare services, psychological services. But this is again very informal. So if you want to, I can put you in touch with them. That will help you, because again, the response should be contextualized and localized, right? So which goes back to the ethical consideration, right? That how we as an outsider can do something about it. Um, I think this is where MSF comes in.
Okay. The concept of overall well-being is something that MSF very early on realized that if you want to look at holistic health, you cannot ignore the psychosocial aspect of it. And the turning point in the organization was Rwanda genocide. Because when we would see in our clinics, in our OPDs, lots of patients manifesting psychosocial somatic symptoms, and our physicians feeling helpless to see what to offer to them. So there was a point in time where we started slowly building a learning base and repository and expertise on psychosocial care. So over the last 30 years, this has been something that has been an integral part of our programming. So the project in Manipur does have a psychosocial component. So when it comes to, we fully are cognizant of the fact that there would be always challenges of how we would look at supporting all those individuals who have been impacted. So the solutions are local. We look at a more solution-oriented approach. Our primary, I would say, objective in such cases is to keep people functional, because when people stay functional, there is hope to come back. So, of course, I can give you more details, but in just in time, we have just 1 minute left. I would just look around the room to see if there is any other question. If no, then I would really like to thank the panelists, 3 young women who have presented different sides of the project. Thank you very much. And while I have the mic with me, I'm going to abuse it for 30 seconds. Bhargavi, please forgive me for that. I would really like to actually welcome Petros, Dr. Petros at the back. Please stand up. He was our MC for the day. He had an adventure entering India, unfortunately, so we're still figuring out a way for that. But Petros has been pivotal in being part of the editorial committee to curate the day. And thank you, Bhargavi, for stepping in between. Thank you very much. Over to you.
Yes.
Dr. Sujata, over to you.
Good evening. Distinguished guests, delegates, colleagues, and friends, it is my proud privilege and honor to be including the proceedings of MSF Asia Scientific Days 2024. During this momentous event, we have embarked on a journey, a scientific and academic journey of mutual learning, insightful discussions, and sharing of diverse perspectives and experiences. The spirit of innovation and the quest for knowledge are the driving forces behind scientific discovery, as quoted by Ellen Orker. We have witnessed the showcasing of novel innovations in diagnostics, treatment, and healthcare delivery, from rapid diagnostic point-of-care testing for oral cancer to AI-driven surveillance systems for TB screening, the utilization of mobile applications and digital platforms for early assessment of mental health, and the development of biodegradable PPE and anti-AMR surgical solution supplies are some of them. These fascinating inventions have the potential to advance access to affordable healthcare even in remote areas. It also provides us an opportunity to consider future collaborations and implementation of these innovations in our institutes and in the field. We also experienced an animated and extremely relevant panel discussion on AMR. Antimicrobial resistance is no longer an imminent threat, but a clear and present danger to global health. This is a complex and ever-evolving challenge, particularly in regions where resources are limited and access to appropriate treatment is constrained. We discuss the problem of excess versus access. And in order to combat this crisis, we need to strengthen surveillance, increase reporting of AMR-related deaths, develop new, probably more effective antimicrobials, and implement appropriate and effective antibiotic stewardship policies. Effective infection control and prevention strategies, such as the WASH strategy, is also imperative. Coordinated and collaborative action across sectors, including governments, NGOs, research institutions, and engagement of local communities, can prove vital in tackling the perils of AMR. The focus must remain, however, on developing sustainable solutions that are scalable across diverse healthcare settings, reaching even the most marginalized populations. In closing, I would like to thank our dynamic leaders, Dr. Ajay Shukla, Director, AB WIMS RML Hospital, Dr. Farhat Manto, Executive Director, MSF South Asia. I extend my deepest gratitude to all our speakers, panelists, delegates, researchers, editorial committee members, and participants. Your invaluable expertise and insights have not only enriched our discussions, but have inspired us all. I express my heartfelt appreciation to the entire organizing team of MSF South Asia office, whose unwavering dedication and hard work have been the pillars of this event's success. Their meticulous planning and seamless execution have been nothing but exemplary. This forum has provided a golden opportunity for continuing future collaborations, fostering relationships, and embracing new ways of thinking in the pursuit of excellence and advancement in healthcare of the region. We endeavor to promote and advocate for equitable access for health for all, which as definition is not a mere absence of a disease, but a state of complete physical, mental, and social well-being. We move forward with the hope of applying this wisdom we have gained for the benefit of all humankind. For what is science without humanity? As Louis Pasteur once said, science knows no country because knowledge belongs to humanity and is the torch which illuminates the world. Empowered with this wisdom, we strive to shape a better future for ourselves and our children. Thank you so much for your participation, and let's stay connected.
Thank you so much, Dr. Matthews. Those were really, really inspiring words. I'm going to connect right now to Radha Kamisi, who is the director of the Programs Unit South Asia, who unfortunately couldn't be here in person today, but is going to join us online.
Good afternoon, everyone. Do you hear me? Yes. Bhargavi, do you hear me?
We can hear you.
Thank you. Good afternoon, everyone. My name is Radha, and I serve as the Director of Programs for MSF South Asia. My background is rooted in MSF's humanitarian action, with experience across diverse contexts, from Haiti to Afghanistan, where I have witnessed firsthand the significant barriers to healthcare that marginalized communities endure. Although, as Bhargavi just shared, I regret not being able to join you in person today. The depth and engagement of the panels have made me feel as I were right there in the room with you. So thank you for that. We began the day with a powerful keynote from Dr. Kalkonde, who reminded us that science must always serve the most marginalized. His personal journey from the US to rural Gadchiroli in India, where he led efforts to serve tribal and rural communities, was both inspiring and humbling. In the first part of the day, we explored how community-led action and advocacy can drive health reform and foster equitable health outcomes. Anisha's work on crowdsourcing TB stories showed how technology empowers communities to reduce TB stigma through personal stories, while the Unite to ACT project highlighted the impact of training TB survivors to support others improving treatment outcomes. The midwifery-led model in rural Jharkhand demonstrated that community involvement is in childbirth care with minimal medical intervention led to positive outcomes for women in low-resource settings. Then MSF's capacity building approach with community-based organizations also showed how sustainable healthcare continues as part of MSF's exit strategy in some places like Malawi or India. Another critical issue we discussed today is the impact of the climate crisis on health, as highlighted by Shweta Narayan. We are witnessing an escalation in climate-related disasters, floods, droughts, wildfires, and heat waves that affect marginalized communities. Shweta has urged us to take a stand as advocates for climate change. This talk was a sobering reminder that the health community must lead by example in this fight. Then in the afternoon, we delved into the health inequities and structural violence faced by marginalized communities. Dr. Fernandez's research on NCDs among the transgender population in Kerala highlighted the critical need to dismantle systemic barriers that these communities face on a daily basis, beyond treating illness. This theme was echoed in the experiences of the Hijra community in Bangladesh, where social discrimination hinders access to education, employment, and healthcare. Additionally, the struggles faced by transgender communities during the COVID-19 pandemic highlighted the urgent needs for trans-affirmative healthcare, particularly in times of crisis. And adding another layer to our understanding about inequities, Sankalpa's study from Odisha examined violence in the lives of women with disabilities. It calls for awareness-raising programs to address attitude barriers and advocates for a more inclusive approach to social and healthcare support. So together, these presentations compel us not only to listen, but to act, ensuring that our healthcare systems become truly inclusive and equitable. And finally, in the last session of the day, we were confronted with the devastating human cost of violence and conflict. Exploring the regions of Assam, Manipur, Mizoram, and Kashmir, research showed how years of conflict have eroded healthcare systems, leaving marginalized communities, particularly women and children, vulnerable to poor healthcare outcomes. The studies also shed light on the complex interplay between conflict, gender roles, and mental health. These presentations reaffirm that war and conflict do not just destroy health infrastructure, they shatter lives, hopes, and futures. We are reminded of this tragic reality every day in places like Sudan, Haiti, Myanmar, Yemen, Palestine, and other affected countries and regions. Today's discussions have made it clear that while short-term solutions and emergency responses are vital, it goes side by side with sustainable strategies that address the root causes of health inequities and the human cost of conflict. So, as we conclude today's MSF Asia Scientific Days, I would like to take a moment to express my gratitude to those who made today possible. I want to thank all the speakers, presenters, and participants for their invaluable contributions. Your research and on-the-ground experiences have shed the light on some of the most pressing issues in global health today. I would like to express our deep appreciation to our partner, RML Hospital, particularly Dr. Shukla and Dr. Sujata, for their unwavering support and collaboration in making this event a success. Their partnership has been instrumental in contributing valuable expertise and fostering an environment of knowledge exchange and experience sharing today. I would like also to deeply thank our editorial committee of MSF Asia Scientific Days for 2024. And a special thanks goes to the MSF organizing team and today's chair, Bhargavi. Bhargavi, who stepped in at the last minute and has done an incredible job, all while managing her responsibilities with her toddler. Your dedication and adaptability have been truly remarkable today, and we deeply appreciate your efforts in ensuring the day runs smoothly. Dr. Shevanti Ghosh, MSF's medical strategic lead, has been the driving force behind this event. And maybe if the team, you can stand up while I thank the team members. I think it will be very important that people see who you are. So Shevanti's leadership and commitment have shaped today's discussions, making this platform impactful and cohesive. Alongside her, Noshin Zaidis, MSF's public health researcher, has played a key role in coordinating these efforts. Noshin, your dedication to MSF over the past years has been exemplary. The communications team, represented by Neha Saluja, has provided impeccable support. Thank you for your continuous and dedication and creative contributions. I'd also like to thank all the other members of the comms team for their invaluable work in making it seamless for everyone following the discussions behind the screen, like me today. Thomas, MSF's logistic officer, has been essential in ensuring that you are present with us today, especially those who do not live in Delhi. He managed to bring you to the venue, to find a place for you to sleep in Delhi. So a huge thank to our logistics, admin, and finance colleagues for their tremendous support behind the scenes. Additionally, I would like to extend our gratitude to the talented artist Indrajit Sinha, who enriched this event with vibrant and creative live art experiences. I really enjoyed seeing pictures of your work today. Thank you. Finally, I would like to thank the India Habitat Center for hosting the event. Thank you all once again for contributing to this event. Let's leave here with renewed energy and commitment to making healthcare accessible for all, no matter their gender, identity, or the conflict they endure. I wish everyone a wonderful end of the day and a safe journey back home. Thank you so much.
Thank you, everyone. We look forward to seeing you back here in a year's time, if not in London, in May 2025 for our other scientific days. And if anyone is interested in research in MSF, I encourage you to look up the London Calling MSF to understand a little bit more about its place in our organization. If anyone is interested in working with MSF, I encourage you to come and see Farhat or one of her team to see what the opportunities are for working with our organization. Once again, thank you so much for coming and look forward to seeing you once more.